strategies, how can we intensify the treatment to maximize the cure and to minimize the toxicities. And one of the protocol to get the highest disease control was the escalated BrECADD by the German group. Volker Deal and his group also at that time compared the escalated BrECADD, which they added etoposide to 100 milligram daily, as well as the cyclo increased from to 1,250. The doxorubicin was given at a 35 milligram. So beside the procarbazine as well as the bleomycin. So as you would expect, you will get a more control for the disease. However, that was on the other hand, a long-term toxicities, especially the AML and MDS initially when compared to the COPP ABVD. Other strategies, and this is the 10 years follow-up. You can see the number of the cancers or secondary cancers was higher with the escalated BrECADD compared to the baseline BrECADD or ABVD. So other strategies to how can we also intensify the treatment and then either escalate or de-escalate, that will give us a good disease control and will minimize the toxicities. And one of these studies was the RATHL trial published by Zinzani. 2 arms, but the most important one was the PIT negative arm, those who received 2 cycles of ABVD. PIT was done, and those who had a PIT negative randomized to AVD, so omitting the bleomycin, or the standard ABVD for 4 cycles. PIT positive, 4 cycles of the escalated BrECADD. The study was a non-inferiority at the beginning. And you can see there was no differences in those patients achieved a PIT negative. So AVD was comparable and non-inferior to the ABVD after 2 cycles of ABVD with the PIT negative, both into the overall survival and progression-free survival. This is the 7 years follow-up. So at 7 years, the rate of control, the disease, for those who received ABVD or AVD after a PIT negative was almost like 81%. And if you compare that to the ABVD and that study with the MOB, so increased from a 70% to 81%. So there is incremental also with minimizing the toxicity, especially from the bleomycin. The same for the overall survival. This is also for those who had a PIT negative. When they escalated to the escalated BrECADD, they achieved about a 79% disease control. And this is compared to the historical data considered to be a higher, especially for those with the PIT negative. So the second one was the HD18 trial. The German protocol also, they randomized the patient to the standard of care, which is the 6 cycles of escalated BrECADD, or those who received 2 cycles of escalated BrECADD and then randomized to 4 more cycles or 2 cycles. So the strategy here is to minimize the number of escalated BrECADD after a PIT negative data. And that was also a great outcome if you see the 4 cycles escalated BrECADD, which is almost like a 12 weeks of treatment, 3 months. That's the half of the treatment, compared to the 6 escalated BrECADD, almost comparable with the disease control. And you notice here that the disease control increased from 81 with the AVD and ABVD to 91. So this is one of the also highest disease control. But still, in those patients, the acute toxicities, either with the hematological infertility, as well as the long-term toxicities with the secondary malignancies, were not eliminated because still the certain agents, especially, for example, the cyclophosphamide or etoposide for the infertilities, the higher doses, as well as the procarbazine for the second malignancies. Another study also by Casanova, and that phase 3 HL started again with the 2 cycles of escalated BrECADD, and then randomized after a PIT negative to ABVD, so 2 cycles then ABVD. So it was not 2 cycles to 2 cycles of escalated. Now they are changing to another protocol, or if it's positive, they continued the same treatment, escalated BrCAD. The results also was progression-free survival at 4 years, 86%, so increased into the progression-free survival. As you will notice, no differences will be seen into the overall survival because we have the same salvage for those patients who will progress and on treatment. However, the problem with the escalated or de-escalated, especially with the escalated BrCAD, is that majority of the hematological toxicity are in the 2 first cycle. So you cannot also avoid the hematological toxicities by that strategy. Autologous stem cell transplant, this is all the study in 2002. Those who achieved the CR after ABVD, they put them into the autologous stem cell transplant versus the conventional chemotherapy to see if initial consolidation with high dose chemotherapy followed by autologous stem cell transplant will cure, and there was no differences. This is how the progress into the management of Hodgkin lymphoma over years. That's a SEER data. You can see there is overall survival improvement from 78.5 over years to 81. So almost like a 4 to 5% improvement in overall survival. That was due to the use of the PIT-adapted therapy, the early detection of the residual disease with the PIT, also the strategies of the chemotherapy, as well as the improvement into the autologous stem transplant. And after that, the Brentuximab, as you know, was tested initially into the relapsed refractory setting by Anasionis, and it showed a remarkable response for those who progressed after stem cell transplant. It was tested into the first line into the Echelon study, where 6 cycles of Brentuximab AVD compared to 6 cycles ABVD in stage 3 and 4 advanced classical Hodgkin lymphoma. The initial outcome was the modified progression-free survival. And this is the 6 years follow-up where the Brentuximab plus AVD compared to ABVD showed a superiority by about 6 to 7% compared to the ABVD. And for the first time, we see overall survival benefit in a phase 3 study in advanced Hodgkin lymphoma, where the Brentuximab plus AVD was superior by about 3 to 4% overall survival, absolute benefit in overall survival. This is the subgroup analysis. It was more evident in those who younger patients, less than 60, advanced stage, high IPI. And the Brentuximab at that time was one of the standard of care since 2018 after the Echelon-1 study. The problem again with the Brentuximab was the toxicity, especially the risk of febrile neutropenia, where the G-CSF was not mandatory at the beginning, and later on it was a mandatory. So the risk of febrile neutropenia reduced from 20% to 11%. Peripheral neuropathy was the main also side effect, and 11% compared to 2% into the ABVD group, and was more also pronounced in those patients, elderly patients. One of the concerns also in a young patient is the fertility, and the Brentuximab AVD. This is the data that majority of the patient into the childbearing had the same, similar to the ABVD, so it was not affecting the fertility issue. In the last year also, we had the 2 protocols now. We have the HD21 and the SWOG, and that's the maybe the updated into the data. So HD1, you remember the escalated BrCAD protocol. Now they are testing the escalated BrCAD to something they call it BrECADD. So Brentuximab, Cyclo, as well as the dacarbazine, and I will show you the differences between them. But HD21 was a randomized study, phase 3, non-blind, giving a patient 2 cycles of either escalated BrCAD or 2 cycles of BrECADD, and then if a PIT negative, they will proceed with 2 more cycles of BrECADD or positive 4 cycles. So it's like a 2-by-2 design. Those who had escalated BrCOP 2 cycles, PIT negative 2 cycles, escalated BrCOP positive 4 cycles. It was initially non-inferiority, so BrECADD is not inferior to the escalated BrCOP. And later on, the study design, when at the second interim analysis, was changed to superiority. This is the differences between the escalated and the BrECADD. So bleomycin, nothing, and into the BrECADD, the etoposide from 200 to 150, doxorubicin was increased to a 40, cyclophosphamide, the same dose, no vincristine into the BrECADD, brentuximab was added and still of the vincristine. Prednisone was changed to dexamethasone, and dacarbazine changed to procarbazine to dacarbazine to minimize the risk of the second cancer. This is the study design. As you can see, the BrECADD was, as mentioned, non-inferiority study. However, it showed superiority to the escalated BrCOP, and those who achieved a bit negative either received 2 cycles or 4 cycles, and no differences into the overall survival. The risk of the AML was less than 1%, almost negligible compared to the other thing. The only thing in that study was the PIT negativity up to 64. If you compare that to the other studies into the escalation or de-escalation, this is considered to be lower because PIT negativity almost like 80 to 85% after 2 cycles of ABVD, or into the Echelon study after the brentuximab ABD, and no good explanation for that. The same score was 1, 2, 3 negative. However, you can see that the progression-free survival, now we are achieving like a 94%. So from a 70 with the ABVD, now 94 with the 4 cycles of BrECADD, which mean like a 3 months of treatment instead of 6 months, especially in those with the PIT negativity. This is just to show also the fertility was not an issue with the BrECADD, according to the study after 48 months of the follow-up. Then the SWOG study also introduced the Nivolumab ABD compared to the Brentuximab ABD in stage 3 and 4. It showed superiority of the Nivolumab. You can see this is the baseline. There was no differences between the 2 groups. However, Nivolumab into the intention to treat, because the study included from 12 years to more than 60. And when if you take the whole study, it showed that superiority to the Nivolumab with about 92% compared to the 89 with the Brentuximab ABD. That also was into the subgroup analysis. You can see the age group between 18 to 60, almost the close to 1, the confidence interval, but the 12 to 17 and more than 60, the effect was in favor of the Nivolumab ABD compared to the Brentuximab. If you do subgroup analysis, again, in patients more than 60 compared to 18 to 60 years, also those elderly patients tolerated the treatment, and that's because more patient into the elderly group discontinued the Brentuximab because of the toxicities with either neutropenia or peripheral neuropathy. No change into the overall survival. The only concern was about autoimmune side effects with the Nivo ABD. If you see just into the lower slide here, the rate of the hypo and hypothyroidism was grade 1 and 2, so no grade 3 and 4, and about 2.7 hypo and 7% with the hyperthyroidism. The rate of discontinuation with the Brentuximab was higher compared to the Nivo, almost double, 22 versus 11%. This is the autoimmune phenomena. You can see majority are grade 1 and 2, so no grade 3 with the Nivo. So it was a very well tolerated, honestly, protocol compared to the Brentuximab ABD. The only concern at that time was a short follow-up, almost published at 12 months. Causes of death, we don't see any secondary cancer. The fertility, this is very important slide, because if you want to calculate the doses, for example, into the cardiac dysfunction with the BrECADD 4 cycles, a maximum of 160 milligram compared to 6 cycles of ABVD. If you give 6 cycles of BrECADD, the maximum will be 240, so still lower than what you would see with the ABVD. Also, the risk of fertility was cumulative doses. That's into the cyclo and etoposide, 6 cycles compared to 4 cycles, decreased from 7,500 cyclo to 5,000 and to 7,700 milligram per square meter to 1,800. Only concern is the dexamethasone in a higher doses, weight gain, as well as the osteoporosis and the immune related effect with the Nivo. So if you compare, and this is just only a quick, if you see the SWOG protocol, they included the 12 years. That's something good, was not into the other studies, and elderly patient. The only excellent outcome into the terms of progression overall survival. The only concern is a short follow-up, 12 months, and they reported the 2 years now. It's because a durability of the response with the Nivo, with that sustained, with that maintained, and that's the whole point. And most of the I think centers in North America adapted this protocol of the Nivo AVD. With the HD21, they did not include an elderly patient like 60, so up to less than 60 years. They included the stage 2B, which was not into the SWOG or into the Echelon. However, the question mark about the PET negativity after 2 cycles still low compared to the other. We can see with the Brentuximab, for those who are PET negativity, 89%, 86 compared to 64. So it can be a good option if you want to shorten the treatment from 6 months to 3 months. It's a good for those who might have a contraindication to the anthracycline and a concern about the cumulative doses, especially into the young population. The Echelon, I think that was the first approved treatment compared to the ABVD, with a longer follow-up until now, 6 years, with overall survival benefit. So the conclusion over the past decade, the treatment options for classical Hodgkin lymphoma have significantly expanded. Now we have the Nivo AVD, Nivo BrECADD protocol with the Brentuximab, as well as the Brentuximab AVD. For sure, Brentuximab and checkpoint inhibitors have led to improved outcome. Further direction, which that would, I think, would help, is having novel agents combination more into the front line, advances into the imaging, not just only the standard PET scan, as well as maybe the molecular to guide the positive residual disease escalation or de-escalation after the frontline therapy. Thank you.
Thank you, Dr. Mubarak, for your excellent talk, as usual. We will open the floor for questions. Any question? Can you give the mic to Dr. Ziad? Is there a mic? Can you?
Ziad?
Maybe you can shout out.
Would you do pulmonary function test before or no? My second question is like, with this data, shall we give Nivo just for patients above 60? Keeping in mind, you know, in the German study, most of the patients are fit, marathon runners. Our biological age, usually in 50 years, is really with comorbidities. Shall I consider this age population for Nivo instead of AAVD? And the last question is with neurotoxicity with Brentuximab, what you will do? Would you hold and then restart in small dose? Because I have one patient after 3 cycles, he cannot hold a cup of water. He feels that it will fall down from his hand. Thank you.
I think very important and 3 great questions. I will start with the Nivo in elderly patient. We don't have a standard of care in elderly, as you know. It's the problem is because of the toxicity, especially the febrile neutropenia and the bleomycin with the ABVD. So one of the protocols was initially used by Andrew Evans is to give 2 sequential, for example, Brentuximab and then dose-reduced AVD and then 4 cycles of Brentuximab, that's one of them. Or to use it depends. I mean, the definition of elderly in our population, it's not just only numerical age, but I'm just listing all the options. So you have that protocol. You have also treated certain patients with dacarbazine and Brentuximab only. It went very well, but that elderly 80 years. Nivo AVD, I think one of the excellent options now with the subgroup analysis, it showed that differences. However, I think the point is not about giving the Nivo. Nivo is fine. Would you give a full dose AVD? Because still in our population, sometimes you cannot give a full dose of AVD. But yes, that's one of the things, and it depends on how fit your patient. If you're talking about more than a 60 young fit, fit without comorbidities, yes, I will give Nivo AVD. That will be one, I think, of the options nowadays. For the peripheral neuropathy, unfortunately, there is no specific medications to give. However, after 6 years of follow-up from the peripheral neuropathies, only less than 10% maybe had a residual peripheral neuropathy, 1 or 2 primarily. Sometimes you can use the pregabalin or the Lyrica just to minimize the pain. You can give the vitamin B12 or the vitamin B complex that might help, but only the time will make sure if that's going to be a permanent or resolved peripheral neuropathy. Limited stage Hodgkin lymphoma, what we have now, because we don't have yet the Nivo AVD or the Brentuximab was not BrECADD was just only stage 2B. So stage 2A limited, heavy smoker, I will do the pulmonary function test. And based on that, I would write it to maybe minimize the number of the cycles. By example, if this is a favorable stage 2B, I will give 2 cycles ABVD and proceed, for example, for radiotherapy. If fit and no pulmonary function test problem, I'll go with the adapted protocol, 2 cycles, and then PIT, negative 2 more cycles of ABVD.
Any more questions? If no question, I may ask, sorry. So if a patient had the ABVD and after 2 cycles has significant response, but still have remnant of disease, let's say 80% reduction, so still partial response, would you escalate? Would you continue and re-image, or what would you do?
Okay, that's again a very important question. If you give 2 cycles ABVD and then a PIT, still positive. I think the question you would ask yourself, why I would do a PIT scan after 2 cycles? If my goal is just to de-escalate, if negative, then 2 cycles ABVD. If negative, I will de-escalate to ABVD. If I am thinking of escalation to escalated BrCADD from the beginning, then I will escalate. But if you are trying to de-escalate and then you changed mind to escalate, because if you remember for the ABVD initially, we used to give it 4 cycles and then CT scan. And the CT scan point just to show if the patient having a partial response, you will continue. So we know into the escalation, de-escalation, we don't have either ABVD arm after the positive PIT and no Brentuximab AVD arm after the PIT positive to compare to the other escalation. So what we do is if I give 2 cycles ABVD still a positive, I continue with my protocol initially.
Would you image after 4 or?
And yeah, after 4 cycles I do, and I might do CT scan also, not just follow.
Exactly what we do. I think one more question, Dr. Amel. The mic is coming.
Thank you, Mubarak. Excellent talk as usual. With the new study of the Nivo AVD, you in National Guard usually move ahead before anybody. Do you think it will change practice? And to whom you might start changing, using Nivo instead of Brentuximab as upfront for advanced cases? Or
yeah, this is also a very important question. I think changing the practice to the Nivo AVD. If you see in general, Nivo AVD, I think excellent outcome, very well tolerated protocol compared to the others. I think, as mentioned, the problem is that short follow-up initially when presented by Alex Herrera and was published was 12 months. So everyone was questioning the durability of response with that maintained, because the checkpoint inhibitors, it works into the microenvironment, and we are giving it for 6 cycles. So sustainability of the immunotherapy over time, will that stay or not? I think with time, if a longer follow-up time showed this is something durable, I think it's a practice changing. Majority of North American, especially US, they are changed now to Nivo AVD on all the patients. I think we can consider it in a selected patient. Those patients, for example, 12 to 17, and I think the definition of the adolescent in our population is that 16 years, so maybe a good portion of patients can be used, or the elderly. Can we change it for all the patients? I think this is something possible, but it needs to be discussed with the group and the institution, and waiting for more data.
One more last question. What are you using, since you mentioned that 12 to 18 for your young population from 14? Our definition is 14 years for adult. So 14 to 18. Are you using pediatric protocol, or are you still adapting adult?
Once the patient referred to the adult oncology, we use the same protocol. We are treating the Hodgkin lymphoma either with the ABVD or Brentuximab ABVD.
Thank you, Dr. Mubarak, for the talk. We have some few modifications in our program. Our next speaker will be Dr. Ihab Al-Himadi. The talk is about management of follicular lymphoma beyond the first line. Dr. Ihab is well known, mashallah. He has hematology trained in London or at Guy's Hospital and Thomas Hospital and King's College Hospital. He is a member of Saudi Society of Bone Marrow Transplant and British Society of Hematology and the European Society of Bone Marrow Transplantation and American Society of Bone Marrow Transplantation as well. Dr. Ihab is currently working in the National Guard, Jeddah. He has more than 30 publications, and he's one of our well-known speakers. Thank you, Dr. Ihab.
Thank you, Dr. Mohammed, for the kind introduction, and thank you, SSBMT, for the invitation to talk to you today. And my talk will be on the management of follicular lymphoma beyond the first line. So to start with the incidence of follicular lymphoma, we know that it differs between different ethnic groups, and this study was done in England. And if we say Caucasians are one, you see here that South Asians and Bangladeshi Indians, their incidence is less than the Caucasians. Also, Black Africans and Chinese have a lower incidence than the Caucasians. So there is some biology there, maybe related to ethnicity or social, environmental factors. So our management for follicular lymphoma has been improving over the years, and you can see this is a Spanish study showing that over the many years, the improvement in survival of the follicular lymphoma patients and progression-free survival. However, the incidence of transformation has not changed despite the change in our therapies, as you can see here. So patients who are diagnosed with follicular lymphoma, they still don't do as well as the general population. So this dotted line is the general population in Spain, and you can see the follicular lymphoma patients, they are not doing as well as the general population. So there is a reduction in their overall survival. However, over the decades, there has been an improvement, and you can see the curves of follicular lymphoma patients coming closer to the general population with the advancements of our therapies. This is Stanford data, very similar to the Spanish data, showing the improvement along the years. And the usual median survival for a follicular lymphoma patient now is about 20 years. This is again the Stanford data, and you can see that as time passes by with the newer therapies, the survival of follicular lymphoma patients is coming closer to the general population also. So the first question is, does patients need treatment? Do relapsed follicular patients need treatment? And to answer that question, most of us use one of these criteria to treat a relapsed patient, like the British criteria for life-threatening organ involvement, B symptoms, bone marrow failure, rapidly progressing disease over a period of 3 to 6 months. The French have their own criteria, the GELF, which is used widely over the world, bulky disease, B symptoms, beta-2 microglobulin, involvement of 3 lymph nodes, and splenic enlargement and compression syndromes, and pleural peritoneal effusion. But we have to realize that all these criteria were made for clinical trials, to enroll patients into clinical trials. But in clinical practice, maybe we have to think carefully before we start treating follicular lymphoma patients. There is this study in which asymptomatic follicular lymphoma patients were given rituximab. When you compare those who did not, those who were on watch and wait, their progression-free survival is less than those who had rituximab. Also, their time to start of new treatment is less, or they're quicker than those who had rituximab. However, when you come to the overall survival, there is no difference between the two groups, those who were treated with rituximab and those who were not treated. So treating patients who do not need treatment is not necessary for relapsed follicular lymphoma patients. Who should we treat? Generally, in clinical practice, we should look at local symptoms due to progressive or bulky disease to treat a patient. If there is a compromise in the normal function of an organ, if there are B symptoms, and if there is extranodal disease outside the bone marrow, like in the lung or the liver, then we should think of treating these patients. And if there is bone marrow cytopenias, and if there is a rapid progression of the disease that you see clinically. So in the future, this study was trying to see if PET scan could give us a clue on whether we should treat patients, and they defined what is low volume disease by PET scan versus high volume disease, and they've shown that high volume disease patients are patients who are going to require therapy soon. So maybe starting therapy in patients of follicular lymphoma in the future might depend on our PET scan and calculating the tumor metabolic volume. So who has worse progression when they relapse? The POT24 patients are known to get worse when they relapse. There are data that showed us those patients who have POT24, they have high incidence of transformation. One study has shown 37% of patients with POT24 have transformation of their disease. Another study, 76% of patients have transformation of their disease. And because the treatment is very different, it's very important to identify which follicular lymphoma patients actually have progressed and transformed to diffuse large B-cell lymphoma. This is the first study to show the difference in survival and progression-free survival of those with POT24. This is another study of meta-analysis of more than 5,000 patients in 13 clinical trials, again showing that those who progress within 24 months of the end of their therapy, they do worse, regardless of the therapy, even if they had chemo, or if they had rituximab only, or if they had chemo alone, they do worse, as you can see in the curves here. So what type of induction chemotherapy that might influence survival? In the gallium study, they have did an analysis, and they have it wasn't just an exploratory analysis, and that has shown maybe patients who have obinutuzumab, there is less incidence of transformation and or progression in POT24 than those who did not have obinutuzumab. However, those who have progressed, they have a very higher incidence of mortality, 26 folds more than those who have not progressed. So obinutuzumab therapy or obinutuzumab-related therapy reduces by 34% the incidence of POT24 in follicular lymphoma patients. However, post-progression, the worst prognosis still persists in these patients. There is another analysis of using bendamustine, and this has shown that the incidence of POT24, instead of being 20%, was 9 to 12%. So maybe there is a hint those who receive bendamustine have lesser incidence of POT24 progression or early progression. So transformation risk is about, in general, in follicular lymphoma patients, about 10% in 5 years. It's about 2% per year. And what type of transformation? Patients who transform at presentation are these patients, and they do as well as those who have not transformed. So transformed patients who present you with transformation, they don't do badly. However, patients who transform after having chemotherapy, these are the patients who actually do badly. It's important to know also that there are patients who we have confirmed evidence that they have transformed by biopsy, and there are patients who we suspect that they might have transformed, but when we do biopsy, their biopsy still shows that they have follicular lymphoma, but you clinically think they have transformed. And these patients, they do exactly the same. So the patients you suspect they've transformed, they do as badly as those patients who you prove they have transformed, as you can see here in these two graphs. So who are these patients whom we suspect they have transformed? They are patients who have rapid progression of lymphadenopathy. They are patients with extranodal disease outside the bone marrow. There are patients who develop B symptoms, and there are patients who have very high, rapidly rising LDH and hypercalcemia, and it is mandatory in these patients to do a lymph node biopsy because your therapy is going to change if you prove they're transformed or if you suspect they're transformed. This is another study by the Mayo Clinic, again showing that those who've transformed more than 18 months since end of therapy, they do worse than those who transformed before 18 months of end of therapy. Those who have transformation at diagnosis and they receive R-CHOP, they do as well as any diffuse large B-cell lymphoma patient. However, if patient transform after having R-CHOP chemotherapy, they do badly, as you can see here. And you can see in this graph here that patients who transformed at presentation, they do as well as a diffuse large B-cell lymphoma presenting to you in the clinic. The number of relapses will lead to worsening progression-free survival. As you can see here in this US data, the more therapies the patient receives, the less the survival is. So the summary of the slides, POD24 occurs in about 20% of patients. Unconfirmed reports that obinutuzumab reduces the incidence of POD24, and 50% of POD24 patients have transformed diffuse large B-cell lymphoma. And POD24 patients are unmet need. They do badly regardless of the therapies we have currently. Transformation to follicular lymphoma occurs in about 10% in 5 years, and transformed disease diagnosis is not a poor risk sign. But however, transformation after R-CHOP chemotherapy is a bad sign. So newer strategies for treating a relapsed disease, we have lenalidomide-based therapy, we have CAR T-cell therapy and bispecific antibodies and BTK inhibitors and EZH2 inhibitors. So the first trial is using rituximab lenalidomide in patients who had 1 line or more. They relapsed after 1 line or more. So rituximab versus rituximab only. And this study has shown that many of these patients actually had 3 lines or more, 25% of the patients. Those who are less than 2 years, so the POD24 in this study were half the patients. So these are the patients who actually do badly, as we have discussed. And you have seen here the lenalidomide rituximab has done better in terms of progression-free survival compared to rituximab, with an incidence of progression-free survival about 28 months. And there is a hint that there might be an overall survival benefit in this follow-up study. All groups do better with lenalidomide rituximab. And as you can see here, the marginal zone lymphoma patients who were there in this study actually might not have benefited, although the numbers are small. So this AUGMENT study, CR rates are 34 compared to 18. The secondary malignancies, which we fear with lenalidomide, were not increased. And the venous thrombosis, again, which we fear with lenalidomide, was not increased in this study. As you can see, the side effect profile when you compare the two strategies are very similar. So in conclusion, it improves CR rates and progression-free survival. However, there are more patients who had progression using rituximab only. More patients with R2 discontinued because of side effects, so 8% versus 4%. So maybe there is a hint of toxicity there. CAR T-cell, we have 3 products in the market, the axi-cell, the T-cell, and the lyso-cell. The difference between them is lies in the hinge area. So you can see the hinge area of the antibody is different between the different antibodies. The transmembrane region, again, there is difference between the 3 different antibodies. And the most important is the co-stimulatory domain is different. And the CD28, which is in the axi-cell, leads the CAR T-cell to have a rapid expansion, but shorter durability, while the lyso-cell and T-cell, they have the 4-1BB co-stimulatory module, which make it slower expansion, but longer durability in the human body. So which strategy will win? We don't know yet. We don't have long-term follow-up. There is an update. Axi-cell has the longest follow-up, and you can see in this study the progression-free survival of those patients with follicular lymphoma at 3 years is about 54%. So the overall survival at 36 months, which is 3 years follow-up, was about 76%. The progression due to death or competing reasons were acceptable between the groups. There is a message here, very important message about the bendamustine, which we might make us think what is our strategy should be in our follicular lymphoma patients. So those patients who had bendamustine within the last 6 months from the CAR T-cell, you can see their curve, they did really badly. Those who had 6 months to 12 months, their survival, progression-free survival was slightly better. Those who had ever had bendamustine, again, they didn't do as well as those who never had bendamustine. So you can see the difference in the curves depending on which time, when they had bendamustine. So this is something we should think about. So the grade 3 toxicity from CRS was about 6%. Use of tocilizumab and corticosteroids, because this CAR T-cell leads to rapid expansion, the toxicity from CRS and ICANS is higher than the others. Progression-free survival, this is a study using PET scan, and this study it was in the 3 centers, and they defined that those patients who have a tumor volume of 510 centimeter cube usually do worse than those patients who have less. So these patients here are patients who have 510 centimeters or more. Their progression-free survival is worse than those who have less disease. So how do we benefit from this? In this study in the CAR T-cell, they divided, they had a median volume for the tumor, and those who have lower tumor medium, they did better. As you can see here, these are the Q2 and Q1 are patients who have smaller, less tumor volume. They do better than those who have higher tumor volume. And the progression-free survival of those with lower tumor volume was 71% versus 37% for those with higher tumor volume. So tumor volume tend to have an effect. We talked about the CRS, the ICANS. 15% had grade 3, so higher incidence of ICANS in this CAR T-cell. The lyso-cell, we will concentrate on this group because this was published recently. This is the high-risk follicular lymphoma patients, the POT24 that we talked about. We don't know what to do for these patients, and they have looked at this group of patients in this trial, 2 lines, and then they progressed, and they are considered high risk, and they had the lyso-cell CAR T-cell. So how about the patient characteristics? You can see here the POT24, 65% of the patients had a POT24, so high-risk group of patients. And you can see here the CR rates of this group of patients is equivalent to the other group of patients who were considered as low risk. So treating them with CAR T-cell made their prognosis similar to the other follicular lymphoma patient in terms of CR rates. How about their progression-free survival? Their progression-free survival is similar to what you see in the other groups. As you can see here, the orange curve is similar to the other curves. Overall survival, again, is similar. The progression-free survival at 1 year is 91%, so the follow-up is still very short to make major conclusions from this study, but it's very interesting. CRS rates, as you can see here, 0 grade 3 and 1% grade 3 in the 3 lines or more. The infections, again, not major infections, and toxicity and death was minimal. T-cell, no update, but these are their curves. As you can see, some response. So to summarize the 3 CAR T cells, the CR rates between the 3, we have higher CR rates with axi-cell and longer follow-up, 94% with liso-cell, but the follow-up is short. The progression-free survival is 54% in the axi-cell, 57% at 2 years for the T-cell, and 80% for 1 year in the liso-cell. The toxicity, higher toxicities with the axi-cell compared to the liso-cell and the T-cell. So the bispecific antibodies, mosunetuzumab is a CD20, CD3 bispecific antibody used for relapsed follicular lymphoma, 2 lines or more. So same area as CAR T-cell therapy. And the characteristics of the group, there are 3% of the patients had CAR T-cell, about 21% of the patients had autologous transplant in this study, so heavily treated patients, and any prior CD20 and alkylator double refractory patients were 50% of these patients, because one might think this works against CD20. If they are refractory to CD20 rituximab or mosunetuzumab, this antibody might not work. However, half of the patients had refractory to CD20 therapy. Those who are POD24, half of the patients. So again, heavily pretreated patients, CR rate 60%. So a bit less than what you see in CAR T-cell, but it's reasonable, decent. And the double refractory, it's about 50% of the patients achieve the CR rates. And in the POD24, again, 57%, so decent results. The 12 months progression event-free survival was 62%, the 18 months is 57%. Less than CAR T-cell, median progression-free survival 17.9 months. These are the patients, the blue ones are patients who achieved CRs, and this is their curves, progression-free survival, which is 17.9 months. So this is an update of their results, extended follow-up, and it's still showing a duration of response quite reasonable, and especially in those who achieve a CR. So in conclusion, after a median study of 38.9 months, no relapses were observed in those who achieve a CR beyond 26 months. The duration of response in all patients was about 23.2 months, and the complete responders is not reached yet. So toxicity, we have grade 3, 1%, and grade 3 ICANS, 0%. And we move on to epacrutimab, which has been approved by FDA for treatment of follicular lymphoma in August this year. And we concentrate on 128 patients. Looking at CR rates, the POD24 were about 50% of the patients, and the follow-up was about 17.4 months. Adverse reactions in 19 months, And they did not report the progression-free survival, but it looks like 15 months, the progression-free survival. Their overall response is 82%, CR rates is 62%. 3 out of 6 patients who had CAR T cells responded and achieved the CR. They had MRD negativity, did well. Cytokine release syndrome was high. 40% of patients had grade 1, and grade 2, 25% of patients, and 2% of patients had grade 3 cytokine release syndrome. ICANS, 6% of patients had ICANS. So zanubrutinib obinutuzumab versus obinutuzumab. This is an interesting Rosewood study. Again, the POD24 patients were 30% of the patients, and the overall response rates was 69%, CR rates was 57%, and the 18 months rate was 69%. Progression-free survival was 28 months, so reasonable progression-free survival in this difficult group of patients. And you can see here the duration of response and progression-free survival of 28 months. So all groups benefited from zanubrutinib obinutuzumab. Toxicity is mainly thrombocytopenia, infections, and secondary malignancy. So stem cell transplant and follicular lymphoma works. This is a study showing that autologous transplant works compared to no transplant. This is a registry data which has shown that autologous transplant compared to allogeneic transplant, we have non-relapse mortality is higher in the allogeneic group, relapse rates is higher in the autologous group, and then the progression-free survival is better with the allo. The overall survival is equal because they cancel out the non-relapse mortality with the relapse. So this is a strategy we can use, especially for those who had failed after CAR T cells using allogeneic transplant. So I'll try and finish quickly. Matched siblings, mortality 17%, match unrelated 33% mortality. Conventional versus reduced intensity is equivalent, so that's why we use reduced intensity transplants for follicular lymphoma. And we'll move to the conclusion. There are plethora of new treatments for relapsed follicular cell lymphoma patients being approved at the same time, which confuses physicians. And as physicians, we have to have optimal sequencing of therapy. And to do this, we have to know the benefits and risks of each treatment, and also to weigh the benefits and risks against patient factors, how frail the patient is, the disease-related factors, how aggressive the disease is, and choose the right treatment for our patients. Fit patients might benefit from CAR T cell therapy, less fit from bispecifics, and frail patients from less toxic therapies like zanubrutinib obinutuzumab. And thank you.
Thank you, Dr. Ihab. I think we should postpone the question to the end of the next session because Dr. Ihab is going to present the next session as well about the Saudi experience of 5 years experience about diffuse large B-cell lymphoma. Just a reminder, please, our bus will move to the Haram for Salah for prayer at 10 o'clock exactly. So we ask you if you kindly can finish our talks in a time allowed so everyone can go to the Haram. We are welcoming Dr. Ihab again for the next talk.
very unfortunate for you to have me again so
chairing
soon.
a satellite symposium for
You probably want to forget.
Roche. It's supposed to be 2 talks. I didn't see Dr. Riyad Al-Faqih. First of all, I would like to thank Dr. Al-Asker and the team for this wonderful organized scientific meeting in Medina, and welcome all of you in Medina. Second, thanks for Roche for giving this opportunity to chair the session. We're supposed to have 2 talks, one of Dr. Riyad Al-Faqih. I didn't see him, so we can start with Dr. Al-Humaydi. Dr. Al-Humaydi was presented before, so he will present an Saudi experience about the use of upfront polatuzumab in diffuse large cell lymphoma.
Okay, so we'll talk about diffuse large B-cell lymphoma, new hope in diffuse large B-cell lymphoma. As you all know, most common, it's one of the commonest lymphomas. 30% of non-Hodgkin's lymphoma is diffuse large B-cell lymphoma. Most frequently diagnosed at older age group, 65 to 74. Unfortunately for diffuse large B-cell lymphoma, 4 out of 10 patients tend to relapse. So we want to improve on that. And the median survival of those who relapse is only 6 months. Unfortunately for people who've been in the hematology for a long time, we've seen so many treatments that try to overtake and replace R-CHOP, and they have failed over the many, many years, over the last 4 decades, and none has been able to replace R-CHOP chemotherapy. So this is a study where they looked at Pola R-CHP chemotherapy, replacing vincristine with polatuzumab versus R-CHOP, our standard. And the cell of origin was done in this study using RNA next generation sequencing. So what this study has shown is that there is a progression-free survival benefit using Pola R-CHP chemotherapy, and also there is also an EFS benefit using Pola R-CHP chemotherapy. The hazard ratio is 0.73, so there is a 27 reduction in progression using Pola R-CHP chemotherapy. Toxicity, when we replace Pola with vincristine, as you can see in this pyramid plot chart, is equivalent between the 2 therapies. Peripheral neuropathy, which is a side effect of polatuzumab and vincristine, has been equal between the 2 groups. So there is no increase in peripheral neuropathy using this treatment. Leading to dose reduction, there was no dose reduction. You can see the Pola arm, only 3.9% versus 8.2% in the R-CHOP arm, so there is less dose reduction using polatuzumab. How about efficacy? Efficacy has been measured by what treatments do the patients after they relapse, what do they receive? So there is less need for second therapies after polatuzumab R-CHP, 22% versus 30%. Radiation after Pola R-CHP was less compared to R-CHOP. Also, second line, third line was less using Pola R-CHP, and stem cell transplant was half that of those who received R-CHOP, and CAR T cell use was also less using Pola R-CHP. The cumulative incidence of second therapies, as we've discussed, was less using Pola R-CHP, and death was equal. The number of systemic therapies was 137 versus 217. Radiation was less. If you look at the NGS type gene expression profiling, the cell of origin, the initial study was showing that ABC subtype do worse. Good risk patient age and histology. is there psychological cost for relapse? Is there financial cost for relapse? Is the patients truly GCB, the patients we see and we call GCB in our practice? The patients we call GCB in our practice is actually done by these immunohistochemical methods. At our center, we use the Hans algorithm. But when you look at concordance with gene expression profiling, the non-GCP is 80%, the GCP is only 70%. So 30% of the patients we call GCP subtype actually are not GCP by gene expression profiling. And we have to keep this in mind. Now the area for diffuse large B-cell lymphoma is getting more and more complicated with the more and more mutations we are discovering, and simplifying things by GCB ABC subtype actually might not be so easy. So we have to think about that as well. This is a signal in GCB subtype, DZIC, which has poor prognosis, although it's classified as GCB. And you can see here they do worse, and their prognosis is worse compared to the other GCB subtypes. And you can see here in this graph, this is how they do progression-free survival using R-CHOP. Using polar R-CHIP, this is how they do, so their prognosis is improved with polar R-CHIP. Progression-free survival follow-up, this is an update, again showing persistence of improvement in polar R-CHIP compared to R-CHOP chemotherapy. All subgroups benefited from polar R-CHIP. Maybe the only group that did not benefit, subgroup, is the GCB subtype group by gene expression profiling. However, in our practice, it's very difficult to ascertain whether our patients are GCB subtype or not, because we don't do gene expression profiling, we do immunohistochemistry. So in conclusion, using polar R-CHIP treatment has shown improved progression-free survival, and it might be the new standard of therapy in the future. And thank you.
Thank you, Dr. Ehab. Any questions? Yes, Dr. Darwish.
I think we have left the questions of previous session to this session, so I'm commenting on the previous, not on this one. So I have a case to share with you guys about, I do have a patient who's follicular lymphoma transferred to peripheral T-cell lymphoma. It's reported before in the literature, but it's very rare, so I just wanted to share with you the thing. He's elderly and unfit for active treatment, so I will tailor to his fitness, but anyway. So the question is, I mean, if there is a very late progression of follicular lymphoma, let's say every 10 years, patient have a progression. So would you still suggest a CAR-T for a third line in such a scenario or not?
Did you say he was an elderly patient?
To relapse? Not necessarily. If you're asking what the question. The case was an elderly though.
So late relapse follicular cell lymphoma?
Every 10 years, one relapse. So
10 years or more. And what was his first line?
R-bin the first line, R-bin the first line, R-square second line, and then after 10 years again, relapse a second time, or progressed a second time.
So did he receive a second line or just one line?
Two R-square the second line.
So the first line, he stayed in remission for how long?
10 years.
10 years. And the second line?
10 years again.
Oh, okay. So what was the second line?
Maybe I
Last
confused you. let me wrap up again. So a patient who came 20 years ago with follicular lymphoma had R-benda, 10 years later progressed, R-square, rituximab lenalidomide, then had cytopenia, so the treatment was stopped. So 10 years later, which is 20 years from his diagnosis, progressed again. Would you, so he's supposed to go for a third-line treatment, follicular lymphoma.
When you have such a lengthy periods of remissions, you can use the same protocol again. There is no harm in using the same protocol again. You might get a lesser remission, but it's fine to use the same protocol again. And you have many options depending on how frail the patient is. I'm not sure what you said, R-bendamustine and maybe R-CHOP or rituximab, second line. So you can use R-CHOP if you've used rituximab. You can use rituximab if you've used R-CHOP. So repeating the same protocols after 10 years is fine.
Yeah, thank you, Dr. Dawish. I think this question was back to the previous session because Dr. Ihab is here. So this is for follicular lymphoma. I think many options make our life more difficult, as you mentioned, but selection is difficult, sequencing is very important. Any other question regarding the POLA study? So otherwise we will move to this. Yes, please, last question.
Assalamu alaikum. Thank you, Dr. Ihab, for this great review for POLA. And I think my question is, which better for elderly patients who can be, we cannot, we start with upfront. Is it POLA, CHP, or R-CHOP? And in case of relapse, do you consider for who received upfront POLA to receive CAR-T in elderly patients especially? Yes.
Okay. Yes, age by itself is not, in the States, they're going up to the age of 80. However, in our patients, one has to be careful. And biological age by itself is not something that will prevent us from using CAR T cell because the treatment, lymphodepletion treatment, is very well tolerated. It's not like beam you use for autologous transplant. The toxicity comes from the CAR T cell itself and its long-term side effects, infections. So one have to look at the patient, and their ECOG status is very important, and their performance status and their comorbidities, and make a judgment. So I wouldn't exclude patients based on their age. It has to be based on their performance status and their comorbidities.
Can I have last question? For POLA, if I ask you, which patient you will give POLA in your clinical practice? Maybe 1, 2, 3, he is so and so and so. So which one you will push for?
So we go by the trial, so IPI 2 or more. I think it's going to be very difficult if you start subclassifying your patients. I will give to this patient and not this patient. And based on subgroup analysis in trials are not being made to take clinical decisions. They're not statistically powered to give clinical decisions because GCB doesn't respond. We should not give it to GCB, or because of this and that. I think if you implement it at your center, if you decide to implement it, you implement it as it was done in the trial, or you don't. You're either convinced and do it, or you don't. But giving it to subclasses, I think will create more confusion to other clinicians in the center.
Thank you. So we'll move the second part of the satellite symposium. It will be virtual. It will be presented by Dr. Riyad Al-Faqih. Dr. Riyad, welcome, Dr. Riyad. Dr. Riyad is a consultant hematologist from KKM Faisal Specialist Hospital in Riyadh, and he is the director of clinical research unit in Riyadh. He is special interest in lymphoid malignancies and cellular therapy. And he will present the case presentation and experience from Riyadh. Dr. Riyadh, all the stage is yours, please.
Thank you for the organizers, and thank you for Rosh. Can you hear me well, Dr. Amal?
Yes, we can. Go ahead, please.
Okay. So I was asked to present a case from our practice. So this is my agenda. We'll do a small introduction, go over our standards at King Faisal Riyadh, and then do the case presentation. So as you know, non-Hodgkin lymphoma is a frequent malignancy. And in the kingdom, it was the third malignancy in males and number 6 in females, according to Saudi Cancer Registry 2020. The median age was 50 in males and 53 in females, and it did constitute around 5.4% of all cancers among Saudi nationals, and the total number was around 756 cases. At King Faisal, this is our numbers for 40 years, 45 years actually. And as you see here, non-Hodgkin lymphoma is the fourth cancer we see. We've seen around 7,700 cases all over these years. And here you see the age distribution with the majority of patients between the age of 30 and 69. This is how the distribution is according to the age. As you see, the majority are between the age 25 and 59. And this is how these patients presented. And as you see, the metastatic cases or stage 3 and 4 are the majority, constituting 54% of the cases we've seen. And this is around 4,031 cases. So for early stage diffuse large B-cell lymphoma, we usually treat these patients with abbreviated R-CHOP unless they have bulky disease. So all early cases will get R-CHOP 3 cycles. We do a PET. If the PET is negative, we give a 4th cycle. If the PET is positive, then we extend that to 6 cycles, and we may use radiation according to the location. For bulky early stage, we do 6 R-CHOP and radiation still. For advanced stage, as you've heard, we have too many options trying to beat the standard R-CHOP. Standard R-CHOP still a standard. It was challenged by the POLARIX trial recently with a PFS benefit in the POLARIX trial, but still a good standard. And we do use R-CHOP at King Faisal. We're trying to approve Pola-R-CHP for a specific subgroup of patients, those with IPI, high IPI. We don't do radiation a lot in advanced stage diffuse large. We restricted to patients with bone involvement, extranodal involvement, and for any persistent area on the interim scan. For older and frail patients, we substitute doxorubicin by gemcitabine or liposomal doxo or etoposide, and frequently we do mini-CHOP. And if the patient is very frail, sometimes we do CVP or BTK inhibitor with rituximab. So this is the case I wanted to share. So this is a 69-year-old lady admitted in a local hospital in the north part of the kingdom in April 2024. She was admitted with abdominal pain. She has hypertension, diabetes. CT showed many intra-abdominal and retroperitoneal lymph nodes and biliary obstruction. So they placed a stent, started her on antibiotics, and sent her to King Faisal. She was ECOG 4 and she had a lower extremity weakness on presentation. So we got urgent PET and MRI. And as you see here, the PET, she has many extranodal involvement. As you see, thyroid, both kidneys are full of disease. She has lymph nodes. She has the pancreas is involved, as well as the stomach and a paraspinal lesion pushing on the nerves. So this is the colored part of the PET scan. As you see here, the thyroid involvement. Here's the paravertebral mass. It's actually pushing on the nerve and invading the bone. Here you can see the kidneys and the pancreas involved, and here more you can see the pancreas involvement. So a lot of extranodal disease. So we did a biopsy urgently, started her on steroid and consulted radiation. She was started on radiation actually after securing the biopsy for cord compression pathway. And then the biopsy later on from the right iliac bone came back as high-grade B-cell lymphoma, not otherwise specified. So she had diffuse CD20 lymphocytes, Ki-67 around 80%, and was consistent with aggressive malignant B-cell lymphoma. The FISH failed, unfortunately, because it's a bone sample, so they couldn't run it. So she received radiation to T68, 20 gray and 5 fractions. Then we did CNS evaluation, we did MRI, we did CSF, both were negative. So summarizing her case, we labeled her as stage 4BE because she's had B symptoms and a lot of extranodal disease, large B-cell lymphoma. If you check her IPI, she was of the older age and advanced stage, poor performance, LD was elevated, and she had extranodal involvement, so she gets 5 points. And her CNS IPI, she gets 6 points because she has many extranodal and she has kidney involvement as well. We gave her first cycle RCVP because she was in very bad shape. She recovered very well after 1 cycle, besides her lower extremity weakness. And she was discussed on tumor board for dose adjusted R-epoch or CHOP-like therapy. And because of her age and performance, dose adjusted R-epoch was not selected. And we thought CHOP-like therapy will be not enough for her case, given her risk status and her extent of her disease. So we chose to go for Pola-R-CHP starting from the 2nd cycle with ITs, as she has very high CNS IPI. So this is again her presenting PET scan, and here you see her interim scanning. She's in remission, and the end of therapy PET, she's in remission. If you notice here, she has some uptake subcutaneous, and this turned out to be pressure ulcer development because of her lower extremity weakness and her inability to move around. So basically, she went into remission with the Pola-R-CHP and ITs after 6 cycles. Now, as you know, many of these new drugs are coming into the practice in combination with CHOP or CHOP-like combination. So we have Glofit Pola-R-CHP versus Pola-R-CHP, and this may beat the current standard and becomes a standard. We have Epocrutamab Pola-R-CHP versus Pola-R-CHP, the NHL L5 trial. Also, this may establish a new standard. We have CAR T-cell actually in frontline. So there is the Zuma 23 comparing Axi-cell versus R-CHOP or dose adjusted R-epoch. And then we have even more, CAR T-cell use, and this is the Alpha-3 trial. So this trial is running in patient with MRD positive post R-CHOP. So patient with MRD positivity will be randomized to this CAR T-cell versus observation, and the MRD is being tested by cell-free DNA. So a lot of new options. Of course, we'll have to balance risk and benefit. So not always the best choice for your patient, but these are options coming over and may change the practice. And of course, we have to think about the financial toxicity, like using CAR T-cell in the front line or for MRD positivity. Both trials are expected to be positive, actually, but then the financial toxicity has to be considered. With this, I will finish and happy to take questions. Thank you.
Thank you, Dr. Riyad. Interesting case. And any questions? Any challenging case? So you decided because to switch to Paula because she's fit. She is unfit for the higher or more toxic therapy. Do you find a difference from her clinical response, or do you think that if you continue with the R-CHOP or R-mini, it would be the same, or what do you think? And toxicities and side effect, is there any difference?
So we thought she needs those adjusted RT-POC. The fish failed, but the presentation, the extent of disease, we thought she needs more than CHOP. Okay. The currently more than CHOP available is those adjusted RT-POC, and she's not in any shape for those adjusted RT-POC, the way she presented ECOG-4 and her age and performance. Plus her liver was not back to normal, and the kidney involvement. So this is why we went to CHOP-like therapy, and then we wanted to intensify on CHOP. So we thought CHOP is not enough, mini CHOP is not enough, because she's IPI-5, CNS IPI-6. So this is why we went on to choose Pola-R-CHP. And if you look at the trial, the Polarix trial, this is a group who did a lot of benefit from Pola-R-CHP, the ABC subtype and high IPI. So this is why we chose this treatment, because again, this is the largest, or the subgroup with the largest benefit from Pola-R-CHP. She may have had responded to mini CHOP, but again, this is how we made our choice. So we thought that she's for those adjusted RE-POC, but then she cannot. CHOP, mini CHOP are okay, but we wanted to intensify this. And we looked at the Polarix trial, and we saw that this is where the major benefit was, and higher IPI and ABC subtype, and this is how we made our choice.
Yes, Ziad. One more question.
Dr. Riyad, salam alaikum. Ziad is here. Dr. Riyad, I have the similar case, and we give her Pola-R-CHP, and she's doing good. My question, if we don't have Pola in our center, for example, would you give her R-CHOP, or you will give etoposide in this case?
Depends on the cardiac function. So we usually substitute anthracyclines with etoposide or gemcitabine if the EF is reduced, okay? Otherwise, we proceed with anthracycline. As you know, anthracyclines are the essential part of R-CHOP. So unless your cardiac function is compromised, we proceed with anthracycline-based chemo.
Thank you. One last question, please.
Thank you, Dr. Riyad, for your presentation. My question regarding your case, given that the fish failed, was it concerning to you that the R-CHOP or the Pola-R-CHP was doing worse with the double hit? So there is like possibility of your cases having double hit. So is this concerning for you?
Yeah, definitely. And this is why, again, the choice was those adjusted RE-POC. But with her performance, we did not think she will be tolerating those adjusted RE-POC at all. So this is why we made our choice to choose the next best as compared to those adjusted RE-POC. But if she was fit, walkie-talkie, definitely those adjusted RE-POC would be our choice.
Yeah, my question was the Pola-R-CHP was doing worse than R-CHOP in double hit. So why not R-CHOP rather than Pola-R-CHP?
Oh, I see. So we did not think she has, a double hit. The fish failed. She was ABC subtype, and as you know, ABC subtype, they have lower incidence of translocation and double hit. So she's the typical, aggressive B-cell lymphoma, and the new classification called not otherwise specified. Okay, so you don't have double hit. It's not Burkitt. It's ABC subtype, and very well known. They have an aggressive and bad outcome. Okay, R-CHOP is not enough in these patients, but then those adjusted RE-POC also was not enough in these patients, or did not prove to beat R-CHOP. So this is how we made our choice. In usual patients, these patients, we may give R-CHOP and consolidate with autologous transplant actually, but she's not candidate for that approach. So this is the subgroup where, you don't know what's best for the patient. Is it R-CHOP or those adjusted RE-POC? So this is how the choice was made.
Thank you, Dr. Riyad. أنت حتأخر. Last comment by Dr. Hijazi.
Since Dr. Khalid has mentioned that polar R-CHOP probably is not the best choice in double hit, I just thought I need to say something positive. So we don't know exactly the diagnosis, but if we say this is high-grade B-cell lymphoma, in the POLARIX trial, the high-grade B-cell lymphomas has done way better in the polar R-CHOP arm versus R-CHOP with CR rates 80 plus compared to 60 something in the R-CHOP. So if we consider this high-grade B-cell lymphoma, probably that's why she did better in the polar R-CHOP. It's just a comment. Thank you.
Thank you, Ayman. So by that, we conclude the satellite symposium. Thank you, Dr. Riyad. Good to see you again, inshallah, in Medina.
Thank you, thank you.
So I will just present the last talk, which was delayed. Dr. Hatim Al-Ahwal. Dr. Hatim is a consultant hematologist from King Abdulaziz University Hospital. He is the deputy director, the deputy chairman of the Department of Hematology, and he has a special interest and training in multiple myeloma. Dr. Hatim will present on the management of multiple myeloma post-autologous transplant. Please, Dr. Hatim.
Thank you very much for this kind introduction, and thank you very much for inviting me for this talk. I'll try my best to finish on time, even hopefully a bit less to catch the prayer time, inshallah. I was asked to basically discuss the role of treatment post-autologous stem cell transplantation in transplant-eligible patients with multiple myeloma. So there are two main concepts that we should go through. I'll very briefly go in discussion about consolidation therapy, and then we'll focus more on maintenance, and we'll at the end have a quick discussion about future role of newer novel therapies in maintenance as well. So to begin, consolidation therapy, as we all know, is a short period of treatment following autologous stem cell transplantation. The main goal for it is to deepen the response rate and hopefully improve PFS and overall survival. The main issue with consolidation therapy at this point, we really don't have strong evidence to support or basically say against the role of consolidation. Most novel or new clinical trials do not randomize consolidation. I think almost all of them do include a part of consolidation. There's a lot of subgroup analyses that I don't really think carries a lot of weight because, sorry, we don't really have a good randomized trial looking at this question, except a few. The EMN02 study basically did show an improved progression-free survival in patients who receive VRD consolidation following autologous stem cell transplantation. One of the fewer studies that actually had an arm that looked into consolidation versus no consolidation is the Stamina study. Basically, this trial had an arm that basically assessed, had an arm that investigated the benefit of post-transplant consolidation versus no consolidation, which those patients go into maintenance directly. This analysis was not actually positive, and it showed that there's no benefit in adding extra treatment with consolidation therapy. There's a small caveat here. I believe that in some subset of patients who are high risk or after autologous stem cell transplantation or induction, we did not achieve a very deep response. There might be a role in consolidation for those patients, but I don't really have strong data to support the use of it in everyone, especially patients who had a good deep response initially and they're not high risk patients. So I'll jump to maintenance because we're going to be a bit short on time. As you all know, maintenance therapy initially started with the use of interferon. There was a lot of toxicity associated with it. Thalidomide was the second drug that was trialed. There was a lot of neurotoxicity associated with it as well. One of the earliest success stories in maintenance in multiple myeloma was with lenalidomide. There are around 4 studies early on that actually showed a benefit in using lenalidomide maintenance. This meta-analysis that was published a few years ago actually is I think one of the earliest trials that showed that there's actual an overall survival benefit. So if we can see here, the patients, so this is a meta-analysis including the IFM, Jemima, and the CALB trials. Among those patients, among all groups, there was a benefit of using lenalidomide maintenance compared to no maintenance at all. The median PFS was around 52 or 53 months compared to around 24. If we look at all subgroups, we see that there's a benefit in using lenalidomide maintenance, regardless of what their ISS stage, age, and risk stratification. A more newer trial, the Myeloma 11 study, I think we're all aware of it, did also study the use of maintenance lenalidomide versus observation alone. And in this study, if we can see here that basically both groups, the observation and the lenalidomide maintenance group, are quite equal. There's not a lot of differences between them. And there's around 37% patients who have high-risk disease as well. And again, looking at the progression-free survival, there is a improved PFS in patients who had received lenalidomide maintenance, as well as there's a trend towards overall survival and PFS2 later on as well. Again, if we stratify in the subset groups, both standard risk and high risk cytogenetics, we do still see this benefit. That's quite significant as well. Again, this just highlights patients who have no high risk cytogenetics versus single hit or double hit. This is just the distribution of the patients in the study, which we do see the benefit in maintenance as well. The only subgroup that we do not see a significant benefit in maintenance are patients who have more than one cytogenetic abnormality. This carries basically an unmet need that we still don't know exactly what to do with those patients. Nowadays, because we're having a more diligent assessment of risk stratification early on, I think this group will still need further treatment rather than lenalidomide alone. Going through the proteasome inhibitors, obviously I'll talk about later on, there was more than one IMiD that's now been trialed for maintenance as well, but we still don't have enough data to use it in clinical practice. The first proteasome inhibitor that was used in maintenance is obviously the bortezomib. The HOVON trial initially noted that among patients with high-risk disease, although it's a small study, it did show that patients with high-risk disease did benefit from the addition of bortezomib. The risk was almost close to patients with standard risk who did not receive treatment. I'll focus more on the newer trials. So the 40 trial, basically it's a multi-center open-label randomized study. It looked at the use of KRD with transplant versus no transplant, and KCD with transplant. I'm focusing more on the maintenance side. So at the second endpoint, there was two groups, patients who had R versus carfilzomib R. And among those patients, the addition of carfilzomib did actually improve the overall PFS, the 3-year follow-up PFS. It was around 90% in the standard risk group versus 73%. And around patients who had a single high-risk cytogenetic, it was 69 versus 59. compared to patients who had double hit mutations, which was around 76 versus 42. So basically, there was obviously adding another drug will add toxicity, and that's always the question, should we balance adding more toxicity versus not? Neutropenia, recurrent infection, and vascular events related to carfilzomib was higher in the carfilzomib R group versus lenalidomide. Again, all groups have benefited from adding carfilzomib maintenance, except patients with amplification 1Q. This was not statistically significant. Otherwise, the remainder of the groups were actually showed benefit. Patients with, again, double hit had a less significant benefit compared to the other group. Going now quickly into the ATLAS study. The ATLAS study, again, it's an open label, it's a phase 3 trial, randomized, of course, comparing the use of carfilzomib, lenalidomide, dexamethasone, and then I'm focusing more at the maintenance side. So they added lendex carfilzomib versus lenalidomide alone. Although the problem is the number of participants are a bit smaller. There was one caveat in the study that I don't think they've really clarified in the report initially, but there was a lot of censoring in patients who had carfilzomib, lenalidomide, dexamethasone. Physicians and patients were allowed to stop treatment, and there was no real reporting of the cause for this discontinuation. So again, this is the characteristics for this group. So basically, at the end, this is just with a median follow-up of around 43 months. The MRD negativity was higher in the KRD group versus the lenalidomide group. Although, as I'm just highlighting, there was a lot of censoring in the KRD group versus the lenalidomide group, which was not clarified in the report itself. So again, as I mentioned, the extended post-transplant KRD maintenance, they called it maintenance, but is it consolidation maintenance? It did show an improvement in the PFS compared to lenalidomide, as you can see here. Lastly, the last proteasome inhibitor that we trialed was ixazomib. Again, this study is a very interesting study. There was a lot of talk about ixazomib being an excellent oral proteasome inhibitor, making life easier for patients. Although with such a long follow-up duration, ixazomib did not show the addition of ixazomib with RD to show any benefit in maintenance. The only point that I would like to highlight here is they actually looked at patients who had a sustained MRD negativity after stopping IRD maintenance after 2 years. The rate of MRD negativity did not actually drop significantly. This was the first or one of the earlier signals saying that probably there's a role of discontinuing maintenance in a small subset of patients who have had an extended MRD negative status. Moving on to anti-CD38 antibodies as maintenance. So one of the earlier studies looking at that was the Cassiopeia trial. It's a phase 3 trial looking in transplant-eligible patients with newly diagnosed myeloma. I'm focusing more on the maintenance part, so part 2. Basically, they initially received DARA VTD versus VTD alone and compared those two arms. The second part was comparing daratumumab maintenance. Maybe this is going to be easier. Comparing daratumumab maintenance versus observation alone. So unfortunately, nowadays, our standard of care is LEN. Comparing DARA with nothing, probably you will know that most likely you will find the benefit. Surprisingly, in this study, it was actually shown that patients who have had DARA in induction didn't really benefit much from additional DARA post in maintenance, which is again surprising. There was a lot of questions about whether to use DARA in induction only. Is there any role for DARA in maintenance? There was more studies that actually looked into this, and more recently we had the ORIGA trial that was reported just recently. So basically, this is one of the first randomized trials looking specifically at this question, whether daratumumab with lenalidomide as maintenance will add anything in this group. So basically, they initially had around 200 patients that was MRD positive post-induction / autologous stem cell transplantation. And those patients were randomized to either using dara lenalidomide maintenance versus lenalidomide maintenance alone. And in those patients, we did actually see that there is a progression-free survival benefit around the follow-up period was around 33 months. 82% of patients were still in progression-free survival compared to 66% in patients who had lenalidomide alone. And the MRD negativity conversion rate was even higher in the patients who had dara-R versus R alone. Again, now in this coming days or years, the aim was to try to deepen the response as much as we can with minimal side effects. So having a deeper MRD negativity is hopefully a surrogate for a longer PFS and OS. The other study that I'm going to mention quickly is the Perseus study, which is basically, this is a study that did not randomize the maintenance arm, but I'm just going to go through it quickly. It looked at using transplant eligible patients using VRD induction followed by transplant versus consolidation, and then the maintenance. Maybe this is going to be more easier to look here. So dara VRD versus VRD, all had transplant. And again, as I mentioned before, most trials, they don't stratify or randomize with consolidation. Almost all groups achieve consolidation therapy. That's why it's going to be a bit difficult for us to have any conclusion regarding the role of consolidation specifically in such patients. However, there was an assessment of dara-R versus R alone in the patient who had dara-VRD consolidation. And as we can see here, there is a significant improvement in the progression-free survival at around 48 months. 84% of patients are still in remission, so versus 67%. Again, because now we have a longer PFS period, it's going to need a bit more time for us to actually reach overall survival benefit. Again, this is what we just talked about. Again, one of the, just a few studies that I want to highlight. We still don't have the results yet of the maintenance arm of the GMMG HD7. I think this is going to be a very interesting study to answer this question. This is looked at another anti-CD38, isatuximab, with VRD versus VRD alone. There's another arm or randomization that looked at isatuximab, lenalidomide maintenance with dexamethasone, obviously, and RD later on. Hopefully, we will get the results in the coming months. This will hopefully guide us towards having a better understanding of whether adding an anti-CD38 will actually have benefit or not. So going through all this data quickly, I think we have still an unmet need in patients with high-risk disease. Very limited data actually looked specifically at patients with high-risk disease in maintenance. The data supporting bortezomib use is actually not the strongest, but we still use it. Whether adding MRD testing and incorporating it in discontinuation versus using long-term maintenance, I think this is a very interesting question that we will get an answer soon. And whether the use of consolidation / maintenance strategies, we're adding new novel agents. I know the price is quite prohibitively expensive, but if you want to reach the deeper remission and deeper MRD negativity, I think there are a lot of active clinical trials now looking at use of bispecifics and other immunotherapies in consolidation and maintenance therapy. With that, I conclude my talk, and I'm happy to answer any questions.
Thank you, Dr. Hatem, for being strict to time. Any questions? Yes, please.
Thank you, Dr. Hatem, for this excellent talk. Just a comment and a question about the consolidation. I mean, as you said, there is no clean trial that randomized patients to consolidation versus no consolidation. The EMN one, there was no lenalidomide in the induction, and they put it in the consolidation. And the stamina also, not all patients received VRD induction, like 50% or so. So in your practice, which group of patients are you doing consolidation? This is the first question. The second question about maintenance. There is some retrospective studies about using lenalidomide and bortezomib maintenance, especially in high-risk patients. So what do you think about that?
Thank you very much. So I agree with you 100%. From my practice, if there's someone, obviously we don't really have the MRD assessment that's widely available. But if someone is having a less than VGPR response after the initial induction, I would consider adding consolidation. I don't really have strong evidence to support this, but I think doing the best for those patients, because we know that they don't tend to do well later on, waiting for newer data. The other question, again, I think the use of bortezomib there is some evidence that does support it, especially in high-risk patients. However, there is some associated toxicities, and I find it a bit difficult to, especially in elderly patients, to continue such treatment for a long time. If the patient is young and fit with high-risk disease, I would absolutely do it, depending on the patient, I would say. If they're more of a frail patient with cytopenias and neuropathy, I would actually sometimes consider, if he's high-risk patient, adding carfilzomib instead of bortezomib, just for the neuropathy side effect alone.
Thank you, Dr. Hatem. Any more questions? If no more question, I think we can conclude the morning session. There is coffee break, lunch, prayer, and we'll be back to the afternoon session at 1:30 exactly, inshallah. The bus will move at 11 to the Haram. There is also Jum'ah prayer mosque here nearby. Thank you.
Assalamu alaikum. Bus will come back from Haram at 1 o'clock from parking number 11B. So 11.
present Professor David Lewis, who is a consultant hematology. He's a special interest in lymphoma and clinical trial, particularly in mantle cell lymphoma. Prof. Lewis is a chief investigator of the first line ENRICH study. Also, he been involved in different trial with mantle cell lymphoma. Without any further ado, Prof. Lewis, floor is yours.
Thank you very much. I hope you can hear me okay. So thank you for the very generous introduction. And as you say, I'm going to talk about mantle cell lymphoma in 2024. I'm going to try and get through first line treatment and a bit of treatment, a bit about where we are in relapsed refractory mantle cell lymphoma. So it's quite a lot to get through in 25 minutes, but I'll do my best. As I said, I'm going to try and talk a little bit about watchful waiting, and then I'm going to talk about where we are in terms of treatment of the older patient, those patients that we don't think of as transplant eligible. And then I'm going to talk a bit about the younger patient and what we do in first-line treatment. And then I'm going to go through talking about relapsed refractory mantle cell lymphoma, particularly in that very challenging post-BTK inhibitor failure setting. So first of all, let's talk about this first patient. So the first patient is a 70-year-old female patient who was diagnosed following a routine full blood count at the GP surgery, was found to have a lymphocytosis on a peripheral blood count, but otherwise a normal full blood count. And you can see the flow cytometry showed a CD5, CD20 positive population that was positive for a cyclin D1 translocation by FISH. So classic, typical of non-nodal mantle cell lymphoma, because on examination there was splenomegaly but no lymphadenopathy. So in the UK, we've actually looked at this group in some detail with the mantle cell lymphoma biobank observational study. And the reason this was set up was in order to distinguish between indolent and aggressive forms of mantle cell lymphoma, and really to try and establish the incidence and natural history of this indolent form of mantle cell lymphoma, because actually not a huge amount has been described in a prospective manner. We also collected biosamples on these patients to use as a resource for future studies. So what was the biobank? So it was a prospective observational study which enrolled any newly diagnosed mantle cell lymphoma patient over 16. The only exclusion criteria really was prior systemic therapy, with the exception of localized radiotherapy. And we recruited 590 patients across 73 UK sites over 5 years. So what happened to these patients? Well, actually, the median age was 70, which is what you'd expect from a mantle cell population in the UK, and the majority were male. We've now got a median follow-up for these patients of almost 6 years. You can see that about 2/3 of patients went on to have treatment immediately, which is perhaps not surprising. But a surprisingly large number of patients, 38% of patients, were selected by their physicians at the time of diagnosis for a watchful waiting strategy, which was actually slightly more than we thought it was going to be. We thought when we set when the biobank was set up, it was probably going to be about 20%, but actually 38% of patients with mantle cell lymphoma were thought to be suitable for a watchful waiting strategy. And of those patients, all the patients that were selected for immediate treatment went on to treatment, which is unsurprising. But only 2/3 of the patients who had a watchful waiting strategy went on to have treatment in the 5-year follow-up. So there are some patients who were never treated, about 36% of patients with mantle cell lymphoma. And this is what happened to those patients who were selected for watchful waiting. This is a graph showing the time to treatment or death. And you can see that I think the really interesting things are, first of all, remember, these are patients that were picked out for watchful waiting on the basis of baseline clinical factors. And we can see that actually only 6% of those patients received treatment within 6 months of diagnosis. So we're actually quite good at picking these patients out on baseline clinical factors for indolent disease. And of those patients for watchful waiting, the median time to treatment was almost 2 years. It was 21 months. And at the time of follow-up, when we reported this data, 22% of patients remain under observation. So there are some very indolent patients in this group that perhaps will never require treatment. And 52% of them were observed for over 2 years. Now, if we look within this group of patients that were observed for over 2 years and look at the factors predictive of observation for over 2 years, there are some factors that come out as being predictive of very indolent disease, such as being female, having a low MIPI score, having early stage disease, and less proliferative disease. So perhaps unsurprising, but it is also it's useful to be able to say that we can pick out these patients that are likely to have very indolent mantle cell lymphoma and may not require treatment for quite a long time and possibly will not require treatment at all. Unsurprisingly, if you look at overall survival is prolonged in patients who are assigned to watchful waiting. But I think the really key question is what happens to these patients following the initiation of treatment? What happens to their overall survival from the point of treatment? And you can see if you measure this, that actually those patients who had a period of watchful waiting certainly didn't do any worse than those patients who had immediate treatment. So I think you can be confident that if you have a patient with indolent disease, low volume lymphadenopathy, that you can quite happily say to the patient that you're not going to compromise their care by giving them a period of watchful waiting. And it's possible you may be watching them for years. So I'll talk. So I think I've mentioned most of those things. Okay, let's go on now to the patients who require treatment. So the second patient I'm going to talk about is a 75-year-old male patient who's got bulky lymphadenopathy and biopsies confirm mantle cell lymphoma. They're not TP53 mutated and they've got no significant medical history of note. So this is a patient who's 75, so not auto-eligible, I would say, who does require treatment because they've got bulky lymphadenopathy. So what's the standard of care currently? So I would say the standard of care in these patients right now is chemotherapy. So there are various different chemotherapy regimens that are used in first-line treatments who are non-transplant eligible. The most popular one, certainly in the UK, is bendamustine rituximab, which is used in about 70% of these patients. And we know that from data from the STILL NHL trial and from the BRIGHT study, that patients who are treated with BR probably have a longer PFS compared to patients who are treated with R-CHOP or RCVP. Other options include VR-CAP. And the other thing it's very important to remember in this group of patients is maintenance rituximab, as maintenance rituximab leads to an improvement in overall survival. And the best evidence for that is following R-CHOP chemotherapy, but there is good evidence suggesting that it leads to a benefit in overall survival following bendamustine rituximab as well in real-world data. So currently standard of care, bendamustine rituximab or other chemotherapy, including R-CHOP, VR-CAP, etc. And remember the maintenance rituximab. But can we improve upon that? So there are two studies in this population that have been reported looking at the combination of first-line chemoimmunotherapy with bendamustine rituximab plus the addition of a BTK inhibitor. So I'm going to talk first of all briefly about the SHINE study, which enrolled patients over 65 who were not fit for transplant, and it compared bendamustine rituximab with rituximab maintenance with bendamustine rituximab plus ibrutinib. Now, importantly in this study, ibrutinib was given as a treatment to progression or toxicity. So that it wasn't time limited, it was ongoing treatment. And the primary endpoint of the study was progression-free survival. So the SHINE study is a really interesting study, in my opinion. And the reason it's interesting is because it was a positive study, but it's a positive study that I think is seen by most people as actually negative, because it hasn't influenced what we do. So why was it a positive study? Well, it was a positive study because it met its primary endpoint. Its primary endpoint was progression-free survival, and you can see a clear benefit in progression-free survival for those patients who are randomized to the ibrutinib arm. Now, what I would say is, if you look at the benefit of progression-free survival, the benefit is in the order of 26, 27 months, which is important for reasons I'll come on to in a minute. So a PFS benefit for those patients with the addition of ibrutinib. Okay, so why is it not changed practice? The reason it's not changed practice is because there was no overall survival benefit at all. So despite that progression-free survival advantage, it did not translate to an overall survival advantage. And in fact, there were more deaths that were due to non-lymphoma reasons in the ibrutinib arm compared to the placebo arm. Now, interestingly, it was because of this result from the SHINE study that the FDA withdrew the license for ibrutinib for mantle cell lymphoma in the US. So a positive study in terms of meeting its primary endpoint, but because of the lack of overall survival benefit and because of the excess non-lymphoma deaths in the ibrutinib arm, this study really has not changed clinical practice, and I don't think people are routinely using this in first-line treatment. So what about if you use a different BTK inhibitor with a different toxicity profile? So this data was presented at EHA, and there is an update at ASH coming up. So the ECHO study was an identical study design to the SHINE study, with the exception that it was acalabrutinib as opposed to ibrutinib that was used as the BTK inhibitor. Otherwise, the backbone of the study is identical. Crossover was allowed from the control arm. So in other words, at progression, patients were allowed to cross over to acalabrutinib if they'd had placebo in the control arm. So what if we use a different BTK inhibitor? First of all, if perhaps unsurprisingly, if you add BTK inhibitor to chemotherapy, you do slightly improve the overall response rate and CR rate. Perhaps not as much as you might expect, but there is undoubtedly an improvement. In terms of adverse events, this was one of the things that really led to the SHINE study not changing practice because of the increased adverse event profile. But actually in this study, we're not really seeing a dramatic increase in atrial fibrillation in the acalabrutinib arm. And in fact, there was slightly less hypertension in the acalabrutinib arm. COVID-19 had a really big impact on this study. So this study was conducted at the height of the COVID-19 pandemic. And you can see, looking at the number of deaths, there were more grade 5 adverse events, in other words, deaths from COVID-19 in the acalabrutinib arm compared to the placebo arm. Now that's important because of the way the investigators interpreted this study, which I'll show you on the following slide. So significant numbers of acalabrutinib, of COVID deaths, particularly in the acalabrutinib arm. So in terms of its primary endpoint, this is progression-free survival that I'm showing you here. And progression-free survival, similar to the SHINE study, was the primary endpoint of the ECHO study. And again, perhaps unsurprisingly, there is a progression-free survival advantage for the addition of acalabrutinib to the bendamustine rituximab. The astute among you will see that the control arm, placebo plus BR, is actually performing slightly worse in this study than it was in the SHINE study. And the reason for that is because of the COVID-19 deaths. So actually what the investigators did was they generated another PFS curve with censoring for the COVID-19 deaths. And what that effectively means is they took the COVID-19 deaths out of the curve. And you can see that if you take the COVID-19 curves out, then the progression-free survival curve of the control arm behaves in a similar way to the SHINE study. And actually the gap between the PFS curves of the control and the intervention arm actually widens. So they made quite a big deal of this when they reported it and said that actually if the study had been conducted in a COVID-19 free era, then actually the PFS curves might have been even wider apart. Now this becomes even more important when we look at the overall survival curve, which remember was the thing that really led to the SHINE study not really influencing practice because of the lack of overall survival benefit. In the ECHO study, there is a non-statistically significant trend for a benefit, overall survival benefit in the acalabrutinib arm. And remember, crossover was allowed from the placebo arm, so people could cross over from the placebo to the acalabrutinib arm at the time of progression, which might well bring the curves together. And again, when they censored for COVID-19 deaths, those curves separated even more. So the investigators made the conclusion that if this study had been conducted in a non-COVID-19 era, that we may well have seen an overall survival benefit. I think it's going to be very interesting to see how the licensing and reimbursement agencies around the world interpret this data, because a lot of it is going to hinge, I think, on the interpretation of the overall survival benefit. And if there is really an overall survival benefit, or if possibly when you center for the COVID-19 deaths, you may well just be taking out frailer patients who potentially could have died of other non-relapse reasons. But nonetheless, they made quite a big deal of this when they presented this at EHA. So that's where we are, and AZD are going forward with an FDA license off the back of the ECHO study. So it's possible that may well be an option for us in the coming, in the near future, actually, to use ACAL plus BR as a first-line option. So the ENRICH study is our UK Nordic study, which is actually comparing ibrutinib rituximab with no chemotherapy at all. So in other words, completely chemo-free, with rituximab plus chemotherapy, and it was investigator choice of bendamustine or CHOP. Now, this study, I'm pleased to say, has been accepted for an ASH oral presentation. It's read out. The data is embargoed, so I'm afraid I can't tell you the outcome of the study, but do please come along to see our presentation if you're at ASH on the Saturday in the Mantle cell lymphoma session, as I do, in my opinion, I think this study is going to define the standard of care for this older group of patients. Okay, let's talk about a younger patient now. So this is a 56-year-old male patient who presented with bulky lymphadenopathy and biopsy showed mantle cell lymphoma. They're symptomatic with weight loss, and the CT revealed bulky disease, including bowel involvement. So this is a young patient who requires treatment. So the study that I think informs our practice in this group of patients is the Triangle study, which is a study that was reported at ASH a couple of years ago and published in Lancet in May of this year. And that study compared standard of care, which was a high-dose cytarabine containing first-line treatment with the addition of an autologous transplant. And most patients actually got maintenance rituximab, although the original study said observation. And there were 2 experimental arms. One experimental arm was standard of care with the addition of 2 years time-limited ibrutinib maintenance. And the third arm was standard of care plus ibrutinib, but without the autologous transplant. So time-limited ibrutinib in a younger population. And this is the paper which I highly recommend you read, as it's a very, very good study, and I do believe sets a standard of care in these young patients. So what was the outcome of this study? Well, the primary endpoint was failure-free survival, which is a bit like progression-free survival, but it also includes as events those patients who had stable disease and switched to second-line treatment because of stable disease, which PFS doesn't include. And it showed a significant improvement in failure-free survival for the addition of ibrutinib to standard of care, as shown in graph A. Now, graph B is quite interesting. What graph B shows is the comparison of the addition of ibrutinib, but without the transplant, to standard of care. Now, this was a non-significant result, but the reason it was non-significant is because the question was asked, if you like, the wrong way round. So the the assumption that the statisticians were asking the question for is whether autologous transplant was superior to ibrutinib without the transplant, because that was the assumption that was made before the study started, was that group A was likely to be superior to group I. But actually, of course, it came out the other way around. And I think if with the eye of faith, you can see that actually, if you look at A and B with the green line and the blue line, they're more or less superimposable. So although graph B is a non-significant result, and in fact the p-value is about 0.9, the reason it's non-significant is because the question was asked the other way round. So it was non-significant for the superiority of the red line over the blue line, whereas perhaps in retrospect they should have asked the question the other way around. And this is the overall survival, which is key, I think, because if you're giving everything together at the beginning, you do want to see an overall survival advantage. And the overall survival shows a trend for the addition of ibrutinib, with or without the autologous transplant. This has not been tested for statistical significance yet. When this data was first presented, I think a lot of us thought it was a non-significant result, whereas actually it's that the German statistical team only want to look once at overall survival. So we don't know if it's statistically significant. They just haven't looked yet. So does an autologous transplant add anything to ibrutinib? The answer is yes, it adds toxicity. This is AEs during maintenance. You can see that the arm with the ibrutinib plus the autologous transplant had significantly more toxicity than either the arm with just the autologous transplant or the arm with the ibrutinib but without the autologous transplant. So I think in terms of transplant eligible patients, I think Triangle does set a new standard of care. If you are following the Triangle approach, my interpretation of data is the autologous transplant adds toxicity but probably does not add any failure-free survival benefit. I think unanswered questions from Triangle are, will the OS benefit persist and reach statistical significance? Can we retreat with BTK inhibitor at progression, or are we better off going straight to CAR T-cell therapy? And in fact, the Triangle approach is now reflected in treatment guidelines for mantle cell lymphoma, both in the NCCN guidance, which interestingly allows other BTK inhibitors as well as ibrutinib, and in fact in our BSH guidance as well, although we in the UK don't currently have access to this approach, so it's not reimbursed. Okay, what about a patient 3 who is almost identical to the patient I just presented a minute ago, but this time around they've got a TP53 mutation. So what about this TP53 group? So we know that patients with TP53 mutation have historically done very poorly indeed with standard immunochemotherapy approaches. This is data from the Nordic studies showing that the median overall survival with TP53 mutated MCL is in the order of 18 months to 2 years, which is significantly shorter than patients without a TP53 mutation. So could the Triangle study help us here? Well, we've got data in the Triangle study looking at high-risk subgroups and looking particularly at patients who had TP53 overexpression. And it does look like patients with TP53 overexpression, as demonstrated by graph D on the lower right there, do benefit significantly from the addition of ibrutinib. There is also data from TP53 mutated MCL, which was presented at Lugano, which shows a similar pattern in a benefit for the addition of ibrutinib to those patients with TP53 mutation. So whilst small numbers, and this is ultimately a subgroup analysis, there is some evidence to suggest that a triangle approach may well benefit those patients with TP53 mutation. And there is also data in TP53 mutated MCL from the Simpatico study. There was one arm of the Simpatico study which looked at previously untreated mantle cell lymphoma with TP53 mutation and showed a PFS, perhaps slightly disappointingly, because I think we're all hoping that these combinations might look better in TP53 mutated MCL, of about 18 months. We're also looking at triplet combination treatment in TP53 mutated mantle cell lymphoma. So this was a study presented at ASH last year. This is a phase 2 single arm study conducted in the US, looking at TP53 mutated previously untreated mantle cell lymphoma using the triplet combination of zanubrutinib, obinutuzumab, and venetoclax. So, I mean, it was kudos to the investigators for managing to recruit patients to a very challenging group of patients to this study. So we're seeing a very high response rate with this triplet combination of 96% best overall response rate with 88% CMRs. And in terms of progression-free survival, again, perhaps, I mean, a single-arm phase 2 study, these are going to be slightly selected patients, remember, because it's a US tertiary center study. But with a median follow-up of 23 months, you can see a PFS, which is probably slightly better than historical controls. What do we need then? What we need is a randomized study, and we've got a joint UK-French study called the OASIS-2 study, which is looking at a triplet combination of ibrutinib, venetoclax, and anti-CD20 antibody, again, a doublet combination of ibrutinib plus rituximab, and this is looking at previously untreated mantle cell lymphoma, including those with TP53 mutation. And so this may well take us a bit further forward in answering the questions to whether triplets or doublets are better. And there is some preliminary analysis of this data being presented at ASH in this year. So if you're at ASH, do come along to that. I think it's being presented on a Monday. Okay, I'm going to talk about BTK inhibitors in second line briefly, and then I'm going to try and just cover in probably the 5 or so minutes I've got left what we do post BTK failure and what studies are going to tell us. So I think BTK inhibitors have become the standard of care for second line mantle cell lymphoma treatment. Ibrutinib is the first in class BTK, but we also got FDA approval for Zanu and acalabrutinib. The ibrutinib FDA approval was withdrawn following the SHINE data, which I showed you a few minutes ago. And I think the key difference between them in mantle cell lymphoma is different off-target effects with different toxicity profiles. Currently, we don't really have any head-to-head data in mantle cell lymphoma comparing the overall response rate and PFS of these agents. They're all phase 2 single-arm studies, really, and they have different patient populations, which makes it actually very difficult to compare them, but certainly different toxicity profiles. And from the pooled data of ibrutinib clinical trials, we know that the best time to give BTK inhibitors is second line as opposed to subsequent lines. If you give it with one prior line of treatment, you get a significantly better progression-free survival than if you give it later. So the time to give BTK inhibitors is at your first relapse. We know that there are some patients, though, who do pretty poorly with BTK inhibitors. This is data that we've looked at with our real-world data set, and we've also collaborated with the North American group and shown that actually that patients who have a very short progression-free survival to their first-line treatment, those POD24 patients, and particularly those patients who get a response of less than 6 months to their first-line treatment, actually have a very short progression-free survival and overall survival following ibrutinib treatment. So those patients who have a poor response to first-line treatment, really you've got to start thinking ahead about what you might do third line and beyond, because these patients are likely to do very, very poorly, unfortunately, on second line BTK inhibitors if they've had a very short response to their first line treatment. And we know that post discontinuation of ibrutinib in trial populations and real world populations, overall survival is very, very short indeed. So this is a very challenging patients, these patients who relapse following BTK failure. So can we improve on BTK inhibitor second line? The Simpatico study was presented last year at ASH and looked at the doublet of ibrutinib plus venetoclax compared to ibrutinib in a randomized study. Here's the Here's the trial schema for you. The venetoclax is time limited, the ibrutinib is ongoing treatment, and the primary endpoint was progression-free survival. I won't spend time on the patient characteristics other than to say that they're reasonably well matched, and there were significant numbers of high-risk patients, including TP53 mutated patients in the study. And again, the primary endpoint was met with a progression-free survival for the addition of ibrutinib plus venetoclax. Now, importantly, the PFS advantage was longer than if you give venetoclax as a single agent. The PFS for venetoclax as a single agent in relapsed refractory mantle cell lymphoma is short, in the order of a few months, 2 to 3 months. And actually, the overall response rate is low as well, in the order of about a third. And you can see that the PFS advantage of ibrutinib plus venetoclax is longer than the PFS you would get if you gave venetoclax as a single agent, which is promising. The only thing that makes me slightly, I guess, dubious about the results from this study is that I would expect a PFS advantage in patients who are having a BTK second line for mantle cell lymphoma to translate to a significant overall survival advantage. And we're not really seeing that in a Simpatico study. There's a trend for OS advantage. So I think it is important we get a bit more data from Simpatico in terms of what patients had as subsequent lines of treatment, if these patients are all going to get CAR T cells, for example, and whether that might explain the lack of OS benefit that we're seeing. But it is a bit strange, in my opinion, that we're not seeing the OS curve separate a little bit more, given that PFS advantage.
2 minutes, please.
I won't spend time on this. Okay, so I've got a very short period of time left, I think. So I'm going to skip through a patient case for you. We obviously got CAR T cell therapy in third-line treatment, which is available now. But our UK data, this is the PFS curve from the Zuma-2 study. But our UK data suggests that CAR T is actually quite challenging to deliver in mantle cell, although it's probably the third-line agent with the highest response rate and PFS. In terms of agents under investigation, I would say the most promising agents in mantle cell lymphoma are bispecific antibodies, including the glofitamab data at ASH in 2022 and the Mohsen and Polar data in ASH 2023. There's also epcoritamab data coming through with the CD3, CD20 bispecific antibody, but that has not yet been reported. Other agents in the post-BTK failure setting include BTK degraders and non-covalent BTK inhibitors, including pirtobrutinib and also ROR1 antibodies. So I think in the interest of time, I will stop there. It's quite ambitious, I think, to get through relapsed refractory and first-line mantle cell in 25 minutes, but I'm very happy to answer any questions.
Thank you, Dr. Lewis. You cover most of the challenges in mantle cell lymphoma. For the sake of time, if we have one question, please. Yes, please. Dr. Lewis, you're with us?
Yeah, I can hear you. Can you hear me?
Yes, we can.
Thank you, Dr. Lewis, for your talk. Regarding the triangle trial, would you apply it on the leukemic indolent mantle cell lymphoma patients?
So I think, I think, as I said, those patients may well not require treatment first. So you could quite happily watch those patients for a period of time. Would I use a triangle? So you're asking the question, is it overkill maybe to use? My approach actually is at the point of requiring treatment, I don't treat those patients any differently to treating any other patient. So my feeling is that indolent group, I would watch them up until the point they require treatment, and that period might well be some time. And we've shown from our data that the median time to treatment in the indolent group is about 2 years. So you might be able to watch them for some time actually. But at the time they do require treatment, when they're becoming unwell, or if they're getting lymphadenopathy, I tend to treat them in exactly the same way as I do any other patient personally.
Thank you, Dr. Lewis. We will conclude here. Thank you.
Thank you.
Thank you. I think we'll move to the next talk. It's my pleasure to present Dr. Toby Ayer. He's a hematology consultant at Oxford University. He's an expert in lymphoma and cell management and editor and investigator at many trials for CLL and lymphoma. He has over 150 papers as well. He is an editor at the British Journal of Hematology. Dr. Tubi will talk about cell and Richter transformation best practice management. Dr. Tubi, please.
Great, thank you very much. Can you hear me okay? Is the audio good? Hopefully you can.
Yes, we can.
So thank you for the invitation to speak. I'll speak for about 20-25 minutes on this topic of Richter transformation. I think we all recognize that this is a very distinct, uncommon but difficult scenario that we sometimes face. And I'll run you through some of the current thinking, some of the clinical workup, and also some of the investigational sort of data in this space that's helping influence our practice. Here are my disclosures. So Richter transformation was first described nearly 100 years ago now as an American pathologist who described a patient with a low-grade lymphoma developing a low-grade sort of indolent disease at that time, then later found to be CLL, basically developing a life-threatening syndrome with rapidly enlarging lymphadenopathy. But it wasn't until the 1960s where this term Richter transformation was actually formally coined based on more cases described. And then, of course, this has become a well-described disease entity now. Most of the transformations are to a activated B-cell type or non-GC type diffuse large B-cell lymphoma, but of course you can rarely transform to Hodgkin type Richters and also very rare other entities as well. The patients we should suspect Richters in are patients with CLL who develop disproportionate weight loss, rapidly enlarging, asymmetrically enlarging lymphadenopathy, extranodal disease, or a rapidly rising LDH or a new high calcium or necrosis on a CT scan. A combination of those factors make you concerned. Of course, the disease is fundamentally a histological diagnosis, and so it's critical to get tissue from FDG avid masses wherever possible. If you do confirm the diagnosis, most patients have clonally related disease to their underlying CLL. And unfortunately, if you look into the literature, the median overall survival is somewhere just under a year. Now, the rates of transformation have been variably reported, but probably represent about 2 to 3% of our patients that we see with CLL. Now, of course, a number of interesting and important questions that still exist are around whether you can change the natural history of the disease by offering non-chemotherapy-based treatment. And there's some suggestion from recent data, I've just put an ASH abstract up from last year, that in the novel era, there may be a reduced rate of transformation. Although it has to be said, in studies like, for example, the Murano trial, there was no difference between the rates of transformation following BR or venetoclax rituximab. And actually, in this series, both groups still had prior historical chemotherapy. So we don't have a lot of data on, for example, novel approaches from diagnosis and what that does to the risk of transformation. So it's still an open question. So what do you do around the diagnostic workup? Well, the first thing is just a few words about PET scans. So PET scans can be useful in patients with Richter transformation for a couple of reasons. Firstly, if you've got somebody who you don't think has Richters and you do a scan and for whatever reason, and their SUV is generally less than 5, although in some series less than 10, but generally speaking less than 5, then that actually has a very high negative predictive value for Richters. And so you probably don't need to go on then and look for biopsy sites and so forth. You can probably manage patients as if they have CLL, SLL. So it can be useful if the SUV max is low. It can also be valuable, of course, if you have a really dominant site or a disproportionately avid mass or area, because it can help target biopsy. So those fundamentally are the two key reasons to do a PET scan. I've just listed some of the recent references that have helped define the use of PET. There is really relatively limited data with patients post, for example, BCL2 inhibitors or BTK inhibitors, and I think some of that data still needs to be sort of more fully worked out. But in essence, those are the sort of rules of really where PET is valuable in in people who you're concerned may have Richters. And the other really important thing to mention is the workup of patients and looking at the diagnostic material. And just a reminder that this really is a histological diagnosis, and ideally you need specialist hematopathology review. We did a UK-based study a few years ago and actually got 2 independent and blinded hematopathologists to look at the biopsy tissue, and actually they only felt independently that about 80% of the patients who were initially enrolled in the trial actually ultimately had Richter transformation as opposed to accelerated CLL or some other issue. So I think it's really important to get expert eyes on the biopsies for these patients, because the histological WHO defined definition of Richters is different to, for example, just accelerated CLL, which we sometimes see in these patients. The other 2 important factors to at least consider testing for, if available, are the clonal relationship to the underlying CLL. Certainly those patients with clonally unrelated disease probably do better, although it's still recognized that the evidence base for treating patients differently is limited. And the other important factor, and this has been a consistent finding, is that patients with a TP53 deletion or mutation do substantially worse from a progression-free survival point of view compared to those patients that don't have a TP53 disruption. You can see here the differences in this series from over a decade ago now. The other key thing is actually the context in which the transformation occurs. So here's some data from the Mayo Clinic and also some data from ASH last year. So on the left-hand side, you can see here, this is overall survival according to prior CLL treatment status. And so if you have had prior treatment, you're the red line. And if you've never had prior treatment for CLL, you're the black line. And so that really is a stark difference. And it makes biological sense, of course, but just a reminder that actually your survival is very much influenced by your historical CLL disease course. And this is dividing patients further into whether they've had 1 prior CLL treatment or more than 1. And again, you can see quite a substantial difference here. Something similar has been shown from data at ASH. These are patients in the novel agent era, where to look to see whether they've had prior treatment for the CLL, and then also transformation. Concurrent diagnosis or a prior diagnosis but no prior treatment. You can see here this substantial difference again being seen. So the context of diagnosis is really important. Okay, so if you make the diagnosis, what are the clinical challenges here? Well, this schema hopefully just describes some of them. I'm just going to run through some quickly. So the first thing to say is you often have a patient deteriorating quite quickly in front of you. Clinically, they can develop a rapidly deteriorating performance status, can have quite bulky disease. The kinetics of this disease is generally quick, and so you don't have a lot of time to play with if you think somebody's got transformation. Of course, CLL is a disease of older people, and so often comorbidities and other organ dysfunctions can sort of play into the challenge. Many patients historically may have had chemotherapy. The genetics of the disease I'm not going to talk about in great detail, but often these are the sort of findings you see. CDK and 2A mutations, TP53 mutations, and MYC mutations are really quite common and often lead to chemo resistance and also proliferation. So those are the challenges there. And of course, one of the key things also is the delivery of treatment is challenging sometimes because the CLL is often quite sort of commonly infiltrating the marrow. And that means, for example, delivering immunochemotherapy to standard dose on time is actually challenging because of this. So giving, for example, 6 cycles of R-CHOP chemotherapy in this setting is sometimes quite a lot more difficult than if you're giving it, for example, in just a de novo DLBCL patient. And one of the challenges, and I'll talk more about this, is the relative lack of clinical trials and the fact that there haven't been any pivotal or registrational studies per se in Richter's alone. Okay, so how do we treat Richter's? This is a historical slide of attempts made over the last 20 years or so to analyze different chemotherapy-based regimes. And I've just listed some of the sort of most common regimes here. You can see here sort of anthracycline-based treatments, platinum-based treatments, some fludarabine-based treatments as well. And a couple of things just to say, they are quite toxic. You see quite a lot of cytopenias. You can see here the treatment-related mortality ranging a bit here between a couple of percent, but right the way up to nearly 20% with some of the more intensive treatments. And then sadly, the median survival in these series is short, as I mentioned, between a few months up to sort of a year or so. And the other thing to say importantly is actually these are very modest sized clinical studies, anywhere between 7 patients at the bottom there up to a maximum of 35 here. So really the clinical trials that we've seen historically with chemotherapy have been fairly limited. This is also reflected by one of our UK studies that we performed. So we published this now 8 years ago. 37 evaluable patients were enrolled, and CHOP was given alongside ofatumumab, so sort of historical CD20 antibody then, and ofatumumab maintenance was also added in here. And you can see, sadly, this didn't really improve on historical outcomes. Median progression-free survival only 6 months, with a median overall survival again at a year. And there were no particular subgroups that really benefited from a response point of view. One of the key things here is you actually lose responses on therapy. So the overall response rate was 65% after 4 cycles, but by the end of 6 cycles, that dropped to 44%. So 20% of those responders were actually losing their response on treatment. So clearly one of the key issues here is just the innate chemo resistance that this disorder unfortunately leads to. What about dose-adjusted EPOCH-R? We know there's some data in double-hit lymphoma, in patients with a MYC rearrangement. Can you improve on outcomes with Richter's? Well, the answer is probably not. Here's some data from the US demonstrating short, median progression-free survival, and also a very sobering statistic of 30% of patients actually dying without disease progression or response. So this is really demonstrating some of the toxicities that you see with dose-adjusted EPOCH-R, and it's certainly not my routine practice to deliver this in patients with Richter's. And one of the key things here is, if you do get patients into a remission, should you offer a stem cell transplant to patients? This is probably the best data that exists. This is data from the US, from the CMBTR registry, looking at patients with autologous transplant and allogeneic transplant. And of course, as you might expect, you get more relapses with auto than you do with allo, but the non-relapse mortality is higher with allogeneic stem cell transplant. So actually the 3-year progression-free survival is an overall survival are pretty similar. But allo transplant obviously has a better ability to target underlying high-risk CLL and probably leads to the higher chance of cure. And so it's my preference broadly to perform our allo stem cell transplants in this setting. You can see here that your remission status going into transplantation, allo transplant, is really important. So the deeper remission you're in, the more likely you are to survive longer. And if you have really genuinely resistant disease, I'm not personally convinced an allo transplant gives people great benefit. Now, of course, one of the issues here is actually the broad applicability of stem cell transplants, really limited by the lack of durable disease control that you find in people in first remission. So, of course, you ideally need patients' disease to be under good control while an allo transplant sort of works, and you get graft versus lymphoma effect and graft versus CLL effect. And one of the issues here is you just don't get that time often because patients relapse very quickly often. So how do I treat patients with Richter's now? Well, this manuscript from the JCO last year that I co-authored with some Australian colleagues, I think really highlights how I manage patients. So obviously looking for clinical trials at any time point during the disease entity, I think is clearly critical. But outside of a clinical trial, I would say a sort of inadequate, but a sort of recognized standard of care is still R-CHOP chemotherapy. And then I think about allo stem cell transplant in first remission if a patient has any one of these features, so a TP53 disruption, clonally related disease, or a prior CLL therapy. All of those are sort of represent higher risk groups. If they don't have any of these features and they obtain a remission, then I think it is reasonable to observe those patients. But of course, those represent the real minority of patients. The relapse refractory pathway is listed here. I won't go through this in detail. Of course, clinical trials are critical. Anti-CAR T-cell therapy does look active. I'll show you some data here. And there have been some interesting molecules coming through in clinical studies, which I'll talk about shortly. And of course, if you're fortunate enough to get somebody back into remission in the relapse refractory setting, you should also consider allo transplant. But the same issues certainly exist with durability of disease control in that setting. So a look to the future. Have we seen anything recently? Have we got novel agents which may change the treatment pathway and the development in Richter's? So the next couple of slides, really a summary side of the literature looking at different targets and different agents that have been at least studied and are in a degree of development. And what you can see here is a list of treatment options, covalent and non-covalent BTK inhibitors as monotherapy here in green. I'll talk a bit more about pirtobrutinib here because the data is really sort of standout data in terms of at least patient number. One of the issues here, though you do get reasonable responses and clearly BTK inhibitors are easy to deliver tablet form treatment, one of the issues here is that the duration of response again is not great as monotherapy. What about novel combinations? Well, we have seen interesting data with BTK inhibitors and PD-1 inhibitors. And again, I'll talk a little bit more about the RT1 study because that has demonstrated some quite interesting results with, again, some durable responses seen in some patients. BCL2 based treatment, so venetoclax alongside chemotherapy does look active. Matt Davids from Boston has done a lot of work here looking at responses in patients who've received venetoclax plus either dose-adjusted EPOCH or then more recently the protocol was amended to include R-CHOP. And you can see here CR rates really pretty good in the range of sort of 50 to 60%. But median PFS still sort of somewhere between about 7 to 10 months. So perhaps a little bit better, but not game-changing data. And then we've seen some interesting series of bispecific antibodies. So you can see here 2 molecules that are licensed in DLBCL. You can see here demonstrating really quite good single agent activity with CR rates of 45 to 50%. Of course, very small patient numbers, but still interesting. And mosunetuzumab does look active as well, but the CR rates look quite a lot lower compared to glofitamab and epcoritamab. So I mentioned I'd talk about pirtobrutinib in a little bit more detail. So this is a highly selective non-covalent reversible BTK inhibitor. It's been studied in a lot of patients now in the BRUIN trials. It's very selective. And one of the advantages here compared to other BTK inhibitors is you get coverage across over the IC90 for BTK from a pharmacokinetic point of view across the 24-hour period. So in theory, that may be more important for diseases where there's a substantial proliferation and cell turnover, such as Richter's. Here's the data with Richter's, 75 patients, most of which are previously treated. And you can see here the overall response rate over 50%, with actually tumor reduction in most patients, at least initially. So certainly demonstrating single agent substantial activity in this disease. But one of the issues here is the relapses occur earlier. So median progression-free survival in this whole cohort is only about 3.5 months. But certainly it does suggest real activity, and this agent is very well tolerated and could be combined in clinical trials. I mentioned the RT1 study. So this was the PD-1 inhibitor tislelizumab plus zanubrutinib, so second generation covalent BTK inhibitor in Richter's. 59 patients were enrolled. They had a slightly unusual rule, which patients who dropped off early were not considered in the efficacy evaluable patient population. So do bear that in mind if you read the manuscript. And you can see here the response rate when those patients were removed was 58%. And actually this PFS curve, although encouraging with some durable remissions, did exclude those 11 patients that progressed early. So it suggests certainly here that there are some patients who get very durable responses, and one of the key things is trying to work out sort of who that group is. This looks like a well-tolerated combination. And then in the relapsed refractory setting, I did say I'd talk about CAR T cell briefly. So anti-CD19 CAR T is clearly a highly active treatment in diffuse large B-cell lymphoma, and Richter's hasn't been studied to the same degree. Of course, T-cell function in CLL is a particular issue, and certainly has to some degree limited the development of T-cell engaging therapies in CLL and Richter's. His data on 69 patients, they were heavily pre-treated. Nearly all had received a prior BTK inhibitor or BCL2 inhibitor, and a median of 4 prior lines overall, 2 for the CLL and 2 for the Richter's. Most patients required bridging. So these were a high-risk group of patients. Now you can see here that there are some durable remissions. This is going out to sort of 3 years follow-up here. Some patients, maybe 20-25% of patients in a long-term remission, but very few patients here sort of at risk from a Kaplan-Meier curve point of view. And this is a fairly toxic therapy in this setting, with a non-relapse mortality of 13% and quite a lot of infectious complications, and also cytokine release syndrome and ICANS. So it's not necessarily straightforward to deliver, but I think there are a proportion of patients that get sort of durable responses. And if you obtain a CR, you do pretty well. If you don't, then you relapse very, very quickly. So that's some of the data that exists at the moment. Now, of course, in theory, there's lots of rational combinations that you can look at from clinical trials. And this is just a summary of some of the ongoing clinical studies that we've seen. There's a lot of detail on this slide. I just want to highlight a couple of things. So firstly, the bispecific antibodies are being studied in more detail. So we should see more, hopefully some more data there in the future. This is a study which I think has some real potential. So this is a randomized clinical trial of CHOP-based therapy, so R-CHOP or R-mini-CHOP versus pirtobrutinib plus epcoritamab in patients who previously had untreated Richter's. That's a randomized study, 112 patients run by the German CLL study group. So do look out for the results of that in the future. It will take quite a while to recruit to that study, clearly, but of real interest. And then I just want to highlight a couple of other studies. So in the UK, we have the ongoing trial of R-CHOP versus R-CHOP plus acalabrutinib. It's called the Stella trial. It's recruited now over 40 of the 60 patients. So we will hopefully see results of that in the relatively near future. And then this is another interesting study where glofitamab is being added into immunochemotherapy in a 40-patient single-arm study. So again, that's an area of real interest. And of course, at the moment, I think we're at a bit of a crossroads where we don't know whether we should be using chemotherapy as our backbone or whether we should be using sort of novel approaches. And I think that really is still very much to be debated. So this is my last slide. So clearly, the context of the outcomes for Richter's depend very much on the context of the of the disease. So lines of therapy, concurrent diagnosis, genetics, and clonality, I think, are key considerations. One of the challenges to recognize what a standard of care is. Is there one? I mean, R-CHOP or R-mini-CHOP is used very much as a control arm in randomized trials. So that's probably a standard of care. It's just, it's not a particularly adequate one, but I think it's what exists at the moment. I think you should consider allo transplant in first remission for suitable patients. And we've seen lots of development across hemato-oncology, and that's starting to impact the management of Richter's. Many of these agents are well tolerated. They lend themselves to combination studies. But of course, none of these studies have been pivotal studies designed at licensing and reimbursement. And sadly, we don't have any sort of active therapies that we have outside of our standard of care treatments that are readily accessible, and hopefully that will change in the future. And of course, not all these patients will respond to these therapies. You can see response rates that I've demonstrated to you between 30 and 50%. And so it'll become increasingly important to understand who responds to non-covalent BTK inhibitors, bispecific antibodies, PD-1 inhibitors, etc., because there's a lot of efficacy as monotherapy, but the response rates are fairly modest, and so we need to sort of ensure we understand biologically who is responding to these treatments and who isn't. So that's a brief tour of Richter's transformation. I hope that was of interest. I'll stop sharing my slides now, and I'm happy to take any questions.
Thank you very much. I think we can take question now.
Thank you very much for your talk. I just wondered what might be the rationale for combining glofitamab with anti-CD20 while both are targeting, the CD20?
Yeah, that's a good question. Yeah, I mean, I'm not involved in that particular study. I suppose I think they potentially target different epitopes. Yeah, I mean, and there are studies, for example, of R-CHOP plus bispecifics in, DLBCL that have been done. So I think it's just a rationale that they just target different parts of the CD20. But I mean, I agree. There's certainly a debate to be had about whether you need that. I think we don't know more broadly whether CD20 targeting bispecific antibodies will take the place of CD20 antibodies more broadly in hemato-oncology. I think that's still to be worked out. And there are certainly ongoing studies of, for example, R-squared with bispecifics in follicular lymphoma, where rituximab is still used in addition. So, yeah, I think it's still there to be debated. It's a good question, I think, and something we'll need an answer to in the future.
Thank you. Do you think that the choice of first option in the management of CLL can delay transformation to Richter?
I think there's a potential that actually if we're using, for example, fixturation therapy, driving high levels of MRD in our patients using, doublets and triplets and so forth in the future, that may well do. Yeah, I mean, we'll rely on population-based data to sort of tell us whether they're genuinely impacting the Richter transformation rates. It's possible. It certainly looks like that might be the case, but I don't think we'll sort of know definitively.
Thank you very much. I think we can conclude and we move to the next talk. Thank you very much.
Thank you. Thanks for the invitation.
So we will move to the third talk. It will be bispecific antibodies in multiple myeloma. It will be presented by Dr. Joshua Richard. So it is not Richter. And Joshua is Associate Professor of Medicine at Sinai Medicine in School in New York. And he is heavily involved in the medical community and continues to mark significant stride in treatment and research in multiple myeloma. So without further ado, Dr. Joshua, floor is yours. Thank you.
Thank you so much to the organizers of this amazing conference to allow me to speak today. And I love the very, I guess as the British would say, cheeky reference. So we go from Richter's to Richter, but I will be focusing on bispecific antibodies in multiple myeloma. So across the last few years, we've really discovered that we are optimizing our induction therapy by using 3 of the core drug classes in multiple myeloma: immunomodulatory drugs like lenalidomide, proteasome inhibition like bortezomib, and CD38 monoclonal antibodies like daratumumab. And with the recent advances and approvals of regimens such as Perseus, Griffin, Imraz, Cepheus, Ischia, the list goes on, but essentially we're shoving these 3 core classes into the upfront setting of multiple myeloma. And we have patients who are becoming triple class exposed, if not triple class refractory, even in the early relapse setting of myeloma. And one of the things that has become clear is that despite the last decade of regimens in relapse looking at novel combinations of CD38s, proteasome inhibitors, and IMiDs, we need to move beyond these 3 drug classes in relapse and consider small molecules such as venetoclax and 1114 translocated myeloma, selinexor in specific patients, as it has wonderful activity. But I think one of the biggest areas that we've come across has been the T-cell redirection therapy, both in terms of CAR T cells and bispecific antibodies. At the current time in myeloma, we have a number of bispecific antibodies approved and in clinical trial, but we can classify them as either the BCMA bispecifics or the non-BCMA bispecifics. On the left side of the screen, we see the current leading candidates for BCMA bispecific antibodies in myeloma. And just a point of reference, these are all BCMA CD3, so T-cell engagers. We note that in the last 15, 20 years of myeloma approvals, at least in the US, the approvals have been for drugs given as monotherapy or in combination with dexamethasone, have shown approval of overall response rates between 22 and 30%. The original approval for carfilzomib, based on the 003A1 study, was only 23%. Pomalidomide was approved at 28%. Daratumumab approved at 29%. But we see here in a more heavily pretreated group of patients, the BCMA bispecifics having overall response rates between 60 and 80%, showing them to be some of the most efficacious drugs ever approved in myeloma. Now, the bispecific antibody space is moving very, very fast. And even since this slide, there have been some updates, as alnuctamab is no longer being pursued in myeloma, and TNB-383 has been purchased by AbbVie, now ABBV-383. However, elranatamab and teclistamab are currently approved in many countries, and linvoseltamab will likely be approved in the first half of 2025. In terms of non-BCMA bispecifics, we have 2 leading candidates. And one important thing of note is that CD38 bispecifics have really not come into their own in myeloma. There have been a number of therapies, including ISB 1342, formerly GBR 1342, and AMG 424. Both drugs have been undergoing clinical trial, although 424 has stopped, and ISB 1342 has not shown significant activity to date. However, 2 additional targets which have been GPRC5D and FCRH5. GPRC5D, CD3 antibodies noted as talquetamab, which was approved in the recent year, and again has response rates of between 60 and 80%, and we'll go through some of that data granularly. And in my mind, one of the most exciting bispecifics that is still under trial, additional data to be presented at this year's ASH meeting, and hopefully approval, hopefully by 2026, will be cevostamab, the anti-FCRH5 bispecific antibody. So this really all began with teclistamab's approval based off of the Majestic-1 study. And one of the things that the last talk talked about very exquisitely is that when we use CAR T-cell therapy, we do run a risk of CRS and ICONS, which can have significant morbidity and even mortality at higher grade. One of the ways that we offset the risk of CRS or ICONS is through step-up dosing with our bispecific antibodies. And here we see with teclistamab, we have several step-ups at 0.06, 0.3, ultimately up to the 1.5 mg per kg dosing schedule. This is administered subcutaneously, and step-up dosing typically be given between 48 and 72 hours apart. We did see an overall response rate of around 63%, with more than half of these patients achieving a VGPR in data that was published by Philippe Moreau in the New England Journal of Medicine. Now, the swimmer's plot here shows that not only are these deep remissions, they are quite durable. And we have many patients who are staying in remission well beyond a year, whereas standard novel therapies in this setting have provided durations of remission between 3 and 6 months. Now, one of the things that's noticed that along with these new amazing response rates is a litany of new toxicities that we must take into account. Now, of course, I really think about these in terms of acute and delayed toxicities. The acute toxicities, as we've discussed, are CRS and ICONS. And again, when you have a patient with immune suppression and hematologic malignancy, and the symptoms they develop are fever, hypotension, tachycardia, and hypoxia, this could be difficult to separate from an infectious cause, but timing very much helps. If 10 hours after your step-up dose, you have these symptoms, most likely CRS. 3 months after starting this, you have those symptoms, most likely sepsis or infection. Anywhere in between can become quite difficult. But the other issue, apart from this and general hematologic toxicity, has been overall infectious problems. We recognize that there's a multifunctional immune suppression, both from hypogammaglobulinemia, neutropenia, lymphopenia, and the T cell redirection itself, whereas originally you'll have T cells directed to fight off bacteria, viruses, and cancer, but if they're sent off to fight the malignancy, there's no one minding the store, and infection rates can be quite high. And we saw around a 75% rate of hypogammaglobulinemia. And in data that was published from our group, we showed that primary prophylaxis with intravenous immune globulin led to a 10-fold reduction in infectious complications. Now, obviously, the big question is, what can we do about sequencing these great therapies, and what do we lose? And in general, the data to date has shown about a 10% declination in response when going from one type of T-cell redirection therapy to the next. So we see here data from teclistamab, and in the original Majestic-1 study, the overall response rate was 63%, but we see here in patients who had prior ADCs or CAR-Ts, about a 53% overall response rate. Elranatamab was another approved therapy, and this is proved on a number of studies run by both Alexander Leshokin at MSK and Mohamed Moti over at the Sorbonne, another BCMA CD3 bispecific antibody that is administered in a subcutaneous fashion. Again, similar to the Majestic-1 study, these patients were heavily refractory with a median of 5 prior lines of therapy, many of these patients being triple class refractory, and some of them having prior BCMA therapy. The overall data does look quite similar to Majestic-1, median duration of remission of around 12 months, overall response rate around 61%, again with an impressive swimmer's plot that we can see here. Now, this in turn led to a median duration of remission of around 17 months. There are a handful of small differences between elranatamab and teclistamab. Elranatamab has a shorter step-up dosing schedule, 5 days instead of 7 days. It is fixed dose, so as opposed to mg per kg dosing, fixed dosing schedule, which makes pharmacy very happy. But other than that, in terms of efficacy and toxicity, the drugs are quite similar. So again, we see similar rates of CRS, which can be as high as 70 to 90% when we give bispecific antibodies, although the overwhelming majority of this is going to be grade 1, and with ongoing studies about giving prophylactic tocilizumab, we've seen that many drugs can get that CRS rate as low as 20 to 30% when giving one dose of prophylactic tocilizumab. Now, we recognize that BCMA bispecifics are quite amazing, but one of the big things is that BCMA, also known as CD269, is expressed on other hematopoietic tissue above and beyond plasma cells. As such, hypogammaglobulinemia and infections become quite severe with BCMA, and because it's continual administration with a bispecific, that risk never goes down. In fact, it continues to go up. So other targets, such as GPRC5D, do hold some advantages in that they are not as widely expressed on hematopoietic tissue and therefore have a lower rate of infectious complications. The two key assets that have been investigated have been talquetamab and furimtamig. Unfortunately, in recent days, it was announced that furimtamig will no longer be pursued in myeloma. So at the moment, we're left with the talquetamab bispecific antibody, which is an extremely effective drug. But the other issue to note is that there is additional expression of GPRC5D on other tissues of the body. Notably, it's expressed on the squamous epithelium of the hands and feet, the lining of the oropharynx, salivary glands. So the main toxicities are skin and nail toxicities. Patients get a desquamating rash, which to me looks just like the rash from capecitabine, Xeloda. But perhaps a bigger issue is the dysgeusia, anorexia, loss of taste, loss of appetite that patients have while utilizing this drug. The drug was approved based off of the Monumental-1 study published in the New England Journal from Ajay Chari. And again, just as with the other bispecifics, there's a step-up dosing schema. However, this was approved with two different step-up dosing schemas. One takes you up to 400 micrograms per kilogram, at which point you can continue weekly dosing. Alternatively, you can give an additional step-up dose, bring patients to 800 micrograms per kilogram, and dose them every other week. Again, very heavily pretreated group of patients. Many of these patients had aggressive prior therapies, triple class refractory, many of them penta-drug refractory, refractory to lenalidomide, pomalidomide, bortezomib, carfilzomib, and daratumumab. Some of these patients even having prior BCMA therapy. Now, overall, we saw some of the highest response rates we've ever seen in bispecific antibodies, up to over 73 to 74%, with an extremely impressive duration of remission. And again, we can see this across the board. Now, we note that whether or not you choose the 400 microgram or 800 microgram dosing schema, we saw impressive progression-free survivals, upwards of over a year in some of the studies. One of the things that's quite interesting about bispecific antibodies is that the toxicities of these drugs do not appear to be dose-related, but schedule-related, meaning bringing the dose down from 800 to 400 does not seem to improve toxicity, but extending out the dose from weekly to every other week to monthly seems to mitigate many of the adverse events of our bispecific antibodies. Again, just as we've seen in some of the data from the Majestic trials, for patients who received talquetamab who had prior T-cell redirection, we see about a 10% declination in response rate. So whereas the original Monumental-1 had a 73% overall response rate, here in patients with prior T-cell redirection, we see around a 63% response rate. But again, these patients are still maintaining duration of remission for about a year. Now, again, the main issues that we see with talquetamab are very similar to that of the BCMA bispecifics. We see CRS and icons. In general, CRS with bispecifics, due to their step-up dosing schema, is grade 1 and grade 2, with the overwhelming majority of this being grade 1. And again, giving tocilizumab, especially with its long half-life, will not only reduce the severity of CRS you have now, but prevent recurrent CRS later on. ICONS tends to be a very rare event in the clinical trials with bispecific antibodies. However, it is important to note that in commercial use, we are putting far sicker patients on these therapies than would have been eligible for the original Monumental-1, Magnetism-1, and Majestic trial. In turn, in clinical practice, when you put patients on with very aggressive disease, bulky disease, extramedullary, CNS disease, we see higher rates of CRS and definitely higher rates of ICONS. So aggressive management is really necessary for those patients. Now, to me, one of the most exciting bispecifics out there is the cevostamab study. notably in KAMA1 and KAMA2. And this is the FcRH5 CD3 bispecific, whereas FcRH5 is widely expressed on plasma cells, particularly malignant plasma cells. Now, one of the things that has been an issue in the relapse refractory world of myeloma is that all therapies are to be given in design until progression or intolerance. However, the cevostamab study, specifically KAMA1, was designed for fixed duration therapy. After the initial step-up dosing, cevostamab is administered intravenously once every 3 weeks for a total of 17 cycles and then stopped. Patients are then observed off of therapy and they have the option to be retreated at the time of progression. And every 3-week dosing for 17 cycles, along with the step-up, is approximately 1 year of therapy. And besides seeing impressive response rate, we're starting to get an inkling into what it looks like when we stop patients with T-cell redirection therapy, allow their T-cell repertoire to recover, and then treat them again at the time of relapse. Small numbers, but we are seeing the ability to recapture, although the response appears to be muted compared to their original response rate. Now, data that was presented at this year's EHA meeting by Shaji Kumar has focused on the role of cevostamab as a post-BCMA therapy, whereas BCMA seem to look at the post triple class, now FcRH5 looking at post quadruplet class, including the BCMA therapy. And what was quite impressive about this data was that we see that the overall response rates in post-CAR T patients was 73%. And now that BCMA CAR Ts are moving further and further up, currently approved in first relapse based off of the CARTITUDE-4 study, and likely at some point to be approved as part of our upfront therapy based on studies like CARTITUDE-5 and CARTITUDE-6. There is a possibility that we will have patients relapsing after first relapse or even initial therapy, progressing beyond BCMA. And the big question is, what is the next line of therapy? And seeing a 73% response rate in cevostamab in that group is going to help us out in the coming years. Now, in myeloma, all we do is combine therapies. We love to combine because if one drug is good, 2 is better, and now we love 3 and 4 drug combinations. Well, one of the first areas that looked at this was the Majestic-2 study combining teclistamab with daratumumab, and this was done in an earlier line of therapy with 1 to 3 prior lines. We noted that the response rate here is quite impressive at 93.5%, but it is important to note that the combination of CD38 and BCMA-based therapies can impart significant immune suppression. Data from our site during the COVID pandemic showed that the 2 biggest predictors of myeloma patients not being able to form antibodies following COVID vaccination were anti-BCMA therapies and anti-CD38. As such, we see all-grade infection here is over 90%. So this is a very potent combination, but needs to be met with the appropriate prophylaxis, including antiviral prophylaxis, regular vaccination, and prophylactic intravenous immune globulin. Now, the TRIM2 study sought to use talquetamab with daratumumab, and the benefit here is that there's a lower rate of infection with the GPRC5D bispecific antibodies. We can see here at the 800 microgram dose, response rates of over 84%. And again, this is a very potent combination and maybe a better combination for patients who are progressing on or after BCMA-based therapy, because we note that it takes around 4 to 6 months for cells to re-express CD38. So you can imagine a time where patients get Dara-RVD up front, go on to receive a BCMA CAR T, and at the time of relapse, this may be an appropriate line of treatment. Now, some of the most impressive data that I've seen and we've used in clinic is based off of the data presented by Jeff Mattis from Colorado Blood, looking at the Monumental-2 study combining talquetamab and pomalidomide. And here, we interestingly use pomalidomide not because of its myeloma cell kill, but for its immunomodulating properties. And in clinical practice, giving 2 milligrams of pomalidomide not only reduces the incidence of cytopenias as opposed to the 4 milligram full dose, but here we're using this to augment the T-cell response that's induced by the talquetamab. At the 400 microgram dose, we saw a 94% response rate, which is extremely impressive in the relapse setting. So really need to see longer follow-up with more patients, because so far these are small studies. Now, if we give one bispecific and it's good, what about giving multiple bispecifics? And this has been seen in the Redirect-1 study, which has been presented by Yael Cohen and Mary V. Mateos, who would give talquetamab and teclistamab. And note that the dose of teclistamab is a bit higher than the current approved dose. It doubles it up to 3 milligrams per kilogram. This is in efforts to improve the PK/PD data about extended dosing schedules. In many ways, we can get this up to once-a-month dosing. Now, this has been an extremely effective regimen, including response rates of over 96%. Where it seems to have particular efficacy is in the setting of extramedullary disease. Now, this is in some of the hardest disease to treat, myeloma that lives outside the marrow. But in a subcohort of the redirect study, we showed over an 86% response rate in patients with extramedullary myeloma. So this type of aggressivity may be needed for patients who present with numerous plasmacytomas. Now, really at the end of the day, symptom management, toxicity management is key to success with bispecific antibodies. And here we see a list of the rates of infections across the different trials. And again, most of these are monotherapy, but once we start combining drugs, we do have a risk of increasing infection. Particularly focusing on regimens such as single agent teclistamab had not only an overall infection rate of around 76%, but a grade 3 or higher infection rate of 45%. So it is not uncommon to have to deal mostly with upper respiratory tract infections, pneumonia, and bronchitis with anti-BCMA bispecifics. So we need to prophylax with IVIG to markedly reduce this. The other issue is the utilization of white cell growth factors can help prevent high-grade neutropenia. There's a question of using with caution in that patients who are receiving step-up doses with bispecific antibodies who have not yet had CRS and received tocilizumab, you may run a risk of propagating CRS with white cell growth factors. However, once tocilizumab is on board, the risk of this is essentially zero. Now, CRS grades can be quite profound, and in many of the studies, CRS rates were as high as over 90%, albeit the majority of this was grade 1, grade 2. Now, there have been a few areas where we've seen improvement in CRS. Linvoseltamab has shown some of the lowest rates of CRS, between around 30 and 40%. Additionally, there have been a number of studies looking at giving prophylactic tocilizumab. And in the cevostamab study, the E1 cohort presented by Suzanne Trudel, prophylactic tocilizumab reduced CRS rates from around 96 to 30%. And in the Majestic studies with teclistamab, prophylactic toci reduced CRS rates from around 76 to 25%. Overall, it's important to note that besides CRS, ICONs, infections, cytopenias are certainly seen across the board. And additionally, anytime you're activating T cells, we do run the risk of not only CRS and ICONs, but also once the cascade is set off, we see activation of macrophages and macrophage activation syndrome, and even HLH has been seen. There's no clear pattern. However, it does appear that patients with higher burden disease will have higher risk of having some of these difficult toxicities like HLH, macrophage activation syndrome. The difficulty is, how do you debulk a patient prior to a bispecific? Because if you use classical chemotherapy and give a regimen like DCEP, those therapies are T-cell cytotoxic, and then you may not have a good response with your T-cell redirection therapy after that. So really, how do we prevent all of this? We try to mitigate cytopenias with standard supportive care. We recommend primary prophylaxis for hypogammaglobulinemia. This is different from daratumumab, where we wait until you have an infection. We start right in the beginning. The one caveat is that if you have IgG subtype myeloma and you're starting a bispecific antibody and your IgG is very high, you need to hold off on IVIG to reduce the risk of hyperviscosity. But once the IgG comes down, it should be started as soon as possible. Make sure patients get HSV and PJP prophylaxis throughout their treatment. Make sure vaccinations are up to date. Very controversial about whether or not to provide bacterial prophylaxis during the initial dosing. Our standard of care is not to provide antibacterial prophylaxis. However, for patients who suffer from prolonged neutropenia, it may be worthwhile to provide either bacterial prophylaxis or fungal prophylaxis, but routinely it is certainly not necessary. The biggest things is vaccination up to date and IVIG. And with that, I will thank the audience very much for listening and happy to take any questions.
Thank you, Joshua. Any questions from myeloma expert? Yeah.
Thank you so much for this comprehensive talk. I have a specific question about teclistamab. In your practice, which group of patients do you space up the dosing? And have you done any spacing beyond 2 weeks, for example, every 3 weeks or 4 weeks?
Absolutely. So I think this is a wonderful question. So teclistamab, we recognize that for a number of reasons, spreading out the dose is very helpful because it likely reduces the incidence of infection and patients prefer it, and it may provide better help for T cells. One of the ways that we are trying to do it at the moment is we're going to mostly monthly dosing. And the way we're getting there is to follow the daratumumab step-up dosing schedule. And in turn, the Horizon-1 and a variety of ongoing trials are mimicking daratumumab. So in general, 2 months of weekly dosing, then 4 months of every other week dosing. And after that, we continue with monthly dosing the same way daratumumab is given.
No more question. Thank you, Joshua, for being with us. Hopefully, we'll see you physically here in Saudi Arabia.
Would love that. Thank you so much.
Thank you.
Thank you. We'll move to next speaker, Dr. Mohammed Al-Makadi. He's a hematology BMT cellular therapy at consultant at King Faisal Specialist Hospital, Medina. Dr. Makadi, he completed his BMT and hematology fellowship at McMaster University, Canada. Dr. Makadi will talk about relapsed refractory CLL.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Askar and the organizer for having me at this great event. And allow me also to say welcome to Medina. I'm really happy to have such, or be part of such an event in Medina. So these are my disclosures. So I'll be going quickly through these three main items of the agenda, and I'm hoping at the very end I'll be able to convince all of you that relapsed refractory CLL is indeed or can actually be a terrible disease. So starting from like 1840s, this is when it was first described as having, so patients will present with elevated white cell count and lymphadenopathy. Later on, this condition was actually termed lymphosarcoma because of the presence of spleen and bone marrow involvement. So generally speaking, when we define CLL, it's an indolent clonal B lymphocytic disease or neoplasm. It's actually instigated by a genetic mutation that is later on fueled by continuous antigenic stimulation, which will lead to further genetic and epigenetic dysregulations, which ultimately will cause imbalance between stimulatory and inhibitory pathways, including apoptosis. So normally, for normal B lymphocytes, they actually go through two phases. The first phase is antigen independent, which happens where they're actually formed in the bone marrow. And during this phase, as they mature and proliferate, they go through the most important step for B lymphocytes to function, which is the rearrangement of the immunoglobulin heavy chain. That rearrangement is very important for the function of the B cell receptor for these lymphocytes. Initially, the heavy chain becomes rearranged, and then later on, the light chain becomes rearranged. And only after they are ready to be released into the peripheral circulation, which is judged by how reactive these BCRs are, they get released. Otherwise, if they have high affinity for antigenic stimulation, they'll have to undergo further modification or even clonal deletion. Whereas in CLL, which is the abnormal counterpart, somewhere across the hematopoietic stem cell lineage, they acquire a mutation, and that mutation will instigate the process of CLL. Generally speaking, we can divide CLL into like two subtypes. One subtype with mutated or unmutated immunoglobulin heavy variable chain. Heavy chain, immunoglobulin heavy chain. So you can see here, I don't know if this actually points, but at the lower of the diagram, this is where unmutation happens. It's before the germinal center, before the germinal center assignment of these lymphocytes where they undergo antigen stimulation. So this is why we call them naive B cells. So they're also even T cell independent. And this is how this type of CLL develops. And then the other subtype is post-germinal center, where they have been exposed to antigens. And then this is how they evolve after that. And then further evolution, as I mentioned before, depends on more antigenic stimulation through the BCR receptor within the microenvironment. And this is how the disease will progress from monoclonal B lymphocytosis to florid CLL. This is actually a very interesting study where they actually isolated CLLs from 3 different sites, from the peripheral blood, from the lymph node, and from the bone marrow. And they've done gene expression profiling for those cells. And they found the pathways are actually different depending on the niche or the environment they're actually residing in. You can see how more than 100 genes can get upregulated in the lymph node, and how CLLs within the bone marrow tend to actually have or downregulate apoptosis. This is how the BCR looks like. You can see how the immunoglobulin heavy chain makes an important part of this structure. The solid line is basically how normal antigenic stimulation goes through. It is basically dependent on 2 important kinases, which are the SYK and the LIN. The dash line here at the bottom, this is what they call it tonic or autonomous stimulation, which is mainly regulated by the PI3K. In either ways, this is very important for the function. So now you would understand why, when this immunoglobulin heavy chain is mutated, this process becomes slower. And this is why unmutated immunoglobulin heavy chain, they actually utilize this signaling much more abrupt. So the burden of the disease, prevalences of CLL, according to the American Cancer Society, is around 180,000. So around 21,000 are diagnosed every year with a death rate of around 4,000. And then we all know that it's mainly a disease of older population, but we also see it in younger population. So generally speaking, this is just a summary of how does the CLL fate looks like. You can appreciate from these gray tables, it shows how the molecular pathways changes. They become more upregulated, or they acquire a new one as the disease progresses, especially when they're exposed to therapy. So we can generally divide CLL fate after exposure to therapy into either relapse after chemoimmunotherapy or after targeted therapy. And we shouldn't also forget the talk we just heard, evolution into Richter transformation, which can happen either de novo or following exposure to therapy, commonly BTK inhibitor. So since 2012, MRD has become a hot topic in CLL. So the A graph is showing MRD measurements interim from the peripheral blood, and on the B graph, this shows the MRD measurement at the end. And then on the C graph, this is from the bone marrow, and you can see the blue line, the deeper the MRD, the lower the likelihood of disease progression. And I just want to remind you of the response criteria because I'm going to also show you much more exciting studies on MRD. So according to the international workshop, this is how complete remission and partial response is defined. Complete remission with incomplete count recovery. So they actually have, so in another study, which is not too far from the first one in 2016, now the focus now is only at end of therapy, so they're showing the same results at the end of therapy. If the patient achieves an MRD of less than 0.01% or less than 10 to the power of -4, the chance of disease progression becomes less. What's actually more interesting is this seems to be also applicable for partial responders. So they have identified this unique group of partial responders who, so they will fulfill the criteria for the nodal, but they wouldn't fulfill it, but they still have an MRD negative when you measure the peripheral blood. They actually seem to behave much better than complete remission with MRD positive disease. And this was also shown again in a just recently published study using 12 RCTs from the German CLL group, again showing the same thing, but they added the benefit of targeted therapy. So the blue line here is undetectable MRD with targeted therapy. You can actually see they actually do better than with chemoimmunotherapy, which is the blue line. This when it comes to PFS and overall survival. Sorry. And the last figure on, which is D here on the right side, it actually shows that incomplete response, if they achieve MRD, their behavior is closer to complete response with undetectable minimal residual disease or measurable residual disease. This is where we actually thought we achieved the standard of care for CLL. This is the CLL-10 study. We all know this study that continued to show FCR to be the standard, and people have made even a recommendation, which you can see on the figure on the left, that shows a flat line for young patients with mutated IGH, that this could be an option for them to give them FCR. But this should also be thought against the potential toxicities of these regimens, especially the risk for AML and MDS. But a few years later, targeted therapy has established themselves to be the standard of care. So I'm only going to show the studies that have compared them to FCR or like a standard of care regimen at that time. You can see how ibrutinib outperformed FCR, whether it's young patient or older patients, and this was also the case in second generation BTK inhibitors. Even when you go to BCL2 inhibitors, you can also achieve such an amazing response following fixed duration. So this was very exciting when it was published, because we can now offer to our CLL patients fixed duration of therapy and then monitoring. Even off therapy, you achieve better response in comparison to other modality of care, as you can see here. So why am I bringing this? Because this is very important to know or to put in your mind when you are managing relapsed disease. We like to always risk stratify patients when they come to us. I find this a very exciting way of, or interesting way to risk stratify. So the BALL score or the BALL score utilize beta-2 microglobulin, LDH value, and then the hemoglobin value depending on women or for men and women, and how long the time is from last therapy. Interestingly enough, you can actually show an overall survival concern for the higher risk group, which scored positive on all of these. You can see that unlike what we have seen in these targeted therapy trials, the overall survival is actually shorter if the patient has higher risk manifestations based on this scoring. So the patient comes to you and he or she has a relapse or refractory disease. It doesn't mean you have to treat right away. They still have to have an active disease using the same criteria we use for de novo patients or patients who are coming for the first time. So once you actually decided that they are active, so treatment is indicated, then these are the options you have to consider in your mind. Have they been exposed to prior chemoimmunotherapy or BCL2 inhibitors or covalent BTK inhibitors or others? Majority of the studies that you came across are based upon patients who've been exposed to prior chemoimmunotherapy, which is not something we will see these days commonly, as most of them now are on targeted therapy. So I'm going to have to skim through them quickly just to get the idea of what is the level of PFS that happens even when you use targeted therapy in patients who've been exposed to chemoimmunotherapy. So starting with acalabrutinib in the ASCENT trial, you can actually see that the PFS tend to be a little bit shorter than what we have seen when we used acalabrutinib in patients who are treatment naive, yet it is much more significant even in comparison to bendamustine-rituximab. I know it's not the right comparison when we're thinking about treating those patients. So that PFS was observed in another drug. I'm just going to show this one first. In another drug, which was zanubrutinib, you can actually see that it is superior than using ibrutinib in relapsed refractory patient. The study I skipped, it was just to show that relapsed refractory disease is terrible. And when you add on top of this 17p deletion or TP53 mutated or even 11 deletion 11q, the PFS is almost shortened by 50%. And then in the last trial here, which was the Murano trial, again, those are not the type of patients you will be seeing. They've been treated with chemoimmunotherapy. So if you compare venetoclax-based regimen versus bendamustine, you're still going to get similar PFS that you will get with other targeted therapy. However, it tends to be a little bit less toxic, especially in patients with limitation due to cardiac diseases. And what I liked in this paper also, again, it's the trend of MRD. You've heard this also in the previous talk. Because of the data here, people have always had this idea that using venetoclax can allow you to achieve a negative MRD. So even in those relapsed patients, around 63 of them was able to attain undetectable MRD, which correlated with better PFS. So to summarize, these would be your options in somebody coming to you with chemoimmunotherapy, relapse. You could choose between covalent BTK inhibitor or BCL2, depending on the patient's own preference and risk factors. How about if the patient comes to you with a relapse disease after BCL2 inhibition? We've known the need to go for BCL2 inhibition because of these specific characteristics. You could achieve undetectable MRD, and then you can have a treatment-free remission. Cost saving, you could argue it could. And then biologically, it is believed when you give them a treatment-free period, you withdraw the selective pressure for any resistant clone. But people have described the resistance mechanisms in BCL2 inhibitors. So these, it can either be BCL2 related mutation or using an alternative pathway or acquisition of other mutations. There are studies which I'm not showing here that comparing the second generation of BCL2 inhibitors and how they can overcome some of these mutations. But generally speaking, you could still try BCL2 inhibitor retreatment. So the studies I'm going to share with you, they're very small. They're not larger scale like the ones from before, so it's very hard to draw strong conclusions out of them, but it is possible to achieve longer progression-free if you retreat with venetoclax, especially if that recurrence happened in longer than 24 months. The reason why I'm saying this, you'll see this in the other study, which is another option to treat those patients, giving them covalent BTK inhibitors. So this is around 40 patients, retrospective, single center. You can see that if the venetoclax response lasted longer than 24 months, they will do better. If it is shorter than that, they will do worse, even if you use BTK inhibitor, which people will argue it is a little bit more efficacious than BCL2 inhibitor. So to summarize, patients with relapse after BCL2 inhibition, you could consider retreatment with the same regimen. With or without rituximab, some people, they still prefer to add rituximab or obinutuzumab, which is a monoclonal antibody against CD20. It has actually good biological benefits because any of these pathways that are trying to develop around the CLL cells or within the CLL cells while being exposed to venetoclax can actually sometimes be lessened with the exposure to monoclonal antibody. The other option is switching or sequencing to covalent BTK inhibitor. This is actually the way I see it, it's the worst phenotype. So relapsing after a BTK inhibitor, you really have to be patient before you make that diagnosis because anything can happen. Flare of CLL, patient maybe was non-compliant. So you really have to determine it is relapsing or progressing based on multiple occasions, especially if unless it was a transformation. So before you call it a progressive disease, it has to be on multiple occasions. And even when you say they're actually progressing or relapsing, you should never stop BTK inhibitor because there is always a risk of tumor flare. It has to be continued until the second intervention is going to be initiated. So again, smaller size studies, I don't think you need to mind the BCR naive group. So focus on the columns from the BCR treated. So BCR inhibitor treated group in this study, which is a little bit bigger, they actually, when you look at the table, those agents were either ibrutinib or idelalisib. You can still, again, achieve CR and PR in this difficult patient population if you treat them with venetoclax as an option. You can actually see also here almost similar PFS to the other studies from before. However, BCR inhibitor experienced group tend to do a little bit worse as we may expect. So what other options you would give to those patients? This is just an animation of how the BTK looks like. So the blue shape is the non-covalent BTK inhibitor, which they don't need to rely on this molecule for the covalent bonding. If that patient acquires a mutation in this covalent bonding, the common one being C481S, it will lead to abrogation of this bonding, and this will almost make the effect of covalent BTK inhibitor limited or negligible. Whereas non-covalent BTK inhibitor, they don't need to rely on this bonding. A good example of them that was studied in the Bruin's trial was the birobrutinib. So the upper information here is just related to how they selected the dose. The dose that was selected for the phase 2 study was 200 milligram. And then these were their primary and secondary endpoints. Those are very heavily pretreated patients. And despite this, the drug itself is very clean, very minimum side effects, especially cardiac side effects. And you can see the response is actually impressive, reaching 82%. And majority of those patients appreciated by the by the blue bars, it was actually discontinued due to true refractoriness. The orange bars are the one who actually discontinued due to intolerance or toxicity. Reasonable PFS can be achieved using a non-covalent BTK inhibitor in this heavily pretreated patients. It received an accelerated FDA approval. And just to appreciate how the effect of multiple lines of therapy, we're now hearing studies thinking or planning on using it slightly more upfront than than as a third-line therapy or fourth-line therapy. So in patients who've been exposed to covalent BTK inhibitor and they relapse, if you have access to mutation testing, you could do the testing, but these usually are the options that could achieve a response. Either you use BCL2 inhibitor or non-covalent BTK inhibitor. This last category is been described, double or triple refractory. There's no specific definition for it because even CD20 inhibitors are actually counted as a class. So, but true double or triple refractory options are actually limited. I put a question mark before PI3K inhibitors because there are some studies showing this pathway may get upregulated. So people have used it, but the longevity of response is very short. In either case, when you are dealing with prior BCL2 inhibitor or BTK inhibitor or double or triple refractory, you really have to consider allogeneic stem cell transplantation using reduced intensity conditioning. I put a dashed line for the patients with prior chemotherapy in case fludarabine was used, because there is enough literature about how high risk the disease can become if they are refractory to fludarabine. But with these other targeted therapies, it is now, I should say, not a strong, but a strong suggestion / mild recommendation that you should proceed for allogeneic stem cell transplantation once you achieve response following your salvage or your second sequence of therapy, as shown in the previous talk for rectal transformation. The status of the disease before transplant could inform longer outcomes. However, the two studies I came across, there was no difference depending on the lines of therapy, disease biology, or status of the disease on allogeneic stem cell transplant outcomes. The 3-year PFS is around 75%, and the 3-year overall survival was around 80%. So with that, I will conclude with my take-home message. So targeted therapy, we know that they have significantly improved disease outcomes in CLL. However, we have seen the results when the disease relapses. How do we measure relapse, or how do we estimate or predict the possibility of relapse? I think MRD measurement will likely become the new standard, because we've seen how it behaved regardless of complete remission or partial response attainment. And I have shown you some of the results and how exposure to targeted therapy, although it has resulted in great PFS and overall survival benefits in comparison to chemoimmunotherapy, what comes after that is a very aggressive disease. And then I have mentioned to you that the importance of making sure before you commit to that second line of therapy to ensure the disease is active, and whether or not sequential therapy is clear. We don't actually have studies with high number of patients, and with the limited body of evidence that we have, it is durable, the response you get this, but I would recommend you utilize this durability to prepare this patient for much more definitive therapy like allogeneic stem cell transplantation. Thank you very much.
Thank you, Dr. Makadi, for comprehensive overview. We can take one question because we passed our time. As no question, we can conclude. Thank you all. We want to thank organizer. We have an announcement. Please, you are invited to the stage for a photo group. Dr. Alaska.
Good afternoon, everyone. I'd like to start the next session for today. أنا حوقف هنا وقت الأسئلة. Okay, so this satellite symposia is sponsored by Roche, and it will be in the changing treatment paradigm in relapsed refractory diffuse large B-cell lymphoma with the use of bispecifics. The speaker will be Dr. Martin Hutchings from Denmark, and we'll start now.
Hello, my name is Martin Hutchings. I'm a senior consultant at the Department of Hematology in the Phase 1 unit at Rigshospitalet in Copenhagen, Denmark, and a professor of hematology at the University of Copenhagen. I'm very grateful for the invitation to this meeting and I'm happy to share with you some of my thoughts about the management of relapsed and refractory diffuse large B-cell lymphoma, including a focus on the bispecific antibodies, which I've worked with in the last 7-8 years. These are my disclosures, some of which are relevant to the content of this talk. First, a bit of background. This is the PALMA trial, well known to all of you, published almost 30 years ago, but no longer relevant in the current era because it included only chemosensitive patients and it only included patients naive to rituximab, which made a big difference, and the promise of curing 50% with chemotherapy in second line no longer holds. We know that from several studies, including the ones shown here, the CORAL study, ORCHARD, and the LI-12 study, all attempting to find a better induction chemotherapy prior to autologous transplant, but failing to do so, and on to of that showing that in patients previously exposed to rituximab, which means 100% of patients nowadays, the chance of cure is at best 25% if the patients are late relapses, so there is and probably only 10 to 15% if the patients are primary refractory or relapse within 1 year of completion of first-line chemotherapy. Steps forward. So there is a great unmet need, not only in second, but also in later lines of treatment of this disease. But in recent years, we've seen quite a few significant steps forward. I'll mention a few of them. This is the study, randomized phase 2 study of polatuzumab vedotin plus rituximab bendamustine versus standard rituximab bendamustine, which is arguably not the greatest standard arm in this setting, but still something that we occasionally use in elderly and frail patients and patients accepting other options. Now, this study, as you can see, showed a really meaningful difference between the treatment arms, both when looking at progression-free survival, which I show here, in favor of the polatuzumab-containing arm, but actually also a statistically significant benefit is not looking at overall survival. The patient group treated here was not the worst prognosis, but still 40% complete response rate, with some of these being quite durable, is not a bad thing in this difficult to treat situation. Similar things could be said about the L-MIND study. That was not a randomized study, it was a single-arm phase 2 study of the anti-CD19 naked antibody tafasitamab, which in combination with lenalidomide also led to complete responses in 40% of patients. And as you can see in the graph showing the progression-free survival according to depth of response, the complete responders actually quite long in many cases. And of course, in this case, lenalidomide was given for 12 months, tafasitamab was given until progression. So, of course, we cannot say that this has a curative potential, but still really deep and, in many cases, lasting responses. Targeting CD19, not quite so high complete response rate was shown in the phase 2 study of loncastuximab tesirine, which is an ADC targeting CD19 and using the tesirine payload. 48% of heavily pretreated and high-risk patients responded, including 24% with complete responses. And as you can see in the progression-free survival curves on the right and the duration of response curves on the left, the complete responses were, in many cases, quite meaningful and highly durable. And in this study, treatment was given up to a maximum of 12 months. So perhaps a small curative potential among the patients reaching a complete response. But the real revolution in the last 5 years has been the introduction of the CAR-Ts, all targeting CD19, at least the hitherto approved ones, and showing more or less the same results. I'm showing you here data from the ZUMA-1 study of axi-cell in relapsed refractory large B-cell lymphoma. Patients going into this study had at least 2 prior lines of therapy, and 2/3 of the patients had been refractory to the most recent therapy. Yet responses were seen in over 80% of patients, including 58% with complete responses, and you can see progression-free survival at more than 2 years of follow-up was around 39%. And in an indirect comparison with historical data from the SCHOLAR-1 study, where patients were treated with conventional chemotherapy, you can see that at least in this indirect comparison, there is a massive benefit in favor of the new method of treatment. And similar results that I don't show were shown in the Transcend study of Lisa-cell in the same indication, and the Juliet study of Tisa-cell also in the same indication. And these 3 CD19 CAR-Ts have been approved in most recent regions globally and reimbursed in some for the treatment of large B-cell lymphomas with 2 or more prior lines of treatment. And with such good results, it was only logical to try and introduce CAR-Ts also in the second line, because as I just showed you, the outcomes for conventional chemotherapy-based treatment are in most cases quite dismal. So this is the ZUMA-7 study, a randomized study, where the experimental arm was axi-cell CAR-T, and the standard arm was chemotherapy induction followed by high-dose chemotherapy with autologous stem cell support. You can see that the primary analysis was grossly in favor of the experimental CAR-T arm, with event-free survival at 2 years over 40% in patients treated with CAR-T, and the expected 16% among patients treated in the chemotherapy-based standard arm. So this study, as well as the Transform study, a similar phase 3 study of Lisa-cell versus chemotherapy standard of care, have led to the approval of these 2 CAR-Ts also in second-line treatment of patients with either primary refractory disease or relapse within 12 months of completion of first-line chemotherapy, because these were the patients who could be included in the phase 3 studies. Later, we've seen the introduction of the bispecific antibodies. The clinical work with these antibodies has been going on for a while now, but more recently we've seen data coming out of the pivotal phase 2 studies of some of these CD3, CD20 bispecific antibodies. This table is just an overview of the characteristics of the patients going into these phase 2 studies, and I'll point your attention particularly to the studies of glofitamab and epcoritamab, which are the approved agents in most regions, and I'll show you how strikingly similar and how quite high risk these groups of patients were. Just over 150 patients in both studies. The median range line of therapy is 3, around 60% with primary refractory disease, just around 85% of patients with refractoriness to the most recent treatment line, so significantly more than in, for example, the ZUMA-7 study, and around 1/3 of patients with exposure to prior CAR-T and failure, obviously, of that CAR-T. And also tested in large B-cell lymphomas. But first, the results from the phase 2 study of mosunetuzumab, which has been approved for treatment of follicular lymphoma, and also tested in large B-cell lymphomas. As you can see, responses were seen in 42% of patients, including 24% with complete responses. And even though 10 years ago these response rates would have been very promising in large B-cell lymphoma relapsed refractory disease, this has not been sufficient to continue the development of simposia in the aggressive B-cell lymphomas. Odronextamab is another CD3, CD20 bispecific antibody which has continued development in this space. It has had a rough ride through phase 1 because it had quite a lot of toxicity with high frequency and grades of cytokine release syndrome, also ICANS, but with a very complicated step-up regimen over 5 different dose ranges, where the first 3 doses have to be given in split doses over 2 consecutive days. It has been successfully been achieved that the CRS rates have come under control, and we now see the readout both of safety and efficacy, showing a 49% overall response rate, including 31% with complete responses. Odronextamab so far in development and also in the phase 2 studies from which I showed data here has been given until progression. So the duration of complete response curve on the right is perhaps not so encouraging since you see no development of a plateau despite treatment being given until progression. These drugs. So I'm jumping to the antibodies with which I have experience, that's glofitamab and epcoritamab. And just to give you a taste of the activity of these drugs, I'm showing you one of the first patients of mine with a meaningful clinical response to glofitamab. So he was treated in the phase 1 study in the relatively early days of the phase 1 study, where we still gave patients flat doses, no step-up dosing, which has later been introduced into all the different bispecific antibodies. And this is to reduce the risk of high-grade cytokine release syndrome. So at this point, after this guy was 42-year-old, he had a chemorefractory, relapsed refractory large B-cell lymphoma, and after the first he developed dose of glofitamab, which I believe was in the low milligram ranges, so approximately 10-fold less than what is now the recommended dose. He developed a mild cytokine release syndrome, but also severe tumor pain in his tumor sites, and also a Horner's syndrome developed over the first 12 hours of treatment, which is really interesting. You could see a tumor flare from his tumor compressing the sympathicus during the night following the first infusion. He was, as you can see, after 2 cycles in a very deep partial response, and the only remaining bit of his disease at the end of his 8 cycles of treatment was a little bit of pit posture disease in his left supraclavicular region, which we irradiated, and at this point, 5 years after the end of treatment, he's still in a complete response, despite receiving, like I said, a dose which is about 10% of what we now will give patients with glofitamab. So I jumped to the phase 2 study of glofitamab, which has led to the approval of that drug both in the US, in Europe, and in many other regions in the world. This study, like I showed you before, including just over 150 patients, and they were, as I already described, very high risk, difficult to treat, and highly refractory. You can see on the left the key inclusion criteria, at least 2 prior lines of treatment, including an anti-CD20 antibody and an anthracycline. They needed reasonable performance status, reasonable organ function, and they would be treated not only with step-up dosing, 3 consecutive increasing doses during cycle 1, but also, like all of the patients, treated with glofitamab, pre-treatment with obinutuzumab, so naked anti-CD20 antibody, 1 week before the first dose of glofitamab, in order to deplete peripheral B cells and reduce tumor burden in order to avoid high-grade cytokine release syndrome. You can see here a diagram of the antibody. It doesn't look like most IgG-based antibodies in that it has 2 epitopes for CD20 and 1 for CD3, so it's 2-to-1 format, unlike all the other CD3, CD20 antibodies, which I will describe. In this phase 2 study, we had already learned a lot about toxicity and how to avoid it. So cytokine release syndrome, which is the dominant acute toxicity of the bispecifics, was really quite controllable, with CRS seen overall in just under 2/3 of patients, but the vast majority of cases of grade 1 and very few cases of grade 3 to 4 cytokine release syndrome, which is where it gets really tricky to treat. You can see that almost exclusively it's during cycle 1 and on cycle 2, day 1, that we see CRS. This is the first pass phenomenon, and after the first 3 to 4 weeks of treatment, we practically do not see it anymore. At that point, the side effect profile is taken over by other things, particularly cytopenias and the occasional infections that we have to struggle with. Despite glofitamab being given, responses in this phase 2 study were seen in 52% patients, including 40% with complete responses. And you can see that despite glofitamab being given for a fixed duration of time, maximum 12 cycles, equaling 8.3 months, we still see durability. We see that among patients reaching a complete response, approximately half still maintain that complete response 2 years after the end of treatment, which is really quite impressive regarding how sick and refractory these patients were going into the study. These are charts showing progression-free and overall survival for patients according to depth of response. The dark blue curves represent patients reaching complete responses, and I think it's a testament to the clinical meaningfulness of these responses when you look at the overall survival curves, how significantly different they are from the overall survival of patients reaching only partial response or no response, because remember, these patients would expectedly be treated in places where patients would have access to excellent standard therapy and also other experimental options. So these responses are not only deep and durable, they are also clinically really meaningful in my eyes. This is a landmark analysis of progression-free and overall survival, where survival is counted from the end of treatment. And this is really quite useful when we sit in front of our patients, because some patients I treat with epcoritamab, they are treated until progression, others with glofitamab, and sometimes the glofitamab-treated patients wonder why you stop treatment when the other patients get to go on until progression, and vice versa. And then you can show them these landmark analyses showing that when you stop treatment, if you're in complete response, this is the case for about 40% of patients, your chance of being alive and progression-free still after 2 years is about 50%, which is really quite encouraging. This is another patient treated with glofitamab. Now, this patient was treated a little bit later, more elderly than the other patient, 69 years, treated for a follicular lymphoma, given 3 prior lines of treatment, to which he had been refractory to the 2 most recent lines. He was treated in late 2018 and 2019 with glofitamab, and at that point, treatment was given at what is now the recommended phase 2 dose. He had a mild CRS of grade 1, despite having a very high tumor burden. As you can see, he went into a deep partial response after 2 cycles, which transformed into a complete response after 5 cycles, and at the end of the 12 cycles of treatment in June of 2019, he was still in a CR, which lasted for more than 2 years. And it lasted until he unfortunately died from chemotherapy-related myelodysplastic syndrome, which transformed into acute leukemia a couple of years later. Like I showed you. Now moving on to epcoritamab, another CD3/CD20 bispecific antibody, also studied in a recently published phase 2 study. Like I showed you, a very sick population also going into this study, and also manageable safety. You can see here that, again, just over half of the patients getting to some kind of cytokine release syndrome. But again, like in the case of glofitamab, the vast majority of patients with CRS of grade 1 or 2, which is highly manageable and very rarely beyond grade 2. Unlike glofitamab, where we see most cases of CRS after the priming dose, which is in the milligram range, after treatment with epcoritamab, most cases of CRS are seen 2 weeks into treatment, which is when the first full dose of epcoritamab is given, and that's probably because the priming and intermediate doses of epcoritamab are in the microgram range, so they probably serve more as tools for B-cell depletion, like the obinutuzumab pretreatment, than as actual tumor reduction. So the first real effect that we see after epcoritamab is after the first 2 weeks. But the effect is good. We see responses in this phase 2 study in 63% of patients, including 39% with complete responses. So more or less like glofitamab. The durability also looks a little bit similar, maybe a little bit shorter than glofitamab. The median duration of complete response is around 20 months versus 26 months for glofitamab. But also the comparison is a little bit tricky because, like I've already said, epcoritamab is given until progression, so it's a little bit difficult to compare the durability, and certainly difficult to state anything about curative potential when you treat until progression, whereas there is a strong hint, in my eyes at least, that glofitamab cures some of our patients even as a single agent. I'm just showing you quickly that there are new kids on the block. This is a drug called TNB-486, now AZD-486, because it's been purchased by AstraZeneca. We have early results from the phase 1 study of this compound, also in different difficult to treat B-cell non-Hodgkin lymphoma populations. And you can see that even though these are really quite preliminary data, it's impressive to see response rates of 75%, including 50% complete responses in patients with relapsed refractory diffuse large B-cell lymphoma. But there are large phase 2 expansion cohorts ongoing where patients are treated with this. Now, moving on in diffuse large B-cell lymphoma and follicular lymphoma, it'll be interesting to see updated results from this study. Bispecifics is not only. Now, moving on to perhaps the most interesting part of my message today, which is the combination study. Because what is so brilliant about the bispecifics is not only their unique mechanisms of action and very distinct way that they work, and also very distinct side effect profiles, which means that not only can they use used effectively as single agents, they are also very easy to combine with almost any other antineoplastic agent that we use in the lymphoma space. And we can basically just let ourselves be limited by imagination and fantasy, because they can be combined with chemotherapy. We might not support the mechanism of action, which is based on T-cell activity, but still it can be additive, as we have already seen in many cases. We can combine them with more novel agents, ADCs. We can combine them with co-stimulatory, which have some T-cell modulatory function and also anti-lymphoma effect in themselves. We can combine them with co-stimulatory molecules. We know from the development of the CAR-Ts that they did not work particularly well until co-stimulatory signals were inserted into the CAR-T molecules. And maybe we should do the same thing with the bispecifics, adding CD28, 4-1BB, what have you. We can also combine with small molecules, tyrosine kinase inhibitors, particularly in the space of CLL and mantle cell lymphoma. It would be very logical to combine with the BTK inhibitors, for example. So let's just go for a few examples. I promise to not show you everything that's going on in these clinical development plans. This is the very complicated development plan for the ongoing studies of glofitamab and the even more complicated development plan for epcoritamab. So of course, I've had to choose a few ones of my favorites, and this is one. So this is a study of glofitamab combined with polatuzumab vedotin in relapsed refractory large B-cell lymphomas, including an enriched population of high-grade B-cell lymphomas, where we have early in the course of this study found surprisingly and encouragingly high activity. But you can see that epcoritamab is given in the fashion I already showed you. So a three-step of dosing. We start with obinutuzumab on the first day of treatment, but as something new here, we insert polatuzumab vedotin on the second day, so in the week prior to the first dose of glofitamab, and then for the first 6 cycles, polatuzumab is given alongside glofitamab, and then for the next 6 cycles, glofitamab is given on its own. Inclusion into this study was for large B-cell lymphoma patients. Performance status could be up to 2. So one prior line of therapy was enough if the patients were truly refractory and without meaningful chemotherapy-based standard options. We still see very encouraging. So look at the results here. It looks as though even though there's no biologically meaningful synergy between these two compounds, we still see very encouraging additive efficacy with responses seen in all patients of 80%, including 60% with complete responses. And I think it's interesting to see that in the relatively high group, number of patients with high-grade B-cell lymphomas, still responses in 73% more, including complete responses in 57%. And I will direct your attention to the upcoming ASH meeting, where we are giving updated, and I can promise you even more encouraging results with much more patients treated from this study. And another favorite of mine is the Alpha study, where we combine glofitamab with the co-stimulatory bispecific molecule targeting CD19 and 4-1BB. It's called Imlumafus Alpha. I promise you, you will hear more about this molecule in due time. It's combined with glofitamab in a slightly different way than polatuzumab. We give the standard cycle 1 obinutuzumab pre-treatment, then step-up dosing of glofitamab, and then we add the co-stimulatory signal in cycle 2 and give it for the full 12 cycles along with glofitamab. This is based on very strong preclinical data showing, at least in the mouse models, very strong synergy between glofitamab, which is where you see the tumor control rate depicted by the red curve, and glumafast alpha, where you can see the tumor control rate of the combination depicted by the purple curve. So with these encouraging preclinical data, it was a joy to start treatment with this drug approximately 5 years ago, first in combination with obinutuzumab, and later, as I show you here, in combination with glofitamab. We are also at this year's ASH privileged to show updated results, which are really quite encouraging. Here I can only show you what we have been able to present so far, the most recent data presented in the summer meetings of this year by Frank Morschhauser, and you can see that it's hard to compare indirectly, but complete response rates of over 50%, irrespective of number of prior treatment lines, and irrespective of prior risk factors, and almost 50% complete response rates, even in patients with prior exposure to and failure of CAR-T. And we believe this is because we, with the 4-1BB co-stimulatory signal, as we show in these pharmacodynamic biomarker studies, we revert the expected fatigue of the T cells occurring during and late during and after completion of treatment with glofitamab, thus not only boosting the depth of response, but particularly the durability of the effect. The same idea was behind the phase 1b study of the combination of glofitamab and another bispecific co-stimulatory molecule, in this case targeting CD19 on the B cells and CD28. And this has actually shown promising both toxicity signal and preliminary efficacy. But this program has been discontinued as the sponsor and us investigators focus on the development of glumafast alpha together with glofitamab. 2-to-1 randomization. Earlier this year, we saw the presentation, the much awaited presentation of the randomized STARGLO study. So STARGLO was a randomized phase 3 study with a 2-to-1 randomization between the experimental arm, glofitamab GemOx, and the standard arm, rituximab GemOx, in relapsed refractory large B-cell lymphomas with one or more prior lines of treatment. But again, patients with only one prior line of treatment had to be transplant ineligible. So really a study which included patients very representative of many of the patients that we see in our daily clinics. This study was powered to have overall survival as a primary endpoint, quite a bold move, but indeed a positive study, as you can see on the left. Overall survival significantly better for the glofitamab GemOx arm, and also progression-free survival significantly better for the glofitamab GemOx arm than for the standard rituximab GemOx arm. So really a useful combination for patients with relapsed refractory large B-cell lymphomas, and you can see the overall and progression-free survival plateauing at around 40% after 2 years of follow-up. And you can ask yourself, is this any better than the CAR-Ts or perhaps the bispecifics alone? Well, it's certainly not any worse. It's quite interesting. This combination is absolutely a valuable contribution to our armamentarium and certainly comparable with the approved CAR-Ts. It's quite interesting to see an overall survival benefit so clearly statistically significant. This drug, glofitamab, is heavily B-cell depleting, and the study was carried out during the height of the COVID pandemic. And I'm showing you this because it's really, really important for the understanding of the results. In the R-GemOx arm, there were a lot of COVID, but no fatal cases of COVID, whereas in the glofit GemOx arm, there were also quite a lot of cases of COVID and 7 fatal cases. So despite a 7-to-1 score in COVID-related deaths, showing the potency of the B-cell depletion and the desire and need for us to be really careful with vaccination and monitoring and treatment of these patients. You still have a very clear benefit still when looking at a primary endpoint, which was overall survival.
Demonstrate any added efficacy because that's difficult.
Perhaps the next interesting phase 1b study was the combination with R-CHOP, also with polar R-CHOP. This was not to demonstrate any added efficacy because that's difficult when the endpoint is response rate, but the primary endpoint for this combination study was, of course, safety, and it was shown that glofitamab can safely be combined with chemotherapy, even first-line style chemotherapy. You can see that cytokine release syndrome was actually quite rare. And why was that? Well, I guess it was because glofitamab was only introduced in cycle 2. At that point, patients have usually responded quite well. Most of the tumor burden has been reduced, and that is the explanation for why CRS was seen very rarely and only of low grade in this study, unlike the similar combination of R-CHOP and epcoritamab, which I'm not showing you here, where cytokine release syndrome was seen in approximately 45% of patients, and where epcoritamab was introduced in cycle 1 alongside with the R-CHOP. And these studies have led to the ongoing important phase 3 studies of the bispecifics. First of all, the EPCOR DLBCL-1 study, which is a phase 3 study of epcoritamab as a single agent versus R-Benda or R-GemOx as per investigator's choice in patients with relapsed refractory large B-cell lymphoma, but also importantly the DLBCL-2 study, phase 3 study of R-CHOP plus minus epcoritamab in newly diagnosed diffuse large B-cell lymphoma with an IPI of 2 to 5, so an attempt to challenge the R-CHOP standard of care, and similarly the SKYGLO study, which is a phase 3 study of polatuzumab R-CHIP, so another standard of care in this space, plus minus glofitamab in the same group of patients with large B-cell lymphomas of an IPI of 2 to 5 and newly diagnosed, previously untreated. The DLBCL-2 study has completed accrual. I think the SKYGLO will complete accrual very soon, and it'll be super interesting in a couple of years from now to access the readout of these data.
I think it's nice.
So towards the end of my talk, I just have a few things, practical things that I would like to address. Because of the many years of experience that I have with these antibodies, I think it's nice to have a few tips that are not always available in the publications or in the prescribing labels. So one thing that is often being discussed is what is the optimal sequencing of CAR-T and bispecifics in the large B-cell lymphomas? And the honest answer, of course, is that we don't know. I think most colleagues, and that would include myself, would probably lean toward so we have a more solid long-term follow-up, and also for that reason a more solid promise of cure in a majority in a proportion of the patients. I'll get back to this. Also, which criteria into consideration when we choose patients with bispecific antibody treatment and when we use a bispecific antibody for a patient? I'll try and give a few lists of things that I think is important to be concerned and conscious about. Then a lot of patients, particularly in the follicular lymphoma, but also occasionally in the large cell lymphoma space, think about prior bendamustine, because bendamustine is not good. Bendamustine is not good for T cells. That goes for cyclophosphamide as well. So should we be careful with bendamustine in patients who might benefit later on from a CAR-T or from bispecifics, which are of course dependent on the functionality of the T cells? And finally, a little bit about toxicity and the need for infection prophylaxis and vaccinations, both in CAR-Ts, cell-treated patients, and patients going into treatment with bispecifics. So about sequencing, I've already shown you data from the phase 2 study of the bispecifics, and without going into detail, I also showed in the slides data supporting that the efficacy in terms of overall and complete response seems to be more or less the same in the overall population, both in the study of and of epcoritamab, regardless of prior exposure to CAR-Ts. And this, of course, would support, again, giving CAR-T prior to bispecifics. We have not until recently known whether the opposite is also true, whether CAR-Ts work as well in patients previously exposed to bispecific antibodies. But we've actually recently seen the answer to that question. It comes from retrospective data of the French DE-escalation database, which is a big database of CAR-T treated patients. And what the authors showed was that both when looking at overall support seem to be the same in a group of patients previously failing bispecific antibodies that we have become used to seeing when looking at CAR-T studies. What about the characteristics of the patients? What should we look at when we choose and select both bispecifics for patients and patients for bispecific antibodies? I think it's very important to have the target. Right now, we only have access to CD20 targeting bispecifics, but that will change very soon. And there is no doubt that it only works if the target is expressed. We have tried multiple times to treat patients with CD3, CD20 bispecifics in patients with no or very weak expression of CD20, and generally it is not a success. We need a reasonable organ function, and I would say that the CAR-T and the bispecifics more or less take the same cardiopulmonary function in order to support pressors and oxygenation therapy in case of severe cytokine release syndrome. We need to be thoughtful about these, particularly bone marrow infiltration and also tumor type. Mantle cell lymphoma carries a higher risk, for example, of CRS than diffuse large B-cell lymphoma. Risk factors for tumor flare should be assessed, can be coexisting and even confused sometimes with cytokine release syndrome. And I can only say that even though the vast majority of patients can be treated completely safely in an outpatient setting, in elderly, frail, or high-risk patients still consider hospitalization, and also in patients living alone and or far from the hospital. What about bendamustine? Gloria Jacoboni from Barcelona presented data on CAR-Ts showing that prior bendamustine is quite reductive for the function of the CAR-T. So bendamustine, recent therapy is really not good for the chance of responding well to a CAR-T. Is that also the case when you give bispecific antibodies? Same Gloria Jacoboni recently gave us the answer to that question too. No, it's not. Why? Well, maybe because when given bispecific antibodies, you potentially bring into use all the T cells that are in the body, whereas the CAR-T, of course, is only a small fraction, which is apheresed and then developed in vitro before being given back to the patient as the CAR-T cell infusion. That is, of course, speculation, but the data show that bispecifics work equally well in patients with or without prior exposure to bendamustine. Now, I told you a little bit before about cytokine release syndrome, and I repeat that this is without a doubt the dominant acute side effect of the bispecific antibodies. But after a while, after a month or two or three, the dominant side effects are the cytopenias, low immunoglobulin levels, leading to a relatively high risk of viral infections, and some but quite modest risk of bacterial infections. Need for transfusion, very rare. Need for growth factors, quite common when it comes to GCSF, very rarely EPO or TPO. Our advice on replenishing immunoglobulins is to, or at least my advice, is to strongly consider replenishment in cases of levels lower than 4 grams per deciliter, and in cases of repeated infections and levels below 6 grams per deciliter, I will also strongly encourage replenishing the patients with immunoglobulins. Also, be quite liberal with prophylactic antibiotics. We give all our patients Bactrim. We also give all our patients anti-herpes prophylaxis with typically valacyclovir, and also be quite liberal, particularly in patients with long-term neutropenia, with the antibacterial prophylaxis. Quinolone for serious infections in the vast majority of our patients, and during during peaks of COVID. We've also been quite liberal with the route of remdesivir. What about vaccination? Vaccines are considered both in patients antibody therapy and in patients recently therapy. So only live vaccine should be avoided during the induction phase of this treatment. Despite profound lymphopenia, despite the complete depletion of B cells, some depletion of plasma cells, we still have shown in the Danish study that COVID mortality was almost zero, because our population had a vaccination coverage of over 99% in the B-cell lymphoma population. And this is in opposition to less well-vaccinated populations, as I, for example, showed you when showing the data from the STARGLO study, where patients from North America were not so well vaccinated. And that probably was the reason for the high rate of grade 5 COVID cases. So in summary, I hope I have convinced you that the future is a little bit brighter than it was 10 years ago for patients with relapsed refractory B-cell lymphomas. I showed you examples of a number of novel agents that have been introduced, not least the CAR-Ts, leading to the development of bispecific around 40% complete response rates in phase 2 studies of both glofitamab and epcoritamab in relapsed refractory large B-cell lymphomas with 2 prior lines of treatment and high-risk features, including high levels of refractoriness. So these complete responses seem durable, both for epcoritamab, perhaps even more so for glofitamab. And in the case of glofitamab, I think it's fair and unbiased to state that there is a curative, because we see that more than half of patients responding completely to glofitamab are still in CR 2 years after the end of treatment, because as I've stressed, this is a treatment which is given not until progression, but for a fixed duration of time. The toxicity to the bispecifics is dominated by cytokine release syndrome, which is typically mild and transient and less severe than seen after the treatment with the most potent CAR-Ts, which and Lisa-cell. We rarely see cytokine release syndrome more than 1 month into treatment, and at that point, toxicity is dominated by the cytopenias, particularly lymphopenia, but also to some extent thrombocytopenia and neutropenia. For that reason, we need to vaccinate our patients, we need to give prophylactic antibiotics, and we need to monitor them for low IgG levels and replenish when relevant. I showed you recent data showing superiority both for overall survival, which was the primary endpoint, and also progression-free survival of glofitamab GemOx over R-GemOx in the STARGLO study, which important piece in the puzzle showing the value of the bispecific antibodies, and particularly glofitamab in treatment both in second and later line relapsed refractory large B-cell lymphoma. And now we are waiting eagerly for the outcome of the first-line studies that I showed you, and perhaps in the future also a randomized study of bispecific antibodies. I would love for that to be glofitamab in combination with, for example, glofitamab with polatuzumab vedotin and/or including alpha in second-line treatment or third-line treatment, directly compared against the CAR-T. Let's see.
Okay, I think we're done with the presentation. Dr. Chinks, can you hear us?
I hear you perfectly well. Can you hear me?
Yes. Thank you very much for being around. So we'll take questions. Please, microphone here. Microphone, please. Let's see here.
Martin, thanks for the excellent talk. So my question regarding the epcoritamab, what's the rationale of giving it like continuously if in a curable disease? Why it's not like glofitamab just for fixed duration?
I think sorry, thank you for this question. Good one. To go a little back, not to be lengthy, but when I first read the protocol, or the first draft of the glofitamab protocol, which is more than 8 years ago, I didn't like the fixed duration idea because, I'm a phase 1 trialist used to treating patients with no treatment options. And the idea of giving something which was potentially really effective, we saw the preclinical data, which was impressive, and then to perhaps reach complete responses and then have to stop, it was almost unbearable. So when 1 year later I got the first draft of the epcoritamab protocol, I really liked the treatment until progression. And then a few years later, when I'd seen the efficacy and seen the first hints of the curative potential, I was completely the opposite. I really like the fixed duration, so do the patients, by the way. And I'm still not very fond of the treatment until progression. But it goes to show that, it's an evolution with time. And I don't think neither of the study teams behind these drugs and studies had imagined that the responses would be so frequent, so deep, and so durable. So I think that's the right answer to the question. At this point, asking for a rationale, I don't think there is one. I don't think we see there is curative potential. We even see that with glofitamab, there is efficacy in retreatment. If you have a relapse of a previously responding patient, that would probably be the same for epcoritamab. So treating indefinitely with something that seriously depletes B cells and gives a high risk of infection is, in my eyes, wrong. And the studies that are being carried out now with epcoritamab in combinations all use epcoritamab for a fixed duration, usually 1 to 2 years.
Thank you. Any other question? Microphone there, please.
Well, my question is about if there's any data of using the bispecific in CNS involvement, whether epcori or glofitamab.
That's another pressing and very good question. So the answer is unfortunately no. But anecdotally, the first patient that I treated with epcoritamab, and this was in the microgram dose level, it was very early during dose escalation, so probably cohort 3 or 4 in the entire study. That was a young 23-year-old guy, and not after the priming dose, which I believe was something like 4 micrograms, but the intermediate dose, which is still very low. After 24 hours of the injection, he went into generalized convulsions, and we had to do an MRI scan, which at that point was not mandatory at baseline. And we found a large tumors in his frontal lobe. And unfortunately, we had to take him out of the study because he was in breach with the criteria, and he died after just 3 weeks. But I think it was a very clear sign that epcoritamab, and that would probably go for the other molecules as well, they are active in CNS. At least in this kind of disease where there is a parenchymal disease, you have a breach of the blood-brain barrier. So it's a shame that we have not yet been able to investigate this properly. But that's the way it goes. CNS lymphomas are always left a little bit behind, but with time, I'm sure they will be developed. And we will perhaps get an answer from the recently completed phase 3 study of epcoritamab in large B-cell lymphomas, because the study, which was in DLBCL IPI 2 to 5, will have included a lot of patients that would normally have CNS prophylaxis, or at least have a high CNS IPI score. And it'll be interesting to see if there is a difference in CNS relapse risk between the standard arm, which is just R-CHOP, and the experimental arm, which has the bispecific antibody. Of course, it'll be low numbers, fortunately, but it'll just be interesting to see if there's a trend.
Thank you. Any other question? So, Dr. Hutchings, I have one last question. So, in a transplant eligible patient with diffuse large B-cell lymphoma, relapsed refractory diffuse large B-cell lymphoma, it's clear that we would go for CAR T-cell directly. However, in patients who are transplant ineligible patients, how would you choose between CAR T and bispecifics in the relapsed refractory setting?
Actually, I I wouldn't have a particular preference. So, I know I just said that the requirements in the individual patient to be a candidate for a CAR T and for a bispecific antibody would be more or less the same. That can, of course, be modified a little bit because, first of all, it depends on the CAR T, because there's no doubt that the elderly and frail patient, I would be a little bit more reluctant to give axi-cel than lisa-cel, and particularly tisa-cel. And also, most of the bispecifics have a lower frequency of grade 2 and higher cytokine release syndrome. So depending a little bit on the patient features, but all things equal, I wouldn't have a particular preference. But of course, like I said, we are short of the randomized study between the CAR T and the bispecifics, and let's see if that study will ever happen, and whether it'll be in second line, which is not unlikely, or in third line, which I believe is unlikely.
Okay. Thank you very much, and we'll conclude this session. Thank you.
Thank you.
Thank you, Dr. Dada. We'll proceed with our program. Last session of the day, but there will be an evening satellite symposium, just to remind you. So it's my great honor to present the next speaker, Dr. Musa Zahrani. Dr. Musa is Associate Professor and Consultant Hematologist and Bone Marrow Transplant from King Saud University in Riyadh. He couldn't make it, unfortunately, to Medina. But Dr. Musa, he will present Burkitt's lymphoma, initial and relapse refractory treatment. Dr. Musa, you can start. You can hear us.
Do you hear me?
Yes, please, go ahead.
Okay, first of all, thank you very much for the invitation. It's always a pleasure for me to attend this annual meeting, and I wish I'm there with you physically in Medina, but I'm attending the ISHL meeting in Germany. So today I will present some recent updates on the Burkitt's biology, genetics, and also the current understanding of treatment for Burkitt's lymphoma. And this is my disclosure. So Burkitt's lymphoma is a disease that we don't usually talk a lot about in the conferences and meetings. So it will be important for us to revise the current understanding of Burkitt's lymphoma. There have been some recent updates in the literature about classification, as well as some updates in the biology and genetics and treatment as well. So I will be talking about some update in the classification from the recent WHO 5th edition, as well as some information about the dark zone family of lymphomas and the molecular subtypes of Burkitt's lymphoma, and then review the current therapeutic options, either in the frontline or the relapsed refractory, and some future directions in the treatment of Burkitt's lymphoma. So according to the recent WHO 5th edition, definition of Burkitt's lymphoma is a mature aggressive B-cell neoplasm that has 3 features, basically morphologically and immunophenotypically, as well as genetically. Genetically, we all know that the classical genetic abnormality that happens in Burkitt's lymphoma is the MYC translocation with an immunoglobulin gene. And morphologically, typically these cells have a monomorphic morphology with the medium-sized cells and basophilic cytoplasm and multiple small nucleoli, and an immunohistochemistry showing that these cells are germinal center origin with CD10 positivity and a very high proliferative index. There are some essential features and some desirable features based on the WHO. So the essential features, as we discussed, the morphology, the classical morphology we just discussed, in addition to the immunohistochemistry of these cells being CD20 positive, CD10 positive, and BCL2 negative or weak. And the Ki-67, the proliferative index, is extremely high, reaching to usually around the 99 or 100% range. with very high MYC expression on the immunohistochemistry of usually more than 80% and or demonstration of MYC breakage based on the FISH analysis. And we do have some desirable but not essential features such as a starry sky appearance, cohesive growth pattern, and BCL6 positivity and negativity of TDT, positivity of CD38, and absence of the rearrangement by FISH in BCL2 or BCL6 to exclude the high-grade B-cell lymphoma with these rearrangements. In terms of epidemiology, typically Burkitt's lymphoma presents with a high tumor burden at the time of presentation. Usually it's already disseminated and usually present in a very short doubling time because of the high proliferation of the disease, and typically present in extranodal areas, far more common than nodal disease, except in immune deficiency associated Burkitt's lymphoma, where they present with nodal disease more than extranodal. It has a male predominance typically, and in terms of age, it has a bimodal distribution, being common in pediatric at around the age of 10, and also another peak in the age of 60s. We also know that there is a form of Burkitt's lymphoma that's endemic in some areas in Africa, usually associated with the EBV and malaria as well. Typically, this type presents in the facial bones, such as the mandible, maxilla, with also some patients present with abdominal involvement, whereas the sporadic cases typically present in other sites, including GI tract, orbits, and well-entering ring, thyroid, ovary, testis, and breast. The CNS risk, as we know, is very high in Burkitt's lymphoma, either at the time of diagnosis or at the time of relapse, dependent on which study you look at, but at least 30% of cases will have CNS involvement. So this is an important consideration in these patients. Bone marrow involvement or leukemic presentation is also relatively common, happens in roughly 2 out of 10 patients. In terms of subtype, traditionally speaking, it had been divided into 3 basically subtypes of endemic, sporadic, and immunodeficiency or HIV, for example, associated Burkitt's lymphoma. But this is mainly, this classification mainly dependent on geography, and it doesn't take into account the biology of the disease. So this is also problematic because many sporadic cases occur in Africa and vice versa. So we do have cases of endemic, what so-called like EBV associated, that can happen in developed country and the other way around. So this is not a very helpful classification. So the recommended subtypes by the WHO 5th edition is to use EBV associated and EBV negative rather than the traditional classification. This gives more of a reflection of biology of the disease. Genetically, the primary genetic event is the MYC translocation of the MYC gene in the 8 chromosome with the promoter region of the heavy gene immunoglobulin in 80% of the time, but it could be also with the light chain, either kappa or lambda in chromosomes 22 or 2 respectively, in the remaining 20% of cases. Typically, Burkitt's lymphoma actually is associated with simple karyotype. So complex karyotype is quite rare in Burkitt's lymphoma, even in the presence of TP53 aberration, which typically present with complex karyotype in other types of like leukemias, for example. But in Burkitt's lymphoma, the karyotype is usually simple. The other translocations with MYC with non-IG partners is not something that is associated with Burkitt's lymphoma, and should basically make us think about different type of diagnosis, like a high-grade B-cell lymphoma or some forms of aggressive diffuse large B-cell lymphoma. This takes us to this recently described the dark zone family or dark zone lymphoma that is presented recently in blood by the group from British Columbia, David Scott and Walid Douaish. where basically they looked at over more than 1,000 samples with the de novo diffuse large B-cell lymphoma, and they evaluated their biopsies to look for their profile by FISH for double hit, as well as immunohistochemistry and the new digital gene expression profile to assign the cell of origin, and also to look at the double hit signature, which was previously described in the literature for patients with double hit by FISH for BCL2 and c-MYC. And there were several key findings emerged from this study that are important to guide this and makes us understand the disease. So the dark zone signature defines a group of aggressive B-cell lymphoma with a common profile that extends beyond the double hit and the diffuse large B-cell lymphoma. And it identifies a subgroup of patients with poor prognosis. Two-thirds of them are negative for double hit by FISH. So although they are not double hit by FISH, but they still have poor prognosis because they are in the dark zone signature. The double hit tumor that lacked the double zone signature had actually favorable outcome despite having double hit by FISH. And what is more relevant for our talk today is that Burkitt's lymphoma, actually all of them universally express dark zone signature. So all of the Burkitt's lymphoma are actually from this family of dark zone lymphomas. As we can see in this study, the graph in the left upper corner, you can see that basically Burkitt's lymphoma, 100% of them have the dark zone, and about 77% of the double hit have the dark zone, while about 15% of the diffuse large B-cell lymphoma, usually in the GCB type. And you can see that the germinal center can be divided into light zone and dark zone, and then the three lymphomas can arise from there. If you look at the freedom from progression, the graph, the Kaplan-Meier curve, you can see that GCB, ABC, in the orange and blue color, they do better than the dark zone lymphoma. So dark zone lymphoma will do much worse compared to the other subtypes, and they have shorter time to treatment days, about 25 days, reflecting the high proliferative disease in these patients. Here also, if you look at the Kaplan-Meier curves, you can see that the lines that are red and green reflect the patients with dark zone, regardless of whether they have double hit by FISH or not, and they will have basically worse outcome in terms of freedom from progression as well as overall survival. So altogether, these findings suggest that the dark zone signature identify a dysregulated dark zone phenotype that is shared by different histologically different lymphomas like Burkitt's or double hit and DLBCL, and it favors to rename the signature formerly known as double hit signature to dark zone signature. In terms of molecular classification, so also a recent study published in the Blood by Thomas et al., where they presented a wide genome sequencing analysis of 230 cases of Burkitt's lymphoma, and they aim to discover genomic subgroups dependent on somatic mutations, copy number, alteration, structure, variants, and then using consensus clustering algorithm. Similar approach was presented previously, as many of us know, with diffuse large B-cell lymphoma, where diffuse large B-cell lymphoma was divided into 5 molecular subtypes. So a similar approach was conducted in this study for Burkitt's lymphoma, and they identified 3 unique genomic subtypes. So the IC Burkitt's lymphoma, DGG Burkitt's lymphoma, and Q53 Burkitt's lymphoma. And each one of these have different clinical features and the molecular genes associated with it. For example, the DGG Burkitt's lymphoma is enriched for EBV positive cases, pediatric cases, whereas the Q53 is enriched by EBV negative cases and TP53 mutations. So the primary breakage is the CMIG, but all of these patients will have secondary genetic mutations or hits to lead to the 3 molecular subtypes. Also, just to remind ourselves that there is for prognosis, there is an international prognostic index that is designed for Burkitt's lymphoma. Uses similar, more or less similar, sorry, variable that is used in the other IPI for diffuse large B-cell lymphoma. So age, LDH, and ECOG, as well as CNS involvement. And with these 4 risk factors, we will have different risk groups. And you can see that the more the risk factors, the poorer the outcomes with these patients. In terms of treatment, the standard of care for Burkitt's lymphoma is still undefined, but the current treatment includes aggressive combination chemotherapy with CNS-directed therapy. 3 common approaches exist. One is the intense short-duration combination chemotherapy, examples of which is McGrath protocol or CLGB or the German BALL protocols. Or the other one is the ALL-like therapy, similar to ALL therapy, where you have induction, consolidation, maintenance that lasts for 2 years, or using hyper-CVAD in such cases. And the third approach is infusional chemotherapy with the dose-adjusted EPOCH, which we will discuss. So first of all, the McGrath regimen, the famous regimen that is initially presented in 1984 by McGrath in a small number of patients with Burkitt's lymphoma and lymphoblastic lymphoma, achieving a very good CR of 80%, 82%, and overall survival at 3 years of 60%. Later on, there were many modifications for this McGrath regimen. One of them is the MEAD modification, where basically in this study that was published in 2002, they defined patients with low risk as non-bulky, stage 1 or 2, normal LDH, ECOG 1 or less extranodal sites, and other patients will have high risk. And for high-risk patients, they gave the full McGrath protocol with 2 cycles of Codoxim and 2 cycles of IVAC-R, whereas the low risk, they will only give 3 cycles of Codoxim. And with this, we can see that the 2-year overall survival was quite good, with 70% overall survival and event-free survival of 60%. However, there were high rates of severe mucositis and myelosuppression with this. We can see that you can see the graph from this study that the low risk did better than high risk, which is expected, and you can see the quite good outcome for overall survival and event-free survival over time. Another modification by Lasaki, this was a phase 2 study where basically they decreased the dose of cyclophosphamide to decrease the myelosuppressive effect, and also capping vincristine and reducing the IT cytarabine to reduce neurotoxicity, and also decreasing the IV methotrexate to reduce toxicity while maintaining a good CNS penetration, and also moderately increasing the doxorubicin dose to keep the efficacy of this regimen. With this, 90% CR were achieved and 64% disease-free survival at 29 months. The other regimens, as we mentioned before, they were quite highly effective in pediatric literature. However, their use in adults was associated with increased treatment-related toxicity, especially in patients with HIV positivity. There are many examples of this. So from the European group, whether the basically French group, German group, Spanish group, and also from the US experience, more or less similar outcomes with CR rate between 70 to 80% and around 80% or so 5-year progression-free survival and overall survival. But more importantly, the treatment-related mortality is quite significant, of about 2% to 6% of dependent on the different protocols. So the treatment-related mortality was a challenge using these protocols. This has led to development of less toxic regimens like those adjusted EPOCH-R. Levy presented in 2006 a report for Burkitt's lymphoma, both HIV positive and negative. This subsequently was published in another phase 2 trial in 2013 in New England Journal of Medicine, reporting excellent outcome, as you can see in the graph, with more than 90% CR and progression-free survival. And there was no treatment-related mortality, which is important. Also, to reduce the toxicity even further, especially with patients with HIV, a short course double rituximab EPOCH-R was developed. So this study that looked at the full dose adjusted EPOCH-R in HIV negative patients, 19 patients, whereas the short course double rituximab was used in 11 patients with HIV positivity. And the difference is that the short course will use double dosing of rituximab per cycle. There was no dose escalation. And there was also response-guided treatment by PET scan after several cycles. And you can see after median follow-up of more than 5 years, both freedom from progression as well as overall survival were quite excellent, whether you use the short course or the full dose of dose-adjusted EPOCH-R. Toxicities were as expected: febrile neutropenia, 19%, mucositis, and peripheral neuropathy. Another approach is the PET-adapted approach. This is something relatively new compared to the evidence that I presented, because many of the studies initially did not use the risk-adapted approach. So it will be important to think about whether PET-adapted approach can be useful. So this is a study, NCI 9177. This is a phase 2 study, multi-center study that used dose-adjusted EPOCH-R in a good number of patients, 113 patients, including HIV positive patients. This had a really good, basically progression-free survival and overall survival at 3 years, and the majority of cases were high risk. And the response was unrelated whether the patient was older or had an HIV status, so patients would still respond. Low-risk Burkitt's lymphoma were treated only with 3 cycles of dose-adjusted EPOCH-R. There was no CNS prophylaxis. And in this subgroup, although the number were small, but there were no deaths or progression reported. So, of course, the logical question will be which regimen is better, is MIGRATH or dose-adjusted EPOCH-R? And we do have one randomized trial that looked at this by the Hovon-Sack group. Before we discuss that, we have to remind ourselves that the CNS risk is quite significant in Burkitt's lymphoma, as we mentioned, whether at the time of relapse or presentation. The majority of cases, 70%, present in a leptomeningeal disease. Hence, the IT chemotherapy becomes important. But 30% actually have parenchymal disease, where IT usually have less of a role in that case. So dose-adjusted EPOCH-R, although had the same, roughly the same IT injections as Hyper-CVAD or Codox MIVAC, but it actually lacks systemic CNS penetrating drugs like methotrexate or cytarabine. So it means that patients with parenchymal disease will not probably benefit from this regimen. And this is supported by some retrospective studies that showed that roughly about risk of CNS relapse is actually higher while using dose-adjusted EPOCH-R as compared to MIGRATH. So almost 2-fold or 3-fold increased risk of having CNS disease after dose-adjusted EPOCH-R. So this is a concern. Now going back to this randomized study, this is a phase 3 study, multi-center, open-label, that is conducted in several countries, and it included adult patients without CNS involvement but high-risk Burkitt's lymphoma, and they were randomized to 2 cycles of MIGRATH versus 6 cycles of dose-adjusted EPOCH-R, and patients also received for intrathecal and for methotrexate chemotherapy. and the primary endpoint was progression-free survival. Unfortunately, the study was closed prematurely because of slow accrual. However, 89% enrolled in the study, and they were able to present the outcome for these patients. 90% of these patients presented with stage 3, 4, and 11 had HIV positivity. And after a median of 28.5 months, the 2-year progression-free survival was 76% in the McGrath protocol, compared to 70% in the dose-adjusted EPOCH-R, with a p-value that was not significant. So there was no significant difference in progression-free survival. And there were 2 deaths only in the McGrath, related to one related to infection, another one to disease progression, and one only death in dose-adjusted EPOCH-R related to COVID-19. And discontinuation happened in 4 patients due to side effects in the McGrath, compared to none in dose-adjusted EPOCH-R. And there were more
Musa, you have 5 minutes to conclude. 5 minutes.
Almost done. Yeah. So 56% of grade 3-5 infections happened in the McGrath versus 34% in the dose-adjusted EPOCH-R. So meaning that dose-adjusted EPOCH-R was less toxic. It is hard to interpret a study that was closed prematurely and did not complete the sample size, but we can get a rough idea that maybe dose-adjusted EPOCH-R is less toxic and equal, maybe in some subgroup, but not all patients. Relapsed Burkitt lymphoma is an important topic. It happens in around 20% up to 40% in some studies of Burkitt lymphoma. Unfortunately, there is no standard of care in such patients because we have limited evidence to support our treatment. So this is an unmet need that we need to basically. There are many salvage regimens that can be tried, as we know. These are some of them, but usually followed by a transplant, whether autologous or allogeneic, but usually autologous transplant. How about CAR-T, CD19 directed CAR-T or bispecific? Unfortunately, the studies of CAR-Ts, the pivotal trials usually excludes Burkitt lymphoma, so we don't have enough data from this. So it remains to be experimental. And one of the challenges with CAR-T and Burkitt lymphoma is the rapid pace of Burkitt's disease. So while waiting for CAR-T to be conducted, probably patients will progress and will not have time to reinfuse the cells. There's no enough data in bispecifics or antibody drug conjugate, unfortunately. There was one study that presented in ASH last year by a Chinese group, and this included 19 patients using CD19 CAR-T, and it seems that the outcomes were encouraging, but this needs to be basically looked at in the future in other studies to confirm these findings. The CRS rates were 84%, 16% were grade 3-4, and ICANS were 16. 26% of them were 3 to 4. And the best overall response rate was around 50%, and 1 year overall survival was 21%. And we can see that one of the things they looked at was the achievement of remission at 3 months, and this was a poor prognostic factor for patients who do not achieve remission after 3 months from CAR-T. What to look for in the future? There is a drug that is a MYC degrader called the D-ubiquitinase inhibitor, and this is the phase 2. This is the first-in-class drug, multi-center study, recruiting still, no result yet of this study. LongCAR-T, in addition to dose-adjusted EPOCH-R, this is also a trial that's ongoing. It's a phase 1 for newly diagnosed Burkitt lymphoma. There are other trials now, including Burkitt lymphoma in their protocol with either CD19 or CD22. So we'll be looking for results from this study. So a suggested algorithm was presented in recent review articles. So so for low-risk patients, you could try to use dose-adjusted EPOCH-R without CNS prophylaxis, and then conduct basically interim scan. And if they are in remission, you give one more cycle, total of 3 cycles. And if they're in partial remission, you give total of 6 cycles, so 4 more cycles. And if they're high risk, you basically treat them with the McGrath protocol. And if they have CNS involvement, of course, you would basically give them more intrathecal chemotherapy. A similar algorithm was also basically presented in the ASCO newsletter by these authors, and they divided patients into fit and unfit. For unfit patients with high risk, you could try dose-adjusted EPOCH-R with intrathecal methotrexate, and for low risk, dose-adjusted EPOCH-R for 2 cycles, and then followed by PET scan. And then if they're negative PET scan, give 1 more cycle. If not, then 4 more cycles. And the high-risk fit patients will be treated with the full McGrath protocol. And of course, if they have CNS involvement, you would treat them aggressively. So just to conclude, Burkitt's lymphoma is an aggressive mature B-cell lymphoma. There have been recent advances in understanding biology and genetics. Biology-driven classification is important rather than geography-driven classification. Multi-agent chemotherapy regimen adapted from pediatric are efficacious, however toxic, especially with the treatment-related mortality, especially in patients with HIV positivity. So short but intensive chemotherapy like the McGrath protocol has good balance between efficacy and toxicity, but less toxic regimen like diffuse, so like dose-adjusted EPOCH-R, especially in low-risk disease, are having encouraging results. And the relapse setting, this is a significant portion of patients with less and limited evidence that we really need to have future studies to help us or guide us on what is the best treatment for these patients. And with this, I conclude, and thank you very much.
Thank you, Dr. Musa. Elaborative, excellent presentation. Just a burning question because we are behind time. What's your opinion regarding upfront transplant for high-risk patients? What's your recommendation or approach?
Look, I think the majority of patients will achieve long-term remission and cure by using intensive chemotherapy. So I think the best approach is to keep the transplant for the relapsed refractory setting rather than to use it upfront, because the majority of patients will actually achieve good remission, even in high-risk patients.
Okay. Thank you, Dr. Musa, and have a safe trip back, inshallah. So we'll move to the next presentation.
We will move to our next speaker and the last one in our session is Dr. Stephen. He is a member attending as physician in Memorial Sloan Kettering Cancer Center in New York. And he is going to present peripheral T-cell lymphoma incorporating novel therapies. Can you hear us?
Yes, I hear you well.
Yes,
thank you.
The floor is yours. You can start. Thank you.
I'll try to share my screen and see if is that the right view for you all? Yes. Is that, do you hear me okay?
Yes.
Yes. Okay, and that's the right view. Yeah. Thanks for having me join you today. I hope I'm not keeping you from dinner, but I'll try to move through. We'll talk about T-cell lymphomas and ways that we're starting to incorporate new therapies into our treatment paradigms. These are my disclosures. So this is just a level set or a starting point for where we think about what we do historically with T-cell lymphomas. These are the progression-free and then overall survivals from a Swedish National Registry. So it really accounts for the spectrum of primarily nodal T-cell lymphomas. And you can see here a couple of things. One, that for most of the T-cell lymphomas, we have a lot of room for improvement. with progression-free survival in the 20 to 30% range long-term. This is primarily with CHOP-based therapy. And we do somewhat better for positive ALCL, though still room for improvement. And then I think the other thing when we look on the right is that historically overall survival and progression-free survival have been tightly linked. And that was because of the lack of sort of available or effective salvage therapies, but that's changing as well. And then this is sort of maybe the best we do with chemotherapy. So this is data from the Nordic study looking at upfront transplant and intensified chemotherapy. So if you maximize chemotherapy, you give CHOP etoposide. This was given every 2 weeks for patients under 60. Consolidate responders with auto transplant. At least in a clinical trial setting, you can potentially push those progression-free survival up to the 40-45% range. If you look over on the right, better for ALK-negative ALCL than it is for PTCL NOS. And then the overall survival curves come up close to 50%. This is probably about the maximum we can do by just intensifying chemotherapy. But our understanding of T-cell lymphoma, or the biology, has really significantly increased really in the last 10 to 15 years and even more recently. Some of the most sort of fundamental insights is this understanding that there's a large group of T-cell lymphomas called now follicular helper T-cell lymphomas. This is angioimmunoblastic as well as some other subtypes that we think the cell of origin, or what's sometimes called the cell state, is really from a germinal center or follicular helper T-cell. And those are characterized by certain mutations, almost always a background of clonal hematopoiesis with TET2, DNMT3A, and then often some additional private mutations in the T-cell lymphomas themselves, which are sometimes things like IDH2 or ROA. Understanding that biology, as well as seeing some of the aberrant signaling in T-cell lymphoma, ROA, VAP1 through SYK, or other signaling pathways like PI3 kinase or the JAK-STAT pathway, have allowed insight in understanding the biology. And because we are starting to have some treatments that target those pathways, we're starting to see those concepts make their way into investigational and I think soon standard therapy. So I think the one principle that I would go back to that we can build on a chemotherapy regimen, so chemotherapy is not worthless, but it's something we could build upon to do better, is the Echelon-2 study. And I hope this isn't a one-off, that we'll be able to repeat this with other concepts. But as those of you probably know, Echelon-2 was a randomized study adding brentuximab vedotin to CD30 positive T-cell lymphomas, randomized double-blinded for T-cell lymphoma. It's a pretty big study with about 450 patients. And that showed an overall benefit in progression-free survival. If you look at the orange curve for BVCHP versus CHOP, and then that led to a benefit also in overall survival. So really the first study we have that showed improvement in overall survival. While those curves run pretty close together, the median PFS was almost tripled, and the OS similarly increased. I think the other thing I point out here is the CHOP arm did quite well. So this study is overrepresented for anaplastic large cell lymphoma, so there may be some more chemosensitivity there. But the median PFS for CHOP alone was 23 months, which was much longer than predicted. But if you look at those curves at 5 years, at 5 years, over 40% of patients remain progression-free with CHOP. And if you look at the overall survival, the median overall survival with CHOP is not met at 5 years. So that the takeaway from that is BVCHP became a standard of care. I think unequivocally overall survival benefit in anaplastic large cell lymphoma, it's what we do. For the other CD30 expressing T-cell lymphomas, it was a little less clear. I didn't go into the details there, but those are underrepresented, not balanced, and the degree of benefit or any benefit at all was less clear, but they were part of the intent to treat subset. And then there's been some other ways that I just mentioned here of looking at adding BV with further intensified chemotherapy that look like there may even be some further benefit consolidating with transplant or adding etoposide. But in terms of new therapies, are there other ways to take the same concept and also move that into an upfront setting to try to benefit more patients? So some of this comes from some data with HDAC inhibitors. So we had the clinical impression that for HDAC inhibitors, primarily romidepsin or belinostat, that patients with follicular helper T-cell lymphomas did better. So we did a retrospective look at number of centers of patients. There's about 120, 130 patients with T-cell lymphomas who were treated with HDAC inhibitors. We reclassified them with the new classification system, coding them as TFH or non-TFH. And what you can see here is that your chance of response is almost twice as high if you're TFH, and your chance of complete response is also quite a bit higher for TFH than non-TFH. And then we kind of looked the other way. We looked at all comers who had mutational profiling and looked at whether they had those typical TFH mutations, TET2, DNMT3A, ROA, things that sort of biologically characterize those tumors. And you can see that responders are greatly enriched for those mutations. So this is, most of those mutations or some of those mutations are in methylation. These are de-acetylase inhibitors. So it's maybe not causative, but there's a correlation between this biology and response to at least HDAC epigenetic therapy. And that idea was taken forward really concurrently, or before the knowledge of particular responses to HDAC was known. And the French, the LISA did, teams keep popping up. The French, the LISA group did a prospective randomized study adding romidepsin to CHOP really in all comers with peripheral T-cell lymphoma. And that data was negative. So disappointing outcomes. If you look at romidepsin CHOP, there was really no difference in complete response or overall response between RO-CHOP and CHOP. Part of that may have been due to the increased hematologic toxicity caused by romidepsin. So romidepsin here was added at 12 milligrams per square meter, which is close to full dose. And it led to significant increases in dose reduction, dose interruptions. And if you look down here at the bottom, the ability to give the chemotherapy on time at full dose, which we think is important, was compromised by the addition of romidepsin. Maybe that was part of the reason, but when the progression-free and overall survival curves were looked at, which were the primary endpoints, there was really no benefit. So the RO-CHOP curve is seen here in sort of blue-green, and it sits above the CHOP curve, but really no significant difference in median or long-term PFS, and then really no difference in overall survival. When they looked at the forest plots, it was almost significant for the follicular helper or the angioimmunoblastic T-cell lymphoma subtype. That was not a planned analysis. So retrospectively, they went back and reclassified the patients as TFH or non-TFH and reran the curves. And when you look at the TFH patients only here, which were 200 patients, this was about half of the study, we get almost doubling of the median progression-free survival with romidepsin versus CHOP. And if you look at the non-TFH patients where romidepsin may have added to hematologic toxicity and reduced dose intensity and maybe didn't benefit those patients so much, you see no difference in really an inversion of those curves. So it may be, had this been done in a different way or powered in a different way, that adding HDAC to CHOP in this setting could result in a benefit for patients with follicular helper T-cell lymphoma with differences, potentially similar in degree to BVCHP. There's also other therapies that are in development that look promising and maybe less toxic for T-cell lymphomas, including hypomethylating agents, EZH inhibitors, and then some other signaling targets, which I'll talk about briefly. So azacitidine T-cell lymphoma has an interesting history. There was an initial series from France where patients got azacitidine off study. It was about 20 patients, and there was this surprisingly high response rate in angioimmunoblastic T-cell lymphoma. On these curves down here, some of those patients had complete responses to single agent. Some of those responses were ongoing, and really very little, if any, response to other types of T-cell lymphoma. There was a formal prospective randomized study done comparing oral azacitidine here, CC486, versus an investigator's choice of gemcitabine or romidepsin. And then the responses were sort of much more what we'd seen with other types of T-cell lymphoma, about 33% overall. And this was only for angioimmunoblastic T-cell lymphoma patients. Some of those responses were durable, and it did lead to some improvement in progression-free survival. Testing that concept, Girowan and Cornell, who we collaborated with, started a study of oral azacitidine plus CHOP chemotherapy. The idea here is that azacitidine might add single-agent activity to the T-cell lymphomas, and they have some data with Ari Melnick and Leandro Cicchetti looking at sensitizing tumors to chemotherapy by adding hypomethylating agents. This was a phase 2 study. The responses were quite good. Small study, but overall response rate was 75%, all complete responses at the end of treatment. And if you looked at the follicular helper patients, which were almost all the patients in the study, that response rate gets up to 90%. There probably is an increase in hematologic toxicity when we add azacitidine to CHOP. but usually that can be managed, at least in this study, in the academic clinical trial setting. And when Gia presented the PFS curves and the overall survival curves, and she, I think, can update them later this year at ASH, they look quite good. You know, we're comparing to historical controls, so it's hard to make conclusions, but the PFS was 65%. And again, among the TFH patients, the PFS with relatively short follow was almost 70%. Looking at some mutation analysis, again, are there better ways to select patients for the study or select patients to take out of the study who are less likely to benefit? And we've seen this in some other settings where DNMT3A mutations correlate with adverse or poor response to chemotherapy. So again, small numbers here, but patients with TET2 correlated with favorable PFS, and patients with DNMT3A mutations shown here in the red curve, small numbers, but looks like those patients are more likely to be chemo insensitive and may not benefit from combination chemotherapy approaches the same way. EZH inhibition, which the phase 1/2 studies will be coming out soon in Lancet Oncology, are another promising epigenetic therapy for T-cell lymphomas. So unlike in B-cell lymphomas, where there's often gain-of-function mutations in EZH, there's almost never that in T-cell lymphomas, less than 5%. But EZH is overexpressed in a number of T-cell lymphomas and may have pathogenic roles, particularly in follicular helper angioimmunoblastic T-cell lymphoma or HTV1-associated T-cell lymphoma. We studied this initially a phase 1 and then a phase 2 study of balimetastat, 1/2 inhibitor, oral agent given as a single agent with a primary endpoint of response and then progression-free survival, these relapsed refractory T-cell lymphoma. And the data looks quite good. So the overall response rate by CT assessment for angioimmunoblastic T-cell lymphoma was over 50%, but good responses in other subtypes. We think PET-based response is probably more reflective of clinical benefit in T-cell lymphoma. So PET was also looked at, even though that wasn't the primary endpoint. And you can see response rates overall, all comers are over 50%, but particularly high responses and complete responses for angioimmunoblastic T-cell lymphoma, good responses in HTLV1 and other types of T-cell lymphoma. So this is another agent that probably has some better hematologic toxicity, more favorable than something like romidepsin, and might be something that's ripe for combination with chemotherapy. Moving on to signaling targets. So as you probably know, JAK-STAT signaling is super common in T-cell lymphomas. It's characteristic of some subtypes like PLL or LGL or many NK T-cell lymphomas, but we also see overactivation of the pathway across the board in many subtypes, anaplastic large cell lymphoma, for instance. And we did a study where we looked at single-agent ruxolitinib in T-cell lymphomas. We grouped them into 3 groups. Patients with activating mutations of JAK. This is sort of a proof of principle study where we thought those patients were most likely to respond. We had another group with elevated phospho-STAT3, where there was evidence of functional activation of the pathway in absence of an activating mutation. Some of those patients may have fusions. And then group C was neither or unknown, and just treated them with single-agent ruxolitinib. And the data was interesting. The responders were most likely for those in groups 1 or 2 that had activating mutations or elevated phospho-STAT3. Response rates of about 30%, so not super high, but maybe clinically meaningful for some patients. And those responses, if you look on the right, really cross subtypes. So patients like LGL or PLL were more likely to respond, but we really saw responses as much based on the biology as the subtype. If you look at clinical benefit, where patients had stable disease or better beyond 6 months, the degree of clinical benefit may be higher than just the response rate. Other JAK inhibitors are in development, and galidicitinib is a primarily JAK1 inhibitor, another oral agent where a phase 2 study was done, again with high responses, numerically better than what we saw with ruxolitinib, though they're different studies. Overall response rate of over 40%, with about half of those being complete responses. And then again, if you look at subtypes, they saw very high responses in PTCL-NOS, less in AITL, lower responses in anaplastic large cell lymphoma, high responses in PTCL-NOS and AITL, lower responses in anaplastic large cell lymphoma, which is a little unclear, as at least half of those patients should have JAK-STAT activation, and a small number of patients with NKT cell lymphoma, which are often JAK3 mutated. responded. So it may be that this is another promising pathway to target, and there may be some ways to individualize the treatment or select patients for treatment. We think the ruxolitinib offers a proof of principle that targeting this pathway can be successful. As I showed you, galidositinib, there's other JAK inhibitors, there's stat degraders that more potently hit the target in the clinic in clinical development. And I think kind of sorting out, are there optimal ways to hit this pathway and ways to make combinations are clinical trials that are going on now. The last thing I'll talk about before wrapping up is PI3 kinase inhibition. So this is another pathway that's consistently upregulated in T-cell lymphomas. You're probably familiar with the B-cell story, where these were FDA approved or useful agents, but in long-term use, particularly in CLL, there were some late toxicities, mostly infectious toxicities. So their use and role in B-cell lymphomas has been a little less clear. T-cell lymphomas, where we don't have things like ibrutinib or bispecifics, as you heard earlier, that cause long-term remissions, we think that these drugs really have activity and are still pursuing them. So in the initial phase 1 we did of duvelisib, which is a PI3 kinase delta gamma inhibitor, most of the other PI3 kinases in lymphoma were delta specific. This is just the one that we started working with. In the phase 1, the T-cell lymphoma cohort, we saw about a 50% response rate in PTCL, and about a 30% response rate in CTCL. And again, if you look at this figure here, didn't really sort by subtype. There were sort of responses and non-responses among different subtypes. That led to the PRIMO study, which is a phase 2 prospective study looking at duvelisib as a single agent in T-cell lymphoma. Without going into a lot of detail, the patients with T-cell lymphoma tend to get treated with higher doses, 75 milligrams BID, which is 3 times what was the FDA approved dose of 25 BID. We did a little dose optimization cohort, and it looked like 75 BID, while more toxic, was also more effective. And that led to a expansion strategy where patients got the higher dose for 2 cycles to try to get early disease control, then were reduced to the lower dose for better long-term safety. There may be some other ways to give these drugs more safely long-term. And this is just some updated data from last year. The study is now complete, and hopefully will be updated at ASH of the phase 2 portion. So these are 97 patients in the expansion cohort. I'll just look here to show you the best overall response. So in PTCL NOS, which was about half of the patients, the response was almost 50%. 2/3 of the patients with AITL responded, so there's some subtype specificity there, and much lower responses in ALCL. And we're starting to understand the biology why ALCL might be less sensitive to PI3 kinase inhibition as a single agent. Toxicities are very important when we're thinking about PI3 kinase, partly because of the experience in B-cell lymphomas. And looking carefully at that, we do see significant levels of transaminase elevation. About 23 or 1/4% or a quarter of those are grade 3 or higher. This is higher at 75, and there may be some other strategies going forward to sort of minimize this. But there is an infectious risk with these compounds. So those strategies are being looked at now in the upfront setting in a cooperative group study going on in the US. So this is a randomized phase 2 study looking at adding oral azacitidine or CC486 to CHOP or CHOEP, duvelisib to CHOP or CHOEP, or a standard arm. And this is an accruing study, and it will look at both the responses and toxicity of these novel upfront approaches, and then also try to do some subtype connection. And are there certain subtypes that seem to benefit more from these approaches? So to wrap up there, for peripheral T-cell lymphoma, it's heterogeneous and it remains relatively poor prognosis. However, I tried to show you that there are a portion of patients that are cured with combination chemotherapy, and there may be ways to build on that for those patients who are chemosensitive. We and others are working hard to identify active agents, and then in addition, trying to understand where those agents work and where they don't, so we're not sort of repeating this one-size-fits-all approach, and try to match therapies with patients as we try to build on chemotherapy. And I think what we're hopefully moving to in the near future are subtype-specific strategies for better results for different subtypes. Some of those will be disease subtypes, but some of those may be molecular subtypes or target-specific subtypes that may cross different diseases. And then I showed you some of the data for some of the newer approaches in combination, epigenetic therapies, signaling targets. I didn't really talk about immune therapy, but that's another topic. So this is a schema we made for a review article recently where we had where we are now and where we may be going in the future. And this is now for CD30 positive T-cell lymphomas, we give brentuximab in combination with chemotherapy and have a bias for auto transplant. For CD30 negative, I think standard treatment is now still chemotherapy or more chemotherapy. But maybe we'll move in the future, and maybe not the too distant future, where we might be thinking more subtype specific. Maybe TFH patients will get an epigenetic modifier or a PI3 kinase inhibitor in combination with chemotherapy, as a single agent activity in TFH is quite good for those. There may be different types of T-cell lymphoma based on the biology, where a PI3 kinase or JAK-STAT inhibitors may be optimally combined with chemotherapy. And then some of these other primarily chemo-refractory or almost universally chemo-resistant lymphomas, you might need wholly different approaches that maybe include some things like immunotherapy or non-chemotherapeutic approaches. So I will end there, and happy to take questions.
Thank you very much, Prof. Stephen. And we will move now for few questions. Dr. Ihab.
Don't hear if the question's being asked.
Just a second, doctor. The mic is not working. Just a second.
Okay.
Just fixing the mic.
This one.
Thank you for your talk. I have 3 questions. Question 1, which group of patients are you using SHIOP? Question 2, I saw in your final slide that you advocate autologous transplant in patients, even ALK positive patients, and I thought that autologous transplant might have a role in those who are in PR rather than in CR, and especially the ALK positive might not benefit from transplant. And the final question is, which group of individuals will have T-cell rearrangement, but they won't have a lymphoma? So there is a certain group of patients that we might find T-cell rearrangement, but actually they don't have any lymphomas.
Great questions. So CHOEP, on study, in that study I showed you, it's younger people under 60. I think where we use it off study is younger patients with aggressive lymphomas, patients who were not giving BVCHP to, and patients with HLH, which is a presentation of some patients with T-cell lymphoma. And the CHOEP we can give every 2 weeks. And in patients with HLH, that intensity of etoposide and prednisone, in my experience, seems to help get control of the disease and the HLH better. So we do have a bias for chemo intensity, and we do that. Alex Herrera had a study of BVCHEP, so essentially CHOEP without the vincristine plus BV, that looked promising, though very intensive therapy. So we're part of a study now to expand that experience. So those are for non-ALCL patients with CD30 expression, and that's something we're also looking at. We have a bias for, again, chemo intensity. So we do transplant a lot of patients. I think as you're familiar, the data is unclear. In our experience, based on our internal data, it looks like it might add somewhere between 10 and 20% improvements in progression-free survival. Maybe not universally across the board. Probably our best results are with negative ALCL. But for patients who are chemosensitive, we do have a bias to add it. When we looked a number of years ago for patients without CR or near CR, so really like borderline PR patients, we didn't see a benefit for adding consolidation for chemo-resistant patients, right? In some way, a PR patient is chemo-refractory. So we generally add it for people in CR or near CR. The ALK positive question is very controversial. ALK tend to do well, but when they do poorly, they crash really fast. And ALK positive patients tend to do well, but when they do poorly, they crash really fast. And there's certain factors like IPI3 or higher, small cell variants, some of these other unusual features, maybe MYC expression, that seem to select for a group of patients without who don't do well. So we do selectively offer to those patients in CR with higher risk factors that we think may not be cured. That's controversial, but there is some data that dose intensification, either adding a topside or other ways of dose intensifying, work for those patients. Those are selectively for ALK positive ALCL patients. We do think about consolidation. But again, that our data there is more experiential and anecdotal than any big data sets. I think your last question is a complicated one, right? We see TCR positivity all the time when we're looking at a diagnosis, and we do see clonal reactive processes where patients don't have lymphoma. So very cautious about using TCR clonality alone as the sole reason for lymphoma. If patients have clear cancer, progressive lymph nodes, getting sick, multiple sites of disease, we're more likely to believe it. We do see people that have clones and disease that is not growing or spontaneously regressing. In those cases, often we'll do next-gen sequencing, which we do a lot, and see are there also lymphoma-specific mutations. We do see in patients like with clonal hematopoiesis, sometimes T-cell proliferations that are clonal that may have TET2 or DNMT3A. They don't have a proliferative signal or additional AITL-specific mutations, and some of those patients don't progress. So we watch them closely. I don't know if I'm answering the question. Those patients, I'm not sure whether they have lymphoma that's behaving indolently or they don't really have lymphoma, but I do use a lot of caution when looking at T-cell clonality only. When you're doing PCR-based T-cell clonality, so looking at fragment analysis, there is something called primer bias, where when there's very small numbers of T-cell, you can amplify certain primers more than others and create the appearance of clonality. So that's we sometimes think about when the T-cell tumor content is very low. It might be a lymph node with 5 or 3% T-cells, but then through the amplification, you see a clone. I think that's another area to be cautious. So I don't have like great advice on that, except that if the TCR is the main reason you're calling it lymphoma and the behavior is not that of lymphoma, or there's other inflammatory processes going on, it's good to pause and check with your pathologist and see if you can be more certain before embarking on intensive therapy.
Well, any other questions?
Yes. Thank you, doctor, for your talk. My question is regarding the group of patients who has ALK negative, but they have DUS22 positive. Would you still, would you omit them from the auto transplant consolidation because they consider behaving like ALK positive patients?
Yeah, I think it's controversial. And when you look at different data sets, whether the DUS22 really behave differently, you know, some of the data from Mayo shows their prognosis, overall survival is the same as ALK positive, but then there's data from France where they're different, and some of the good results may be with intensified therapy. So we look at DUS22 as favorable, but not selecting treatment. Like my best sense is that they do better with the same therapy, but they don't necessarily do better with less therapy. And that goes with chemotherapy-based regimens. So we will still give them chemotherapy, we'll still consolidate. We tried to look at this in Echelon-2, and there just wasn't enough data on DUS22 to clearly say that those patients with BVCHP didn't need transplant anymore, or they clearly did better. So I think it's a little muddy. So right now my take is they do better with the same therapy, but we don't give them less therapy. The other thing we've started to look at recently, you know, as we've been treating more patients, which wasn't in the Mayo series, is we've seen a couple of the DUS22 patients have very late relapses, 8 years, 10 years after therapy. And it may be that the late relapsers are more DUS22. We know there's a lot of DUS22 in cutaneous ALCL, which has a different biology. We see chronic late relapses without significant dissemination. So there may be a different biology there that will understand that they do well with chemotherapy, but are more susceptible to late relapses. But those relapses have usually been easily managed. So that's kind of where we are. I think probably more to learn there.
Thank you very much. And we can conclude here. Thank you very much, Prof. Stephen. Hopefully, we will see you soon in Saudi Arabia.
I would love that. Thank you very much.
Thank you very much. Thank you.
So thank you everybody for staying late. Just a reminder, still we have more. We have a satellite symposium at 8 o'clock. So just have some rest and be back at 8. This will be followed by dinner. Very challenging topic. So be tuned for that. Looking to see you all. Thank you.
Okay. So we will wait for them to come until they introduce you, Doctor.
Dr. Joshua is an associate professor of medicine at the Cancer Institute, Mount Sinai, Echelon. I can't pronounce this, Dr. Joshua, School of Medicine in New York. Well, we know he's going to talk about multiple myeloma. This morning, he has given us a very elegant lecture about the use of bispecific molecules in multiple myeloma. Multiple myeloma is a disease that patients we're not able to cure yet. And whatever medications we have, we will have an opportunity for. His talk tonight is going to be focused on targeting nuclear export proteins in multiple myeloma therapy. Dr. Richter, go ahead.
Thank you very much. I appreciate the very kind introduction. And again, it's an absolute honor to be speaking with people at the SSBMT Congress. Quite amazing collection of talks so far. And of course, thank you to Meridien Stemline for sponsoring this. So for this session, I'd like to speak about targeting nuclear export proteins in myeloma and a little bit about how this may fit into the relapsed refractory world of myeloma. So again, at the current moment, we still deal with myeloma in the setting of classes of agents. And given the more recent data, and again, separate from the T-cell redirection therapies like bispecifics and CAR-Ts, which are essentially given as monotherapy at the current time, the standard in relapsed myeloma is triplets and quadruplets of taking one drug from each of a different class. We don't yet really use two drugs within the same class, although those studies are ongoing. And we can see a variety of the classic therapeutic areas like IMiDs, proteasome inhibitors, alkylators, steroids, antibodies, and signs are a very interesting type of therapy. So I think upfront therapy is really kind of set in as mostly quad-based therapy, definitely triplets with regimens like VRD. But now that DARA VRD is becoming both utilized in transplant-eligible and ineligible patients in myeloma, we recognize that patients still tend to progress on lenalidomide going into their second line, either receiving DARA VRD, autologous transplant, lenalidomide maintenance, and then progress, or they progress on daratumumab and lenalidomide. Either way, many patients enter the early relapse setting, either proteasome inhibitor naive or proteasome inhibitor sensitive. As such, one of the main options for backbone of therapy in early relapse is carfilzomib. And as we can see here, there have been a number of studies looking at different combinations and dosing strategies, as well as different partners. And one of the things that carfilzomib has struggled with is, how do you dose the drug? Do you infuse it over the originally approved 2 to 10 minutes or 30 minutes? Is it given once a week or twice a week? Do we give it at doses of 20 per meter squared, 56, 70 per meter squared? It's a little all over the map. For the most part, we give once weekly carfilzomib. It is a far better tolerated regimen for patients, never really going higher than 70 per meter squared. And when combining with an immunomodulatory agent such as pomalidomide or lenalidomide, never go higher than 56, as some early studies have shown that higher dose carfilzomib at 70 per meter squared with immunomodulatory agents has a much higher risk of dysrhythmia. Now, we also recognize that for many people, carfilzomib may not be an optimal strategy. We've learned from the endurance trial that in patients over the age of 70, specifically those with poorly controlled high blood pressure, the cardiotoxicity may be a little unacceptable. As such, at least in the US, pomalidomide-based regimens are the main backbone of our first relapse. And it's been studied all the way back dating to the 003 study, which led to the approval. However, there we saw a median progression-free survival of only 4 months with around a 30% response rate. Now, the two leading combinations where we use pomalidomide would either be dara-pom-dex, based on the Apollo and Aquelius studies, or isatuximab pomalidomide dex based on the Icarius study. Either way, the progression-free survival improves to around 1 year. Now, even though daratumumab has become increasingly utilized in the upfront setting, we recognize in early relapse that many patients may either be DARA naive or DARA sensitive, as many patients are maintained with lenalidomide alone as maintenance after induction, either post-autograft or post-triplet or quadruplet induction without autograft. As such, daratumumab-based regimens represent the mainstay of early relapse myeloma management, and we see here a variety of doublets, triplets, and even quadruplets with these different therapies, with actually the most common regimen in the United States being daratumumab, pomalidomide, dex. However, we've started to recognize that the combination of a CD38 and Kyprolis, namely DKD or ISA-KD, has shown some of the highest and most durable responses in early relapse, some of them even rivaling CAR T data when we look at the both the IKEMA study and the CANDOR study, with IKEMA showing response rates, median progression-free survival of 30 to 40 months. But ultimately, as we move, and I mentioned earlier, we move all of these drugs to first line and first relapse, the novel therapies, we need to go beyond this when we go into subsequent lines of therapy. We need to look at additional agents. So again, we talk about the BCMA and non-BCMA bispecific antibodies, and we recognize that these drugs are highly efficacious, although right now the current approval in the United States for the bispecific antibodies is fourth line plus. So while these are extremely efficacious, I think there's a gap of how to optimally manage patient with or without T-cell redirection in between first relapse and fourth relapse. We recognize that moving up CAR T therapy to early relapse may help to overcome some of this. And there were two large studies performed, both the KarMMa-3 and CARTITUDE-4 studies. KarMMa-3 and CARTITUDE-4 both compared CAR T against standard of care, and similar in concept, but in execution far different, and ultimately led to different outcomes. So KarMMa-3 looked at patients with 2 to 4 prior lines of therapy and compared ide-cel with standard of care regimens. And there were a number of standard of care, including Darapom-Dex, VPD, KD, and ultimately saw an improvement in an overall response rate from 42 to 71%, an improvement in progression-free survival from around 4 to 14 months. It's important to note that the KarMMa-3 study allowed for crossover. So patients that were randomized to the standard of care arm were allowed to cross over to receive ide-cel in the relapse, and this definitely impaired some of the long-term data. This is in stark contrast to the CARTITUDE-4 study, which compared cilta-cel versus standard of care in 1 to 3, not 2 to 4 prior lines. And here the control arms were either Pom-Vel-Dex or Darapom-Dex, no crossover allowed. And we saw an overall response rate improve from around 67 to 85%, and an extremely impressive PFS curve. We like to say the PFS curves are so different, you could drive a truck through it. And again, median PFS not yet reached, but we can see it looks like it's going to be a very impressive number. But ultimately, we need to consider a variety of non-CAR T-cell therapies or non-T-cell redirection therapies, because CAR T is really best suited for younger and fitter patients, much in the same way autologous transplant is. And we recognize that in many countries, the average age of myeloma is at or over the age of 70, which may preclude more intensive therapy. Therefore, we need to think about additional mechanisms of action outside of T-cell redirection and outside of IMiDs, PIs, and monoclonal antibodies. And that's optimally where the selective inhibitors of nuclear export fit in, namely selinexor. This is a first-in-class orally bioavailable sign. And although it's been studied in a number of places, in the US, it currently has 3 approvals as selinexor and dexamethasone in late-line therapy, selinexor, Velcade, dex in early-line therapy based on the Boston study I'll discuss in a moment. And additionally, it has an approval in diffuse large B-cell lymphoma. But ultimately, where we've seen some of the most impressive data from this is from the Boston study. These were patients with 1 to 3 prior lines of therapy who were randomized between bortezomib, dexamethasone, and bortezomib, selinexor, dexamethasone. One of the key things this study brought to light is the fact that in myeloma, we approve a drug, and by the time we are really comfortable using it, the utilization looks nothing like that original dosing. Meaning, we look back to bortezomib, which is approved at intravenous twice weekly. Now we give subcutaneous once weekly. The Dara used to be IV, now it's sub-Q. Carfilzomib used to be twice a week, now once a week. Same thing here with selinexor. The original STORM study approved the drug at 80 milligrams twice a week. it is a very toxic way to give the drug. But now when we combine it, we recognize that once-weekly dosing, when given in partnership with additional myeloma therapies, is far more efficacious and far better tolerated. And we typically give doses ranging between 60 and 100 milligrams based off of the myelotoxicity of the partner drug. Here in Boston, because bortezomib has very little in the way of myelotoxicity, the MTD was 100 milligrams of selinexor once a week. Now, it met the primary endpoint of median progression-free survival and improved from approximately 9.5 to 14 months. But to me, what is the most important thing is, how do we find the optimal patient in our clinic that will benefit from this approach? Because just like with CAR T, we know some patients do amazing and some do not. The question is, where is selinexor most efficacious? And there's a few areas that are really quite impressive. One is selinexor Veldex in one prior line of therapy, as we see here, median PFS of 21 months, and in bortezomib naive patients, almost 30 months. Remembering that across the last 15 years, the majority of induction therapy anywhere in the world, transplant eligible or ineligible, has contained bortezomib. VMP, VTD, VRD, DARA-VRD, VCD, the list goes on and on. But ever since the publication of the MAIA study, giving daratumumab lendex to transplant ineligible patients, we've seen a rise of patients entering early relapse, proteasome inhibitor and bortezomib naive, and this may be a more optimal approach for those patients. The other concept is we have no true insight on how to sequence therapies. Most of our sequencing in clinical practice is based off of chronologic date of approval. We give Revlimid before Pomalyst because it was approved earlier. We give Velcade before carfilzomib because it was approved earlier. We give Tec before Tau because it was approved earlier, not necessarily because it's the more optimal way to do it. However, there's been some phenomenal work done at Moffitt Cancer Center in the US, looking at the relationships of genomic predictors of resistance and sensitivity between CD38 monoclonal antibodies and signs. And it turns out there's a yin-yang relationship, such that patients who are showing genomic signatures of relapse, genomic predictors of resistance to CD38 will be sensitive to sign and vice versa. Ultimately, we then subsetted out patients treated in selinexor trials, both in the STOMP trial with selinexor Pomdex and selinexor Kyprolidex, and in the XPORT-28 trial with a NextVD regimen, and looked at patients who had immediate prior DARA or did not have immediate prior DARA. And we can see stark differences in the progression-free survival curves, noting that patients progressing directly after daratumumab seem to have an inherent sensitivity to selinexor and sign-based therapy, and this may give us some insight as to how to sequence drugs, giving selinexor directly after a daratumumab-containing regimen. Now, when we look at the waterfall plot across studies looking at XVD, XPD, and XKD of patients who had just an immediate prior CD38 therapy, we can see not only is the waterfall plot extremely impressive, but the asterisks here denote patients with high-risk cytogenetic disease like 414, 1416, 17p. So this may be a very potent approach, especially for patients with functional high risk. And that just literally means shorter response time. So for example, in the MAIA study, the median progression-free survival with DRD up front was over 60 months. But if I put a patient on it and they relapse in 1 to 2 years, regardless of their cytogenetic profile, they are functionally high risk, and giving them another IMiD is probably not the right thing to do. And they're CD38 refractory, my next regimen would be XVD. So here we see the updated data that was presented at EHA by Meridien Mateos from Salamanca. And we look at patients in one prior line within the Boston study, remembering that Boston included patients with 1 to 3 prior lines of therapy. Here we see an improvement in overall response rate from around 2/3 to over 80%, and an almost doubling of the median progression-free survival from 10.7 to 21 months. But the other thing to remember is that selinexor has a lot of similarities with the IMiDs, in that is extremely combinable, because everyone's journey within the myeloma framework is unique. And it's important to know that we can combine this with essentially all of the other drugs at our disposal. And a lot of this data comes out of the STOMP protocol. The STOMP protocol was an umbrella protocol that allowed patients to be treated with a variety of different selinexor-based combinations in triplets as well as quadruplets. remembering that they all are dosing selinexor between 60 and 100 milligrams weekly, depending upon the partner agent's myelotoxicity. So let's go through some of that data. Here we see the STOMP regimen with XDD, selinexor daratumumab dex. And here the MTD was 100 milligrams weekly, waterfall plot very impressive, overall response rate around 70%. The question is, where does this regimen come in? For patients that I have that were progressing on lenalidomide, that I gave KPD, carfilzomib pomalidomide dex, as a second-line therapy. XDD is a great third-line therapy to recoup patients who are progressing on the KPD regimen. Now, what has become increasingly common in many places is recognition that CD38 combinations are better with carfilzomib than they are with pomalidomide. Hence, there's been a steep rise in utilization of DARA-KD and ISA-KD in early relapse. When you have a patient progressing on one of those therapies, one of our go-to regimens is the PD regimen, selinexor pomalidomide dex. Because POM does have more myelotoxicity, the recommended dose for selinexor is 60 milligrams once a week. And we can see here an overall response rate of around 60% at the RP2D with a clinical benefit rate of 75%. The other place where this is extremely useful, is in patients with leptomeningeal myeloma. This has become our go-to for patients with CNS involvement of their disease because selinexor, pomalidomide, and dexamethasone all cross the blood-brain barrier. So this is both an all-oral, which is very good for patients, very effective, especially in a post-CD38, post-carfilzomib-based setting, but it also penetrates the blood-brain barrier and is a great regimen for patients with CNS involvement with multiple myeloma. Now, perhaps the most utilized combination of selinexor in the US, at least, is the combination of carfilzomib selinexor dex. And this is from data recently published by Gary Schiller and Christina Gasparetto. Now, we recognize here the overall response rate of around 78%, clinical benefit rate of over 81%. The dosing here would be selinexor 80 milligrams once a week. And again, given the fact that the most common utilized regimen in second line in the US is Dara-Pom dex, we follow it with XKD here. And I've found anecdotally that this regimen is very potent for patients with bulky extramedullary disease and large plasmacytomas. I find it to be a very potent combination. Now, the toxicity management of selinexor is a bit different from other therapies. Most of the therapies that we think about, at least the novel agents like bortezomib and lenalidomide, we think about delayed toxicity. You start off on 25 milligrams of lenalidomide, 4 to 6 cycles in, the bone marrow is having some fatigue, you have to drop to 15 milligrams. Bortezomib, we start out okay, and a while into it, the patient develops peripheral sensory neuropathy, we have to adjust the dose. This is in contrast to selinexor, where the toxicity is a proximal event. And if you're aggressive about prophylaxis over the first 2 or 3 cycles, the toxicity tends to dwindle with subsequent cycles, and you can back off on prophylaxis. So our approach has been the combination of 3 antiemetics, one of them being dexamethasone, and then adding 2 additional, either the combination of ondansetron, a 5-HT3 inhibitor with an NK antagonist like aprepitant, and if we're unable to get aprepitant, we give olanzapine. My personal preference is to give 2.5 to 5 milligrams of olanzapine the day before, the day of, and the day after selinexor dosing. That being said, if you have access to Akinzio, which is the combination pill of palonastratron and nitipatant, that plus dexamethasone is a great prophylactic approach with selinexor. For us, one of the things that we have really utilized is rolapitant. Rolapitant has the fewest drug-drug interactions with selinexor and is dosed at 180 milligrams every other week. Now, our nurse practitioners recognized these patterns early on, and we decided to take a very aggressive tack at prophylaxis for these toxicities in the original STORM study. And we actually subset it out later on, all the patients treated in STORM with those treated at our site. The overall response rate for the STORM population was 26%. It was over 53% at Mount Sinai, and this translated into improved progression-free survival as well as overall survival. For us, there are a couple of tips, mostly the antiemetic prophylaxis early on. I usually give Zofran, rolapitant, and dexamethasone for the first 3 cycles. Once that's tolerated and we get through that, starting with either cycle 3 or cycle 4, I remove the relapitant and or the Zofran, and then we can taper down per patient. It's known that the XPO1 inhibitors do have a predilection for the TPO pathways. When we used to give selinexor twice weekly, we were not able to overcome thrombocytopenia with TPO agonists like ramiplostim or trombopag. However, with once weekly dosing, early line relapse, it's not much of an issue at all. Rarely have to use TPO mimetics. However, if you use if you use selinexor in late line therapy where there's already marrow fatigue and TPO mimetics are needed, the recommendation is quick up titration. So although the package insert for ramiplostim is to start at 1 mic per kg and then each week going up 1 to 2 to 3 to 4, we recommend rapid titration up to 5 or 10 mics per kg because that's needed to overcome the TPO blockade. So in general, aggressive prophylaxis is very necessary. Apart from that, standard approaches with supportive care, good diet, good rest. And for us, one of the big issues is that we used a lot of aprepitant, fosaprepitant, nutipitant in our patients. And because of this, over 96% of our patients received aprepitant as opposed to under 19% with the rest of the cohort. And that's one of the main reasons why our patients did better is that without this aggressive prophylaxis, patients did not want to proceed on treatment. However, as long as we provided able to maintain very well and tolerate the drug very well and able to stay on much longer. And as we've seen from the original trials with bortezomib and lenalidomide, the longer you stay on, you tend to deepen your response, which is one of the reasons why we had deeper and therefore more durable responses. The other thing to remember is that in myeloma, there are 2 types of drugs. There are drugs that we dose adjust with toxicity and drugs that we don't. Lenalidomide is a drug that we absolutely dose adjust with toxicity. We have patients on 15, they become cytopenic. We're unable to maintain their counts, we drop them to 15. This is in opposition to carfilzomib, where we dose a patient at 56 per meter squared. If they get a little short of breath, we stop the drug. And I would say treat selinexor like lenalidomide, not like carfilzomib. So if you start at 100 milligrams and you have toxicity, hold, drop to 80. If you're at 80, hold, drop to 60. And when we looked at patients who underwent dose adjustment, we saw that if you did versus did not have dose adjustment, we saw an improvement in overall response rate from 66 to over 81%, which translated into improvement in progression-free survival in the Boston study of just over 9 to over 16 and a half months. Now, ultimately, we still need to put this in the context of the very exciting new T-cell redirection therapies, both bispecific antibodies and CAR Ts, because they are becoming part and parcel of how we manage relapse myeloma. The question is, if, depending upon the pattern of relapse, depending upon the approval in any given country, you may have to consider what to do either before your BCMA therapy or after. As far as after, we have data dating all the way back to the original STORM study, which had several patients who had progressed on BCMA-targeted CAR T who went on to receive selinexor, and all of which responded. And across a number of subsequent studies, we looked at patients who have progressed after BCMA CAR T, bispecific antibody, or antibody-drug conjugate. And one of the benefits is that because selinexor does not utilize T cells in order to fight, even in patients who are T-cell lymphopenic, they can still respond very well to selinexor and may be a great sandwich therapy in between T-cell redirection therapies to allow the T cells to recover to get maximum outcome of your bispecifics. Now, what about prior to? And one of the things we've begun to understand and talk a lot about is T-cell fitness, meaning as we are leading up to T-cell redirection, we want to avoid certain drugs because we know that they negatively impact T-cell function. Mostly we avoid high-dose alkylators like cyclophosphamide, bendamustine, and melphalan. But the question is, what is the impact on selinexor as a therapy leading up to T-cell redirection? And one of the things is not only do we see that the T-cell activity was not impaired, they continue to have excellent interferon gamma and granzyme B response, but actually there was some evidence of improvement in T-cell function compared with the control. Now, this has led to an IIT which was started looking to use selinexor as a priming effect prior to T-cell redirection therapy like CAR T. However, this is a little bit too soon for prime time. We're unclear if this data that's seen ex vivo will translate into real-world improvement in CAR T-cell therapy. So in summary, SVD represents a highly effective option in the relapsed refractory world of myeloma. For patients who had prior Velcade-based therapy, the question is, can we use it again? Either patients who got VRD or Dara-VRD induction, transplant and maintenance, or Dara-Len maintenance, or for patients who received DV in the relapse based on the Castor study. We know in Castor, they stopped the bortezomib after 6 or 7 cycles and continued on single-agent Dara alone, meaning that the majority of people in these settings are still sensitive to bortezomib. We go back more than a decade, and the Retrieve trial looked at patients who were treated upfront with bortezomib and stopped, not because of progression or toxicity, but patients who were transplant. And it showed that the deeper remission you achieved upfront correlated to the durability of remission when you reused bortezomib in a later line of therapy. The other thing is that now with increasing rise of DRD as an induction strategy, we have patients who are progressing now in the second line who are proteasome inhibitor naive, but lenalidomide and CD38 refractory. It's a great way to give XVD to provide 2 new mechanisms of action, specifically in patients with functional high risk. So if you give DRD to a patient up front and they underperform 2 or 3 years, you don't want to just go from Rev to POM. If they didn't do well with Rev, they're not going to do well with POM. They're already refractory to daratumumab. XVD has shown great data from the subset analysis of Boston, and that's one of our go-tos for that patient subset. And with that, I thank you very much for inviting me to speak again at this wonderful Congress, and I'm happy to take any questions.
Well, thank you very much, Joshua, for this elegant presentation as usual. It's time to have probably a few questions. We have a few minutes, if we can. Any questions from the audience? Joshua, I mean, you've mentioned an example of carfilzomib where the doses have been all over the place, as you mentioned, and with time we have learned that. And I mean, the way I do it, there was the 27, the 36, and then the 56, and then the 70, once weekly, twice weekly, whatever. I mean, the way I do it, I mean, is that we start with a 20 milligram the first dose, and then subsequently I go slow, especially if there are comorbidities, and see how much they can tolerate. In combination with an EMED, we usually go up to 56 instead of 70. Now, in selinexor, more or less, we have a similar story from 80 twice weekly to 100 once weekly, and then down to 60. And in addition to the measures of mitigating the side effects of selinexor that you have mentioned, would a similar strategy of escalation rather than de-escalation after development of side effects be, the way to go? Or have you ever done that? Or what do you suggest?
So I think this is a really key topic and something that we don't discuss enough because it has huge clinical implications. And it's what is the appropriate strategy? Start high and back off for toxicity, or start low and escalate? And for me, I've had a lot better experience starting high and going low. The rationale being, and again, this may not be the perfect example, but I know that in many lymphoma protocols, they talk about dose-adjusted epoch, where you give a certain dose, and if you don't have a full nadir, you bring it up. And I know that's what it says in the literature, but I see a lot of lymphoma colleagues, they get patients through the first cycle, they tolerate it, they don't have toxicity, and they're responding, and nobody wants to up-titrate. So although I think that this approach is extremely appropriate for older, frailer patients, where you don't want to blow them out of the water, but you want to see, are they going to do okay? And then maybe bring them to 60 to 80. For the majority of patients that are robust, I do start higher, but I absolutely agree with you. For older, frailer patients, I often start at 60. And if they do well with the first cycle, I do go up to 80. But, again, difficult. You see someone on cycle 2, day 1, they're already in a PR. I don't know that there's an impetus to put the dose up higher.
Thank you. Any questions? The other thing, I mean, this is going to be very difficult. I mean, you have mentioned this. We have too many options now in the relapsed refractory setting, but despite these too many options, all of these options are trying to make their way into first line. And, you know, now we have, I mean, the standard is more or less a quadruplet in transplant eligible. And it's becoming quadruplet also in non-transplant eligible after the Cepheus and the and the Emrose that we have seen. I mean, it's not yet standard, but it's probably coming. So upon relapse, we're going to have not really many options apart from the bispecifics, which are also trying to make their way to the first line. So would you, I mean, sequence selinexor before or after bispecific molecules? You have mentioned in your last few slides that the use of selinexor after bispecific molecules is still effective. What do you think?
So, you know, this is another great topic because when we date back to the days that Bart Barologi was giving total therapy, and the entire world looked and saw this was crazy, giving all these drugs at once. And now, exactly as you described, now we're giving all the drugs up front. So he was way ahead of his time in describing this. You're right. As we get in, you know, if we shove everything up front, where does that leave us for the relapse? So I think one thing is, you know, myeloma is still well behind the lymphoma world that has identified the true subtypes and how they need to be treated. There is no lymphoma doctor who would treat CLL and diffuse large B cell the same way, but that's what we do in myeloma because we don't know if this is going to be a CLL-like or DLBCL-like myeloma. So there needs to be better strategies of combining all of these therapies up front, but understanding who needs that in an effort to cure and who we may be able to space it out. But specifically for selinexor and the bispecifics, one of the things that we know is that when you sequence T-cell redirection, when you give CAR T before bispecific, it tends to work better than bispecific before CAR T, because one of the things that we've seen is that the time in between attacking BCMA matters for your next response, partially because of antigen presentation, partially because of T-cell exhaustion. So one of the thoughts is utilizing some of the oral small molecules like selinexor, and in the future, the CELMAs like mezigdomide, to be the meat of the sandwich, where you give a drug like elranatamab or teclistamab, and at a time of relapse, prior to giving talquetamab, give another non-T-cell redirecting therapy in the middle to allow for recovery of T-cell function to optimize the subsequent response of talquetamab or any other bispecific.
Well, thank you very much. I guess with this, we conclude the session. Thank you very much for your talk and the discussion. Thank you. So now it's time to move on to the second satellite symposium, which is sponsored by Johnson & Johnson Innovative Medicine. And Dr. Imran Taylor is our speaker for this satellite symposium. Dr. Imran is well known to everybody. He's a consultant hematologist at the Adult Hematology and Bone Marrow Transplant Department, King Fahd Medical City, Riyadh. And his talk is going to be From Evidence to Practice, the role of daratumumab in shaping current and future patient management. Dr. Imran, go ahead.
Thank you, Dr. Ayman, for the kind introduction. Bismillah ar-Rahman ar-Rahim. First of all, I would like to congratulate SSBMT for a great conference. I'd like to thank the organizers and Johnson & Johnson for the invitation. So my topic is the role of daratumumab in shaping current and future management. Hopefully I'll finish in less than 30 minutes. These are my disclosures. Okay. So we have come a long way in the treatment of newly diagnosed multiple myeloma. For transplant ineligible, we used to treat initially with melphalan, prednisolone, then we got MPT, then RD, VRD, VMP, and VRD, more recently quadruplets, DARA VMP and DARA VRD or ISA VRD. In transplant eligible patients, we used to give, if you remember, 2 decades ago, VAD-like regimens, and then we had thalidomide, then VRD, and now we're getting quadruplets, DARA VRD. Before I dwell into the role of daratumumab in various settings, I just want to highlight one aspect that is MRD and its impact on outcomes in the patients with multiple myeloma. This is a meta-analysis by Nikhil Munshi and team looking at more than 8,000 patients, 93 publications on the outcomes with achieving deeper MRDs. You can see here, if you achieve deeper MRD, irrespective of the case, transplant eligible, ineligible, or relapsed refractory, your PFS and overall survival is better. Irrespective of how deep you achieve the MRD negativity, again, the PFS and overall survival in all these group of patients are significantly better with a hazard ratio ranging from 0.38 to 0.5. And you can see the 2 curves here separating so beautifully in transplant eligible patients who are MRD negative. And another question is achieving MRD negative once, is it enough, or do we need to have sustained MRD negativity? This trial looked at this. You can see the blue line, the PFS in patients who achieved persistent MRD negativity, the red line who are MRD positive. You have another green line in between. The red line in the lower graph is those who achieved MRD negativity but lost it. So it is very important, these patients, to achieve deeper and persistent MRD negativity if you want to have better results. And this is from the Cassiopeia trial. Again, those who achieved MRD negativity at the end of transplant, nearly at 12 months, you can see their curve. The PFS is almost at 90% or more. Again, this master trial looked at MRD at various time points with a view to stop treatment if MRD negative on 2 occasions. Again, you could see those who achieve sustained MRD negativity, they have their overall PFS and PFS at 18 months is significantly longer. So that means if we just achieve MRD once, that is probably not enough. And important thing is our first shot. Just now, Dr. Richter discussed, Dr. Ayman raised about using quadruplet regimens. Are we exhausting our armamentarium at the beginning itself? It's important to note that our first shot is going to be the best shot. If you look at this study, there is attrition in the number of patients with each line of therapy. In transplant ineligible, there are 50% loss of patients. They're either dying or are not able to get any further treatment. Whereas transplant ineligible, there is lesser attrition, but with each line of therapy, there is significant attrition. So we got to have our best shot, our first shot as a best shot, and especially it probably matters more here in Saudi Arabia and low middle income countries where access to neo drugs and clinical trials is not like in the West. So let me briefly go through the recent approaches with daratumumab in mind in transplant eligible patients. So CD38 is a very critical target in myeloma cells because it is expressed highly by myeloma cells, and it acts as a receptor and adhesion molecule, and it's also expressed by other immune cells, making it a very attractive target in these patients. So coming to the Cassiopeia study, the large randomized phase 3 trial in newly diagnosed multiple myeloma patients who are transplant eligible, compared DARA VTD versus VTD, and consolidation. Maintenance was only DARA monotherapy versus observation, because lenalidomide was not approved at that time in 2015 when this trial started in Europe. And you can see very good deep responses. 65% VGPR are better compared to 56% in the VTD arm. And even in the MRD at 10 power minus 5 by flow, 64% versus 44%. And you can see the benefit across all groups, including ISS3 and high-risk cytogenetics. Again, we saw this graph with persistent MRD negativity. Your PFS is close to over 90%. So this is the updated PFS. Median is 83 months at a median follow-up of 80 months from the first randomization, which is 2.5 years longer than in the DARA VTD compared to the VTD, 7 years versus 4.5 years. So really, we have made a huge progress in multiple myeloma in the last 2 decades. And again, you can see updated overall survival. It's significantly, the hazard ratio 0.55. So you increase the risk, decrease the risk of death or progression by 45% versus VTD. So this is the DARA VRD that we more commonly use because we don't use thalidomide in this part of the world. DARA VRD versus RVD is a phase 2 randomized trial. Again, over 200 patients, induction, consolidation, and the maintenance, you have DARA R versus R up to 2 years. After that, they can continue LEN. Again, you can see very high responses. VGPR and more than VGPR around 85 to 90%. If you remember the olden days of VAD, we used to get a CR rate of 10 to 15% with great difficulty. With a lot of toxicity, infusional regimen, things have significantly improved since then. Again, MRD 51% versus 20%, almost nearly double with the addition of daratumumab. Again, at 4 years, the PFS is 87% versus 70%, which is remarkable with a hazard ratio of 0.45. And more recently, we have this phase 3 randomized control trial confirming the results of Griffin study presented in ASH last year. And you can see here at 48 months, 84 versus 67%, the PFS, again, remarkable results. It works in all different subgroups, including high-risk cytogenetics. Again, the overall survival is still immature, but there is a trend favoring DARA VRD. So now coming to ESA VRD GMMG HD7, the part 1 of this trial, ESA RVD versus RVD. Here, the maintenance, they have randomized between ESA R versus R, unlike in Perseus trial. Again, the primary endpoint was MRD. You can see here very high VGPR 77 versus 60%, and MRD rates 50 versus 35%. The first trial with the primary endpoint MRD negativity to achieve this. Again, is it toxic? The quadruplet in Cassiopeia trial during induction, you had no deaths. In Griffin, you had 1% deaths. And in GMG HD7, you had 1.2%, which is not very high. Our supportive care, of course, has definitely improved. Again, this gives us hope that we can use it more confidently. And also over 90% response rates. And again, no significant effect on stem cell collection and more use of Plerixafor. This master trial used DARA with KRD. Again, is a phase 2 trial. What I want to highlight here is achievement of high MRD negative rates, even in ultra high risk patients with 1 or 2 high risk cytogenetics. So here almost 79% MRD negativity rate, even in patients with ultra high risk myeloma. So this is an area of unmet need. So we know if we achieve deeper MRD responses, your outcomes are going to be better. So this is a very attractive option. You can see here, even with 1 high risk cytogenetics, the results are similar with someone with no high risk cytogenetics, although ultra high risk is not doing as well, but still very excellent results at 2 years. Again, this is another trial that looked at DARA KRD with tandem transplant followed by maintenance in high-risk myeloma patients. The 30-month PFS is 80% in this very hard-to-treat group of patients with high-risk cytogenetics with very deep MRD rates close to 70%. So this is a quadruplet regimen. DARA VRD or ESA VRD is approved even by NCC guidelines, and it has pretty much become the standard of care even in Saudi Arabia, wherever DARA is easily available. So what about coming to briefly transplant ineligible patients? So this is a trial that established VRD as a standard of care compared to RD, and you can see the PFS 43 versus 30 months. and overall survival 75 months. In transplant eligible patients, just 15 years ago or 18 years ago, the survival was less than 4 years, 3 years. And this really changed the paradigm in this group of patients. Now, with the newer data, I will show you, and we have done much, we're doing even better. But what is important to note in this trial is those who are over 65 did not do well. Their PFS is still around 30 months, even with VRD. So this was a kind of unmet need, because this trial included both under 65, over 65, with not with an immediate intent to transplant, but they could transplant later. So this Alcyone study that compared VMP with DARA VMP, because this was the one approved in Europe, first quadruplet phase 3 trial. And it showed, you can see clearly the PFS and overall survival in favor of DARA VMP with 30% reduction in the risk of death compared to VMP. The median PFS was 37 months, better than VMP, but still we could do better. And now we got the Maya study, which everyone knows, DRD versus RD in transplant ineligible patients. What is important to note here is nearly 80% of the patients were over the age of 70 years. So these are really, we're talking about older age group, even though the older age and older people in the West, we cannot directly compare to our people. They are more fitter, and around 15% of the patients had high-risk cytogenetics. You can clearly see the median PFS is 61 months compared to 34 months in RD. So really, it has established a benchmark or a standard. So see where we used, the survival was 3 years, just 15 years ago, and now the PFS itself is 61 months. So we have really come a long way in the last 15 years. Again, patients with one high-risk cytogenetics, they do reasonably okay, but not with two high-risk cytogenetics, even though the number of patients enrolled in this study were only 15% who were high-risk cytogenetics. And patients who are less than 70 are doing much better, but 70 to 75 are as well doing reasonably okay compared to RD. And you can see their PFS is still around 60 months. Again, overall survival is trying to show that patients are tolerating, and we can see the effects even in the older subgroup population with this DARA-RD. And it is equally good in most of the subgroups. And we have the 7-year update of the survival. Now it's reaching up to 7.5 years, so almost 80, 90 months. So that's a remarkable achievement in these elderly infirm patients. So coming to the IMROSE trial, ESA VRD versus VRD in transplant-eligible patients. So we're moving from triplet to quadruplets, even in transplant-eligible patients. Again, similar. So basically, you're giving Velcade for up to 9 cycles, 6 months, 24 weeks of therapy. It's not you're continuously giving Velcade. So you're giving for the first around, say, 9 cycles, and then you take off Velcade out of the equation. Again, really the excellent results. 60-month progression-free survival is 63.2. Median PFS is not reached, so I think it is going to beat DARA-RD. But what is important to note here is VRD is also doing very well with a PFS of 54 months. I think it is maybe our supportive care has improved. I think it is still reasonable standard of care in low middle income countries. If they don't have access to DARA, I don't think they should feel bad, or ESA. Again, overall survival, there's a trend towards ESA VRD. Coming to the CEPHEUS study, most recently, it was presented in the International Myeloma Society in Brazil by Saad Usmani. Subcutaneous DARA with VRD like we use here. So here, the difference is it not only transplant ineligible, but transplant deferred patients were also included. And this trial was done during the COVID pandemic also, so we need to keep that in mind. So there were around 15% of the patients high-risk cytogenetics, and you can see high MRD negative rates, 60% versus 40%, and this CR rates 81% versus 60. If I told you 15% CR, which was hard to achieve with VAD, now we are seeing 81% CR, which is really remarkable. And again, you have MRD negativity, deeper MRD responses even at 10 power minus 6, and also at 12 months sustained MRD negativity. And the numbers are almost double. Adding DARA has doubled the numbers. And 54 month PFS is 68% median. We have not reached. I think it's probably going to be 75 months or 80 months. And VRD again doing very well with 52 months. It was effective in all subgroups, and there was a trend. But if you censor for COVID deaths, I think it was even better with DARA VRD. Again, safety-wise, of course, more cytopenia, thrombocytopenia, you would expect with DARA VRD, but we know how to manage, and otherwise there was no other concerns. The benefit trial, ESA RD versus ESA VRD versus ESA RD. Again, here transplant ineligible patients were only included. Again, the primary endpoint was MRD negativity. You can see almost double the rates at 18 months, 53 versus 26%. So deeper responses, significant even at 10 power minus 5 and minus 6. Really very impressive results. The survival data is still not released. I mean the PFS and survival. So we are having newer trials that are looking at adding bispecific antibodies in the frontline, teclistamab and adelantamab. So it will be interesting to see the results. Finally, briefly coming to the maintenance. So this is a meta-analysis that established lenalidomide as the maintenance, giving nearly 2.5 to 3 years improvement in PFS and OS. And again, this study made us use bortezomib in 17p state negative patients, but we generally use dual maintenance with Velcade and lenalidomide in this group of patients. Cassiopeia, as I mentioned, with DARA VTD or VTD DARA, you have maintenance, significant improvement in progression-free survival and overall survival. Although this practice is not very relevant to us because in this trial, lenalidomide was not used. And it's important to remember that the patients who benefit most are standard risk patients. We always think to or focus on high-risk patients. In this Canadian study, the survival with standard risk patient was 13.5 years with len maintenance, and in high risk 7 years. So definitely an area of unmet need. So this is an Origo study that was presented again last month in International Myeloma Society that basically included all the patients after they received induction and transplant. They should not have received daratumumab. Whoever was MRD positive, more than 10 power minus 5, was randomized to DR versus R. So this is a question everybody asks, whether we should give DR or R alone. And they looked at various points. Again, high-risk cytogenetics were almost 23% higher in the DR group compared to R group. Otherwise, they were equally matched. 25% high-risk ISS3. You can see here clearly the addition of DARA to R doubled the MRD negative rates at 12 months. And even if you look at the patients who are achieving CR at any time, 25 versus 61. And so clearly double, close to triple in the primary endpoints. And again, even performing very well in high-risk cytogenetic patients with regards to achieving deeper MRD negative states. And it also increased the conversion rates, MRD conversion rates compared to R alone. You can see 50 versus 18%, nearly tripled. Very impressive results, honestly, and at 12 months and 18 months. Again, this is MRD negative. 10 power minus 6 conversion rates at 12 months was also superior, including the CR rates were higher. Conversions in the DARA-R arm. At PFS at 30 months was 82 versus 66%. So nearly 20 percentage points difference, and really favoring DARA-R. And even if you look, those who achieved MRD negative, if you look at their PFS, almost a straight line, and impressive results here. And there were no new safety concerns. it was reasonably well tolerated because we all have experience using DARA-R in transplant-eligible patients. Usually most patients don't have to stop the treatment. So this is another study that is by SWOG, randomizing between DARA-LEN and LEN. So I think we'll know more about adding DARA to lenalidomide when this study will be presented, phase 3 study, MRD guided. And again, MGHD7, they are randomizing ESA-R versus R. So 3 years follow-up. So this will all be interesting to see the results. Adding CD38 monoclonal antibody, how it's going to improve the outcome. And again, this is another study as well, DARA-R versus R in maintenance setting, also looking at the MRD-based approach. So key learning points. Quadruplets have become pretty much the standard of care in transplant-eligible patients, offering us to achieve deeper MRD responses. And we know that is going to translate into better PFS and overall survival. And Perseus, Griffin definitely have demonstrated that benefit. And for transplant eligible, DARA-RD is still the standard of care, but quadruplets are challenging. And especially, I believe there will be a certain group of patients who are borderline for transplant or no transplant. They could benefit, but I wouldn't be surprised if everyone starts using quadruplets in the near future, given the excellent data. And adding monoclonal CD38 antibodies to lenalidomide further improve the outcomes in transplant-eligible patients. With that, I thank for your patient listening. Thank you.
Well, thank you, Dr. Imran. This is really an extensive talk. I mean, you've covered almost everything in myeloma in these 30 minutes. Any questions? Dr. Imran has a flight to catch, so we have 2 minutes. Well, if there are no questions, I guess we can. I mean, but you have mentioned in your last comment, I mean, whom really do you really think that we can give a quadruplet for in non-transplant eligible patients? I mean,
yeah.
Usually, I mean, as you know, here in Saudi Arabia, it's probably the incidence is at an earlier age, as you see, and most of our patients, in fact, are transplant eligible. And I mean, only transplant ineligible patients are those with really significant comorbidities that we cannot take to transplant. Do you think they will tolerate the quadruplet? I mean, although looking at the results of the trials, it really makes sense to do that. What do you think?
I think sometimes we come across some patients who are a bit borderline. One day you think they're eligible, one day you think they're probably not eligible. And also DRD, I think there is an area of unmet need, especially with high-risk population. And some of our patients I see, they come with plasmacytomas and aggressive presentation. I feel these patients who are a bit fitter probably benefit. And it is because now we have, you know how to use Velcade, triplets, quadruplets, we know those adjustments. Because we have been using maintenance Velcade for a long time for high-risk patients. So at least 6 to 9 months of Velcade in those relatively fit patients, especially with high-risk cytogenetics or aggressive presentation, plasmacytomas, I think there may be a role for such patients.
Do you think the ORIGA study influences practice? Will you give DARA-R for everybody as maintenance?
Yeah. See, if you want to replicate the results of the phase 3 trials, I think you have to follow the trial. Having said that, in the DARA-R arm, you have deeper MRDs, either you take Griffin study or Perseus study and now ORIGA study. I think the other studies will give us better idea and more results. But I think in Saudi Arabia, especially, we have limited access we have access, but not timely access to second line, third line, fourth line CAR-T. So I still believe our best shot will be the first shot. I think at least those patients who do not achieve less than VGPR or less than CR, I think we should closely consider DR. It is for 2 years only. And if we can do MRD, I think MRD, based on the Aureka study, at least for those who are MRD positive, till we get results from other studies, I think it would be a reasonable approach.
Thank you very much. Go and catch your flight. Thank you, Dr. Imran. So with this, we close the second satellite symposium, and we still have one to go. The last satellite symposium sponsored by AstraZeneca, and the speaker is Dr. Ihab Al-Hamidi. Dr. Ihab is well known to everybody, every one of us. He's a consultant in Princess Noura Cancer Center, National Guard Hospital in Jeddah. And his talk is going to be about evolving role of BTK inhibitors in the treatment of mantle cell lymphoma. Dr. Ihab.
Thank you, Dr. Ayman, for the kind introduction, and thank you, Astra, for sponsoring this session. I'll try to be brief. I know everyone is tired and hungry and want to eat their dinner. So there is a disclaimer. I was asked to say that these slides are prepared by myself, and AstraZeneca has nothing to do with them. So the first slide is on the triangle study, which was a very well-designed study, trying to answer 3 questions. Does adding a BTK inhibitor like ibrutinib to chemotherapy improve progression-free survival and overall survival? The second question, is it safe to combine it to chemotherapy? And the third question, do we still need autologous transplant in mantle cell lymphoma? And there are 3 groups or 3 groups of patients who had the standard chemotherapy, which is R-CHOP, R-DHAP, followed by autologous transplant, and then rituximab maintenance. The other group is combining ibrutinib with chemotherapy, and then autologous transplant followed by maintenance with ibrutinib. And the third arm was R-CHOP, R-DHAP, and ibrutinib, and no autologous transplant. So what it has shown is that these are the characteristics of the patients. They are equal between all groups. And what it has shown, failure-free survival is good with the 2 groups with ibrutinib compared to the group that is standard of care. So the standard of care is the green line. And it has shown that the efficacy adding ibrutinib is better than the standard of care that we have currently. The next question to answer by this trial is, does having ibrutinib and autologous transplant produce better failure-free survival? And it is statistically better using ibrutinib with chemotherapy and transplant compared to our standard of care. So you can see the hazard ratio of 0.52. Transplant has been established in mantle cell lymphoma based on 1 trial, and this trial is a very old trial. It was started in 1996, and at that time there was no rituximab. Some of these patients did not receive rituximab. Some of these patients received the transplant. The arm that was compared with transplant was interferon, believe it or not. So they're trying to compare the efficacy of transplant versus interferon. And after 14 years of follow-up, finally overall survival benefit was shown. So you can see that it took a very long time to show that autologous transplant is better than interferon, which is basically placebo. So the role of transplant in mantle cell lymphoma is questionable. And here you see the arm, which is our standard of care, group A, the red line, is not any different from failure-free survival compared to the arm which had ibrutinib and no transplant. So the the place for transplant is being challenged with this trial. Do we really still need to transplant if we add a BTK inhibitor to our standard of care chemotherapy? Overall survival is equal between all groups. And from the third question about the toxicity of this combination, there is no signal of increased toxicity adding this. The only signal from increased toxicity is from transplant, and you can see that the transplant adds a significant toxicity to the combination of treatment. So cause of death, you can see that the cause of death is equal between all arms. There is no significant increased death between all the arms. Then we come to the Selene study, which is they gave the physicians the options of having bendamustine rituximab plus ibrutinib or CHOP plus ibrutinib. And this study was, they were trying to say that progression-free survival is actually better using ibrutinib plus chemo than chemo alone. And this study failed to show that. 90% of the patients actually received bendamustine rituximab, while 10% received CHOP chemotherapy. So that was a negative study. The next study, which was trying to show similar ibrutinib plus bendamustine rituximab, this was a positive study in terms of progression-free survival. It has proven the point that adding ibrutinib to bendamustine rituximab improves progression-free survival. However, it did not improve overall survival, and it had significant toxicities, and that has led AbbVie to withdraw the indication for using ibrutinib in mantle cell lymphoma. The toxicities from this combination, pneumonias were 33% versus 23%, diarrhea was 46% versus 36%, rash was 37% versus 21%, and atrial fibrillation was 13.9% versus 6.5%. So significant toxicities adding ibrutinib to bendamustine rituximab. So we move on to a second generation BTK inhibitor, acalabrutinib, and this is a kinogram showing that acalabrutinib is much more selective than ibrutinib. And the next, you can see that the inhibition of these BTK enzymes is not inhibited by acala versus they are being inhibited by ibrutinib. So this study is very similar to the previous study that we just discussed, bendamustine plus ibrutinib. So this is bendamustine plus acalabrutinib. And what it has shown that in acalabrutinib patients in relapse setting, there is some efficacy using acalabrutinib, and this is the CR rates, the orange lines, that there is significant efficacy of acalabrutinib to no treatment. So progression-free survival is improved in those who had CRs. Median progression-free survival is 22 months. The side effect profile is quite reasonable. Infection, grade 2, 3, 4 infections with 10%. Follow-up is reasonable. Blastoid and pleomorphic variants. The study was looking at the acalabrutinib variants of mantle cell lymphoma. This is a group that does usually has a worse prognosis, and they don't do very well. And the median overall survival was 59 months. The duration of response was 28 months. This is the characteristics of this group, and you can see that it is a heavily pretreated group, but it's a group that you would not expect it to do very well. The overall response rate was, as you can see here, 81% in this group. CR rates almost 40% in this difficult group to treat. This is the duration of response curve. Median duration of response is about a bit more than a year. Progression-free survival, 15.2 months of this blastoid polymorphic variants. And this is the investigator-assessed overall survival curve, which is showing 36.3 months. Zanubrutinib has been also used in relapsed refractory mantle cell lymphoma, although the follow-up is still short, but it also has shown benefit using it in mantle cell lymphoma. At a progression-free survival is at 19.1 months, CR rates about 15%, and PR rate 69%, 84% overall response rates. So it's a reasonable, decent outcome in relapsed refractory mantle cell lymphoma. This is the complete responses. As you can see, the complete responses in red and the stable disease in green, and it's showing a median duration of response of about 18.5 months, progression-free survival of 21.1 months. Pirtobrutinib is a new non-covalent binding medication used in patients who had 2 lines with covalent BTK inhibitors. So those who are resistant to covalent BTK inhibitors in a phase 1, phase 2 study. It has shown efficacy in mantle cell lymphoma patients. It's a dose escalation study, which has shown that it has an efficacy in those who are BTK inhibitor resistant. This is the progression-free survival of about 5.6 months in heavily pretreated patients, and overall survival, a decent overall survival, median overall survival 23.5 months in those who are refractory to BTK inhibitors. And thank you for listening.
Short and sweet. Thank you very much, Dr. Ihab. Any questions to Dr. Ihab? We have a few minutes. So have you started adding ibrutinib upfront?
No, we haven't, but we are discussing it.
We've been discussing since the triangle has been published. Dr. Ayman, did we do that? Still discussing? I guess, I mean, the evidence is so obvious that the addition of ibrutinib or, let's say, BTK inhibitors to frontline therapy is really, I mean, changes PFS, and probably in the future we'll see differences in overall survival.
I think the thing that
so
the
what
company,
do you think, why we are not yet convinced?
I think that when the company withdrew the indication through FDA, it's made people a little bit anxious about that. I think that might be one of the reasons. I think in the US, I think they will find it very difficult to apply the triangle study.
All right. With this, we conclude the day. Thank you very much. Dr. Ahmed, you would like to, any closing remarks? Well, thank you very much for attending and being with us until now. It's time for dinner. It's 9:20. I think dinner is over here, right, Dr. Ahmed? In the same side. Thank you very much.